Wagmare. Today I am presenting a paper, Emotion-Aware AI System for Real-Time Mental Health Monitoring in Indian Workplaces. So, if we see the global statistics of the mental health disorders, as it is mentioned, it is very frequently, it is seen as it is very rising. So rising in the mental health issue in Indian workplaces, specifically stress, anxiety, and the burnouts. So we need to control or try to put out some of the preventive measures for that. If we see the statistics given by the data story, many depression patients, anxiety patients, intellectual and schizophrenia patients are increasing. Again, it is seen in males and females also with certain percentages. And overall percentage has to be identified with the 16%. If we see the age group is also getting affected. The working professionals may be about 25 to 60. In that range also this type of disorders has been identified. So that's why limitation of traditional wellness programs is required. But there are certain corporate companies which are running the wellness program, but there are certain things which we need to may improve. For example, we need to plan reactive measures as compared to the proactive. We need to do the periodical and manual systems. We need to depend on the self-reporting system. So all such parameters are actually contributing where we can take care for the wellness. So here we can identify one of the problem statement, that is lack of real-time proactive mental health tools. In reliance on self-reporting and the reactive HR inventions, they are planning some wellness programs, but how much they are effective, that is one particular question. So why not to include AI in our daily system and identify some of the measures and the preventive measures for the employees. So that's why AIM has been set up for the mental health analysis to develop and evaluate an artificial intelligence framework that proactively identifies emotion-aware AI system for real-time mental health monitoring. So with this target, we have tried to do certain, oh, it is not going on. Oh, sorry. I'm extremely sorry, sir. I was not aware that it is not changing. So this is my mental statistics actually, where age group, male, female, that data has been uploaded over here. So that's why we need to work out with the corresponding problem statement. Problem statement is in the real-time proactive mental health tools. And that's why AIM has been set up for this particular study. Now, if we see the study pattern, we try to work out with the emotion-aware AI system for the well-being of the employees. It has been planned in the IT industry. Study sample set has been taken for the 500 employees. Last from January to March 2025 data that we have taken for the study. And the target was to improve on emotional well-being and reduce the stress level in employees using the AI system. So we try to enhance actually the productivity in the in our corporate system. So it is actually, we see that from the data set, for 6 different type of cases that we have taken care. That is the emotions, sad, happy, anxious, stressed, and calm, and frustrated. So these are the different emotions we try to identify. Looking at the data set, this is the statistics for the emotion labels. So if we observe over here, stressed and frustrated are the most frequent emotion with 260 samples that we can see. Anxious is also 220 samples that we have taken in the data set, and sad, happy, and calmness has been identified with around 245 to 255 indicating relatively balanced data set. So moving further, if we see the statistics, there are 3 different parameters has been taken care. When we collected the data set, at that time physical information, working pattern, the number of hours, the number of meetings conducted by the IT people, project deadlines, and general information about their health awareness. All those parameters has been taken care. So if we see the distributions of the employees, the work hours distribution significance is that there are approximately 45 hours per week work hours has been spent by the IT sector employees, and extreme work hours are there, but they must be little bit rare as it is included the stress and the burnout risk. If we see the second graph, breaks per day distribution, they are taking, and some employees are taking 1 break in a day, some are 2, some 3, some 4. So as per the distribution, break distribution is fairly or evenly divided among the employees. So break frequency can impact the mental fatigue. So they're also one of the risk parameter that we have identified. The third pattern, that is the sleeping pattern of the employee. There are many times project deadlines are there and they may need a little bit of more working hours. So most employees sleep around 6.5 hours approximately. That has been, we have identified over here. So if we see the distribution of employees as per the work meeting count and the health flag distributions. So as seen in the first meeting, the number of meetings people are working and the work they are doing in those meetings, that is completely showing us one graph. If you observe, the graph looks to be normalized, but it is little bit rightly skewed. So right side data has been increasing more. So we can see that most of the employees, they are having 3 to 4 meetings every day, which may be in the online form or physical form, and there lot of time in a day it is going. So high meeting load may correlate with the increased stress and the lower productivity. It is important to monitor the departments and the roles in which they are playing the roles for the meeting. The second graph, that is actually the health flag. If we observe over here, many employees did not report anything whenever they are working in a high stress or anxiety. But some people have certain medical conditions, they may generate the reports also. So based on that, some health flags has been identified. With zero indication, no health issues has been reported by the employee. With one health flag, there are certain issues has been identified from the mental health side. Maybe fatigue, maybe anxiety, maybe stress level. So here we can say that most employees are healthy. However, a small percentage flag are healthy and are important targets for proactive intervention. The imbalance is that using balanced sample method, we can do the modifications over here. So if we observe the burnout risk on day-to-day basis, whatever is the burnout risk, then in that not always linked to the longer working hours. Some employees may vary work hours, manage well, and show no burnout risk. So we can conclude with respect to burnout risk is work hours alone aren't reliable predictors for the burnout. If we talk about the absenteeism, there are the different rates for the absenteeism. So we can conclude that attendance rate is stronger predictor for the absenteeism, which may relate it to health sometimes. We have implemented the AI system which clicks the photo at random times, and whenever you are entering your ID cards at that time. And based on that, it will identify the emotions, current state of a mood of the employee. So we can conclude that it is the absenteeism risk is mainly affected by health flags and the attendance. Burnout risk is not just about the working long hours, but also about the sleep breaks and the meeting loads. Work hours alone can't predict the burnout. Other factors like sleep and meetings also matters over there. Attendance is the strongest predicator of absenteeism. Lower attendance means higher amount of risk. And both burnout and absenteeism are influenced by the several factors, not just work hours. So that may lead to the stress and the anxiety in the working employees. So some recommendations has been given with the AI systems. That is AI-based early warning system we can establish in the companies so that we can identify the mental health little bit earlier. Deliver personalized interventions based on individual risk profiles, regularly analyze the dashboards of the employees, and integrate the preventive analytics to HR decision making and wellness strategies so that we can take some measures for the employees. And we can invest in long-term wellness initiatives like mindfulness trainings and fitness programs and resilience of the workshops. So these are some of the references that I have used in my presentation. So thank you so much.
Thank you. So my first question is, you have used an AI system, right?
Yes, ma'am.
You used it to assess the emotion of the employee.
Yes.
How sensitive and specific is this tool?
Ma'am, actually we have implemented it with the help of machine learning and deep learning models, where we have inputted the training data set of the employee, all the features that we have taken, that has been contributed an identification of a risk parameter for the stress level, anxiety level, and the workload level. So based on that, this parameter, we are identifying the emotions. We have included one emotional component also. We have two systems to identify that. One is sentiment analysis by taking the text data, and the second one is the face structure. If you are happy, you are smiling, you are laughing, those pictures always correlated to the emotion cycle to the happiness. If you are sad, you don't want to give any response to that. Even our AI system generally asks, hi, how are you? How was your day? So in that case also it was hectic. So all these words are actually contributing to the identification of the emotions of the employee.
Okay. My second question is, would this data be kept anonymous, or is it shared to the higher up? So would there be any stigma in the workplace because of this?
Ma'am, actually, we can implement the system based on this in the other corporate levels also, or other companies also. But data, when we are talking about data, currently this data is related to this company. The workload of this company and the other company may differ. So based on that, we can define the training data, and we can improve on that system, and we can implement.
I mean, your AI and deep systems, you have you looked at the emotions and other things when the person entered into the premises. Am I correct?
Yes.
Do
So
you
some voice systems is also there. Two systems I have
understood?
mentioned. Yes.
So, do you think it will remain the same throughout the day?
No, it will catch the data and it will store in that employee's
It's going to
account.
catch the data when the person is entering into your establishment.
Yes, it
Do
is
you
a session actually, sir.
agreed? Do you think the person will remain the same throughout the day? Can his emotions and depression or anxiety or mental
Currently, in a
change?
day, 2 times we are taking the data. We can implement for every time whenever you are scanning your barcode for entering any of the door. We can take it multiple times also.
Thank you, ma'am.
Yes, sir. Thank you, sir. Thank you, ma'am.
Thank you. Dr. Vishnu Priya is there? Sorry. No. Dr. Kadambari? No. Okay. So we are completing over here our paper presentation. Total 3 today. And at sharp 9 a.m. we will start with presentation, scientific sessions. First will be Dr. Bobby Joseph at 9 a.m. And that will be online session.
Thank you, judges, for giving your time and support.
can you hear me?
I request all paper presentator people, doctors to come on the stage to have memento from Gujcon committee. And I request both the judges to give memento to all the presentators. Dr. Mukesh Kumar, Dr. Prakash and ma'am, please. I request Dr. Naveen Ramesh sir. Sir, please come for having memento from the committee. Ma'am, उनको तब दे देंगे, अभी आप ले लीजिए. Thank you for giving your valuable time, sir, and just have a token of memento from Gujcon committee. Surat. Thank you, sir. Thank you so much.
Good morning, friends. Today is the second day of Gujcon 2025. Now we are starting scientific session. So those who are here and there roaming, please come to the main hall, Mirapal. There will be an interesting session of Dr. Bobby Joseph. Its session will be the online and Dr. Marilyn Joseph. For that, I request our chairperson and moderator, Dr. Saxena sir and Dr. Bhavesh. Please come on the dais. It will be online, so he will be near the camera.
Hello. Good morning, everyone. And today we have this session on occupational health services in health settings. We welcome you to this session, and this first session is from Dr. Bobby Joseph. He is a very eminent speaker. You all know Dr. Bobby Joseph. Just in introduction, Dr. Bobby Joseph is MD PSM and he did DNB He's a current editor of IJOEM, and he's a professor, vice dean, St. John Medical College Hospital, Bangalore, and he has more than 30 years of experience in this field. So let us hear from Dr. Bobby Joseph. Along with me, Dr. Saxena, the chairperson. So we welcome you all, and let us have the session from Dr. Bobby Joseph. Over to you, sir.
Good morning. Can you hear me clearly?
Yes, sir. You are audible.
Thank you. Thank you, everybody. And first of all, thanks to the organizing committee of Gujcon 2025 for this honor of letting me to speak, in fact, online and instead of being there in person. Unfortunately, I wasn't able to travel, but I'm sure I can see the pictures that this has been a great conference. So thank you very much, and thank you for setting high standards where conferences are concerned. So without much ado, let me start with my presentation. I will be talking about occupational health services and health settings, basically focusing on some of our experiences here in St. John's. And let me start by saying that I have no conflict of interest to declare, except that most of the work which I'm presenting here has been done by our own department in St. John's Medical College Hospital. What I'm going to do is to give you a brief problem statement from my point of view. It's not a problem statement in its entirety. And I will talk about occupational health services and health settings and basically talk about our experiences here in St. John's, the challenges that we are facing and the way forward, and we'll conclude with a couple of comments. So with regards to the problem statement, 54% of healthcare workers in low and middle income countries have latent tuberculosis. That's something which all of us know. 44 to 83% of nurses in Africa have chronic lower back pain. 63% of healthcare workers experienced any form of violence at the workplace, and we know that that's quite a lot in India as well. And during COVID-19, the pandemic, 23% of healthcare workers had depression and anxiety. The WHO estimates a projected shortfall of 11 million healthcare workers by 2030. So I've purposely drawn all these studies from different parts of the country, just parts of the world, just to tell you that this is not a problem which is particular to our own country here in India, but something which we are going to be facing all over the world over a period of time. Unsafe working conditions resulting in occupational illnesses, injuries, and absenteeism constitute a financial loss of about 2% of health spending, and this is from the NHS in Britain about almost 8 years back, a study which came from Britain. And my understanding is that this financial loss has been increasing over a period of time. And only about 26 out of the 195 member states of the WHO have in place a policy or programs for managing occupational health and safety of health workers. So it is something which is a dire need. We do understand that healthcare workers all over the world do face problems. It's not something which we are facing in our country alone, but something which is common all over the world. The domains of occupational risk in the world over is, first of all, the organization structure and policy with regards to health and health of the healthcare workers. We do know that there are ergonomic problems. We know that there are safety measures, including protection of doctors at their work sites. The resources are limited, even in a country like India. We do know that the resources are limited. Human resources themselves, as you will probably know from various parts of the country, we do have a shortage of human resources, especially in the public health system. Workloads, as a result, are quite heavy for the people who continue to work in the system. Work shifts become a problem because that's a peculiar nature of the work which we do in the healthcare setting. Night shifts and split shifts, these are all issues which healthcare workers can face. The environment and hygiene, especially in some places in the country, can be problematic. There are interruptions in work because of various issues. Communications with patients becomes a problem, and many of the health workers are not necessarily well trained in handling all these problems, starting from ergonomics to talking to people at workplaces. All these are definitely issues which people do face. So the risks in the healthcare sector broadly can be classified into 3 different categories, and I will talk about a couple of more a little later. In the physical health, we talk about physical factors. We all know that these are common not only in the healthcare industry, but in other industries as well. Chemical factors and biological factors are also a problem. I'm sure all of us being in the healthcare setting can understand each and every one of these. Mental health is a major issue. Stress and burnout, as I will show you in some of the statistics that we have a little later on, that this is a major problem as well. And as a result, job satisfaction of healthcare workers is diminishing over a period of time. Peculiar to the workplace that we are working in, we know that infections can be common. We are exposed to infections much more than the others. Harassment and violence, I can guarantee you that all of us have at some point of time suffered some degree of harassment or violence from the patients. Accidents are quite common in the sector that we work in, and the environment itself that we work in can be a problem. Added to this are individual behavioral risks which we have. Many healthcare workers, doctors included, have poor diet and eating practices. There's a lack of physical activities due to the time that we have on hands. We don't have enough time to do physical activities. Smoking and alcohol can be a problem as well. Sickness presenteeism, because we consider ourselves saviors of the world, sickness presenteeism can be a problem. And poor health-seeking behavior. We think that we are doctors, we are nurses, and therefore we tend not to seek health services when we actually need them. So I'm now moving on to some of the studies which we've done, and this is the intention of showing you all these studies is basically to give you an idea of the gamut of problems, the variety of problems that we have in the healthcare setting. Let me start with the colleague, Dr. Naveen, who's there in Daman right now. And a study which he had done a few years back along with us is showing that about 74.9% of the workers in the healthcare industry, and this I'm talking about is basically nurses, have no work-life balance. 98.2% of them are stressed in their work, and 81.3% of them are unable to complete their work on time, and therefore they're forced to stay back beyond their duty hours to complete their work. Another study done by Dr. Nisha and others, again in our own health setting, among nursing aides, and these are people who have not been trained in a GNM program or a BSc program. 60.9% of them suffer from stress. Inherently, 76.1% of them have got anemia, headaches and low back pain. More than half of them have got headaches and low back pain. Coming to a few more studies, another study done by a postgraduate from our department a few years back showed that shift work disorder is quite common among the nurses, as a result of which they do suffer from, 17% of them suffer from anxiety and 23.8% of them have a problem with depression. Again, Dr. Nisha conducted a study among these nursing aides and found that each of those nursing aides, the nursing aides suffer from approximately 36.9 episodes of illnesses or morbidity per 100-person month spent. So that shows you the amount of problems the number of problems that the nursing aides have got. And of those 36.9 episodes, 50% of them are infectious diseases and 30% of them are MSTs. When I talk of infectious disease, I'm not talking of serious illnesses like tuberculosis or COVID-19, but simple problems like an upper respiratory tract infection or a diarrhea can impact the lives of these nurses, basically poor personal hygiene and habits. This is an interesting study done by another postgraduate of ours, Dr. Chandralekha, who did a study among the healthcare workers and found that about 81.2% of them perceive that they've got a musculoskeletal disorder. 37% of them were diagnosed to have a musculoskeletal disorder. This just tells you again the problems that we face at our work setting. Improper postures, constant bending and doing work, all this can lead to problems among healthcare workers. And a study done by Dr. Ashwini GS and others among lab personnel showed that about 3.09 episodes of morbidity per 100 week spent. That just gives you an extent of the problem that we have in our own health setting. This is a study done. The first one is a study done by Dr. Melvin Kumar, who found that there's an incidence of 19.4% of tuberculosis. That's in a period of 1 year, 19.4% of the healthcare workers who were negative by the Mantoux test had converted to positive, or almost 20% of them had converted to positive at the end of 1 year. A study done by Dr. Archana and the others showed that coverage for hepatitis B vaccine, which is mandatory in my opinion, is about 36.3% alone. And Dr. Shashi Kumar had done a study in the ancillary department showing that many people in these departments already have problems like type 2 diabetes and hypertension, 11 and 10% respectively. Another interesting study done again in our department shows that Dr. Chitra showed that nurses, about 10.6% of them suffer from latex allergy. And this is the pre-COVID time, and now of course the quality of the gloves have changed, and therefore we hope that the prevalence of latex allergy has reduced over a period of time. This is a very interesting study done just before the COVID time, which showed that 75% of the participants of the study, a study done in 3 different hospitals in Bangalore, reported presenteeism at least once every year. That means they came to work despite being ill. 40% of them were ill in the past 4 weeks and had still come to work. and 15% of them were sick on the date of the interview. Once again, the many reasons which have been given is that they don't want to burden their colleagues, they don't want to burden the patients, the duty roster was already set, and all these are the different kinds of problems that these healthcare workers said that they were having for the reason for them to come to work despite being ill. All this in the long run leads to mental health problems among the healthcare workers. And among the emergency workers, Dr. Wilson found that about 70% of them were suffering from burnout. You can walk into any emergency medicine department in any tertiary care hospital and see the kind of stress that these people are facing. Another study done by one of our nurses, Dr. Jessie Matthew, showed that about healthcare workers, about 90% of the healthcare workers were women in the group that she studied. 40% of them had suffered from insomnia. 20% of them complained of daytime sleepiness, and 5% of them had chronic fatigue. All this is also compounded by the fact that nurses are sometimes bullied depending on where they're working, and consequently they suffer from low recognize and ensure that at least ourselves and the people working for us or under us in our own institutions don't have these kinds of problems. So who is responsible for the health of the healthcare workers? The probable answer should be themselves. So we all have heard the common phrase, physician, heal thyself, but I think the fact is that the physicians start protecting themselves. Healing is too late. We need to take care of ourselves even before these diseases can occur among ourselves, and the physician should be protecting themselves. So the health of healthcare workers, we can look at different things which we can do. Some of these are very simple: providing healthcare workers with personal protective equipment, ensuring that hand hygiene is adhered to, ensuring that respiratory hygiene is adhered to, and if possible, in all healthcare settings, ensuring that all vaccinations are given to people who are working in those settings. We do know, like I mentioned to you earlier, that mental health and well-being is a major problem, and therefore psychological support programs, ensuring some degree of work-life balance, and peer support programs are something which we can think of to ensure that the mental health of workers don't start suffering. With regards to occupational safety, we do have to ensure that safety is ensured in workplaces. We have a safe shops and chemical safety policy. We have to ensure that ergonomic workspaces are provided for the workers where they're working, ensure that well-lit and ventilated areas are available, and obviously biological safety, because I told you that a little earlier that infectious diseases are probably one of the commonest things that many health workers, infection risks are faced with. So the health of healthcare workers, a lot of it depends on training and education, surveillance and monitoring, ensuring equity, inclusivity, and access to healthcare services, and from our experience over the past 5 years, ensure that we are prepared for pandemics at all points of time. So the challenges we have is that we do have a low health-seeking behavior, like I mentioned. Many of us work long hours and therefore lack of time to ensure that we access healthcare services. We have the savior complex, thinking that we have to save the world and therefore we can neglect our own health. There's low awareness of certain health problems among healthcare workers. The threats from outside sources is that the funding is less. We do know that in a country like India, less than 2% of our GDP is spent on health, and obviously the lack of resources in many healthcare settings can be a challenge, can be a threat to all of us. So the way forward is to introspect as an organization. Many of us work for organizations, large organizations, and therefore introspect as an organization, look at sickness, presenteeism, look at the morbidity of healthcare workers, identify stress and burnout among them, and try and restrict the number of work hours in a week that we have. And obviously, to ensure that this happens for the organizations we work with, we need to show return on investment, provide staff health services, workplace health interventions, education and training, and improve the resources which we have at our hand, and show that over a period of time, the work quality and the work quantity of individuals is increased over a period of time. So the way forward is to address at a national level or at an international level is to address healthcare worker shortages, integrate the systems to tackle burnout among healthcare workers, which is why many people leave the profession, include effects of climate change on workers over a period of time, the kind of institutions that we work in, the kind of infrastructure that we are working with, the kind of buildings that we work in, we have to ensure that the climate change does not affect that too much, and incorporate technology and AI over a period of time in the health of healthcare workers. I think gathering more information on healthcare workers, having a common database of healthcare workers all over the country is probably going to give us a better way to tackle the issues of the future. With that, I would come to the end of my presentation. Dr. Saxena, sir, I wonder whether you have a chance for questions to be asked. I'm available to answer any questions if they have. So once again, thank you very much to the organizing committee of Gujcon 2025, and I'm really happy to have been able to present this to you. Thank you.
Thank you, Dr. Bobby. You have wonderfully presented data about health of occupational health workers, the occupational health of the hospital and our own departments. Any question you people want to ask, anybody from audience? Thank you. Thank you, Bobby, for a wonderful talk.
Thank you, Dr. Saxena, sir. Thank you very much. Thank you. Thanks a lot for inviting me. And we look forward to seeing you in Jamnagar.
Okay. Bye. Thank you.
Thank you. Thank you then.
Good morning, everybody. I would request Dr. Bhavesh and Dr. Saxena, sir, to please join us on stage. Guys, can we have a huge round of applause for our chairpersons? I think itne hum log kafi hai. Let's show some energy. I would also like to request Dr. Merlin Joseph, ma'am. Topic OH issues of better gender, St. John's Medical College, Bangalore.
Good morning, everybody. Welcome, Dr. Merlin Joseph. She is Assistant Professor, Department of Community Medicine. She is looking after the occupational health and in St. John's Medical College. Now, she will be talking on occupational health issues of the better gender. Dr. Merlin, please.
It's there, it's not working. Good morning, everyone. I'm Dr. Merlin Joseph. I'm from the Department of Community Health. I'm an assistant professor working there. Today, my topic would be the occupation health issues of the better gender. So it is quite an interesting topic, and when I asked about this better gender, I got a lot of multitude of responses. And most of the women that I talked to, were very surprised asking who is the better gender. Because in an age and a time when we are talking about equality, they were really surprised that are we really talking about which is the better gender? But for your information, all the men were unanimously agreed that women were the better gender. So for the status of this presentation, I would be stating up front that I'm talking about women and I'm calling them as the better gender. And it is not because of superiority, but it is because of women having better emotional strength in the times of any problems. They can face it better. There is greater resilience that we see because they play multiple roles, so they are more resilient to life's changes. And they also have social responsibility, so they do a lot of multitasking and they play dual roles. They play paid work at work, and then there is a lot of unpaid work at home. So that's why that is another reason. And also, the women have biological edge. That is, they tend to live longer, they tend to outlive their partners. So because of all these reasons, probably the organizers thought that women are the better gender. But there is a definite contraindication in the occupational health settings, because at the workplace, the scenario is entirely flipped. Workplaces are designed for and by men, and unpaid work is not counted. So a lot of women spend an average of at least 4 to 6 hours in a day on unpaid work, and this is just expected of them, but it is not really appreciated. And then there are a lot of stereotypes at the workplace which will devalue their efforts. Like for example, in nursing or as a teacher, caregiving, nursing, and teaching services, women are generally just expected to be caregivers, and they are seen, this is seen as their natural role, and it's not something which is viewed as a skillful occupation, so that also is contradictory. And also at the workplace, the safety and health concerns of the women are definitely ignored, and leadership roles are limited. So most of the women are mainly working at the lower cadre of workers, but we see very few women who are climbing up the ladder and becoming leaders. And definitely there exists the gender pay gap, as well as the glass ceiling for how much a woman can earn still persists. So with this in mind, though we are the better gender at the workplace, it is not necessarily so. Now when we look at women in the workforce, we see that the Iaoh says that the female labor participation is around 47% globally, as against 70% of men. And in India, we are slightly lower. The female participation is around 32.8%. And this is from the periodic labor force survey. And definitely in the last decade or so, this has risen, because previously, a decade earlier, we had only 25% of women in the workforce. And what has been the reasons for increase in women participation in the labor force is there has been a definite decline in fertility rates, also expansion of women's education, and also there has been a rapid economic growth in our country, which we have witnessed. Now, the predominant sectors that women are working in are the informal sectors, like informal work, agriculture, domestic work, garment sector, and in healthcare. Now, what keeps women excluded from the labor market? I have multiple reasons which have been put up here, but I would like to highlight the topmost reason. That is, most of the women are involved in child care and personal commitments in homemaking. That is almost 44.5% of them. And a sizable amount also want to continue their studies. So these are the top 2 reasons which have been cited for keeping women away from the labor force. Now, while we can talk about a lot of health issues and occupational health issues that women workers face, we can classify why do women face occupational health issues, and that is because of a combination of structural, social, and biological factors. Firstly, women have very different physiological periods which have been experienced throughout their lifetime. So they have a plethora of emotional and hormonally charged periods, be it pregnancy, be it during their menstruation, or even during menopause. And they also play a dual role and double burden at work and home. So paid work and unpaid domestic labor. They may be child caregivers, they may be taking care of the elderly, they may be providing household duties. And there is also increased susceptibility to malnutrition among women. More than 50% of the women in our country are malnourished. Anemia is very prevalent even today. And because of all these reasons, they are more prone to develop chronic fatigue, musculoskeletal disorders, stress, and experience high mental strains. There is also an issue of gender discrimination. So there is gender division of labor which is happening at the workplace. So women are generally overrepresented in low-paid, informal and unregulated work sectors like in the garment industry or the agriculture. And these jobs often don't have legal protection, they don't have health benefits or safety standards in place. Now, physiologically also, women are very different from men, and this plays an important role for their health as well. So, firstly, there is increased musculoskeletal disorders in women because of the use of PPEs in certain sectors, because these PPEs are generally designed for and by men. And because of the heavy weights of these PPEs, women have repetitive strain injuries and back aches. Also, the efficacy of certain PPEs like the respirators, the gloves are not very effective because they are not designed for the smaller sized women. Women are more prone to have chemical exposures like cadmium, solvents and pesticides, and these are more dangerous to women because of their effect on their reproductive health and increased risk of abortions and maybe even cancers. And renal system in women is much slower than men. So for the same amount of exposure to a toxin, there is delayed excretion of the toxin from the body, and this can lead to future problems, health problems. So broadly, I would like to classify the occupation health issues of women into musculoskeletal disorders, reproductive hazards, mental health issues, maternal health issues, and workplace sexual harassment, as well as cancers. Now, while we can talk about several industries where women work at, we at the Division of Occupation Health are closely working with 3 prime industries. One is healthcare, another is agriculture, and the third is in the garment industry. So I would be talking primarily about the occupational health issues of women in these industries. So in the healthcare industry, we know that women make up almost 67% of the global health workforce, and they are mostly in the lower paying jobs and lower jobs which have lower power, like the ASHA workers and the nurses. And here, as Dr. Bobby Joseph just mentioned in the previous talk, there is great chemical exposures like exposure to disinfectants, sterilizing agents and hazardous drugs. There is exposure to varying degrees of violence, be it from the patients, caregivers and attenders, or even from the senior doctors. So there is verbal, organizational, sexual and physical violence. There is experience of fatigue because of high workload, burnout and stress, and sleep disorders. And as mentioned previously, newer occupational health issues like latex allergy and needle stick injuries have been noted in 8 to 12% of the nurses. And needle stick injuries predisposes them to HIV, hepatitis B and HCV as well. In the agriculture industry, half of the world's food is produced by women, and 3/4 of all women workers in rural India are working in the agriculture sector. Women work in land preparation, seed selection, seedling production, and also are involved in harvesting, threshing, storing, and animal husbandry. Fewer than 13% of women are landholders in India. So the irony is that though they are tilling in the land and working in that land, they do not own the land that they work in. So the occupational health issues of women in these sectors is primarily the exposure to pesticide. Globally, almost 0.3 million workers are exposed and they lose their lives to pesticide exposure. And in women, this is linked to abortions as well as breast cancer in postmenopausal women. Musculoskeletal disorders are high because of the repetitive load and the strain that they take, high physical activity, prolonged static postures, and heavy load lifting and handling. Also, there are auditory issues as well as respiratory issues due to prolonged exposure to dust, and reproductive health risks. One prime thing which you need to note is that these women do not have access to toilets, so they are more prone to urinary tract infections among agricultural workers. The last sector which I would like to highlight is the garment industry, and 45 million workers are working in the garment industry, and almost 60% of them are women workers, but most of the supervisors and the higher cadre is men. What happens here is there is a high degree of violence. It could be verbal violence as well as physical violence, because the supervisors tend to exert control. 93% of them experience pain in arm, shoulder and neck. 20% have respiratory issues. 11.5% have skin problems like dermatitis and conjunctivitis. 41% of them experience mental health problems, and reproductive and urinary tract infections are also common in the garment industry. So I just highlighted 3 sectors. There are several other sectors where women work in, but most of the women workers in India are right now in the informal sector. And there is a burden in this sector as well, because 90% of our women are working here. And what is the problem here is there is no legal protection, no ESI, PF, no maternity benefit or occupational health coverage for these workers, which puts them at a particularly vulnerable position. So the bigger picture here would be to look at and consider gender differences when we are formulating a plan, a policy at the occupational health settings. It's very important to have a very gender sensitive approach to consider that women are also working alongside their menfolk, and understand that women have different societal expectation, and also understand that they have different responsibilities at home as well as work, and also consider the physical and psychological risk that women face at the workplace. Now, tying all this to the theme for the conference, that is inclusivity, compassion and connectedness, how can we be more connected and compassionate? So firstly, being compassionate, we definitely need to acknowledge burnout and provide more flexibility, especially for women in terms of schedules and timings. For connectedness, I could think of including women more in the leadership roles, because women understand women better. So including them and promoting more women leaders would be helpful. And in safety design processes, because most of the safety designs and PPEs are designed especially for men. And inclusivity, we need to build systems for all women, rural, informal, as well as disabled women. Everyone should be in the same workplace. So in summary, cutting across all industries, the main occupational health issues which women face are workplace violence and gender-based violence, stress and fatigue, musculoskeletal disorders and pain, as well as mental health concerns like depression and anxiety. And the thought which I would like all of you to go back with is that women are not treated as the better gender at work, because workplaces weren't built for compassion, inclusion or connectedness. Rather, workplaces are being built for competition, conformity and silence. Thank you very much for your patient listening, and I'm open for questions.
Thank you, ma'am. It's a perfect time to complete the presentation. Any question from audience? Any questions? Okay. So, yeah, you rightly said, madams, the leadership roles of, women, that should be included, and all these policies and formation. So, that's a very good point. And you covered all things, contradictions of occupational settings, and why the reasons of women's are not, women's excluded for the labor and everything, and occupational health issues very nicely you have presented for the women's, and reasons why they are taking away from some of the work and everything, and the policy making and everything to be included for them. So, and you have included all healthcare settings, agriculture, garment and everything. So thank you, ma'am. Thank you for all your very insightful and knowledgeful sessions. Thank you so much, ma'am.
Thank you very much.
Thank you so much, ma'am. Can we have a huge round of applause for Merlin, ma'am? So, guys, now I would request both our chairpersons to felicitate Merlin ma'am with a memento for this wonderful presentation. Dr. Saxena and Dr. Bhavesh. Guys, can we have a huge round of applause for the morning session we have started? For Dr. Bobby. Thank you. Malin ma'am, please. Yeah, please. I would request Gimawat sir, Solanki sir to please join us on stage for the appreciation from the committee of Gujcon 2025 for her valuable contribution. Guys, come on, we can do it much better here. Come on. Thank you, ma'am. I would request on behalf of committee, Dr. Vashi sir and Dr. Vismay sir to please join us on stage and give a token of love to Dr. Saxena and Dr. Bhavesh for their valuable contribution to Gujcon 25. On behalf of IAOH Surat Gujcon 25 at Daman over here at Mirasol, a huge round of applause, guys, for this wonderful contribution. Thank you so much, sir. Thank you so much. So, guys, once again, wonderful morning, wonderful sessions. One by one, as today also we are lined up with some amazing topics and sessions. I would request Dr. Vismay sir to please join us on stage to chair. And next we have Dr. Ronak Ruparelia, cardiologist. Lovely. Can we have a huge round of applause for Dr. Ronak Ruparelia, Bankers Hospital. Yeah, please sir.
So meanwhile, we will do the formalities of connecting the laptop. I would like to thank all organizers, Dr. Shubham, Dr. Vismay, for having me here on this Sunday morning, and I welcome you all on this Sunday morning to the conference. So my topic will be a clinical topic, that is the approach to chest pain. So let's see, let us have it on the screen, and then I'll start with the lecture. Okay, thank you.
Good morning, friends. Dr. Ronak Ruparelia, sir, is a senior interventional cardiologist from the Bankers Group of Hospital. So he's done his MBBS in 2008, DNB Medicine 2013, and DNB Cardiology in 2018 from Nanavati Hospital, Mumbai. He has so many publications on his name, and today he is presenting to us chest pain at what to do at occupational health level. When industry physician facing some patient with the chest pain, how to proceed? To enlighten us, Dr. Rupanelera, hand over to you.
Thank you, Vismay sir. So, I'll stick to the basic. I'll not go more into details. If you have questions, we'll take it at the end of the session, or meanwhile in between also, if you have any question, we can take it in during the session also. So chest pain, this is a very common symptoms all of us are facing every day. At least one of the patient will tell us that I am having chest pain. So we should know what are the differential diagnoses of the chest pain. Chest pain can be because of the cardiac causes. The commonest of this is ischemic heart disease, that includes myocardial infarction, ST elevation MI, non-ST elevation MI, unstable angina, stable angina. Non-ischemic cardiac causes are pericarditis, aortic dissection, or sometimes valvular heart disease also. Beyond cardiovascular system, some non-cardiac causes can also present to us, like with chest pain. Commonest of this, which you may face in your practice, is gastroesophageal reflux disease. Sometimes esophageal spasm also, Borhev syndrome, cholecystitis is also very common chest pain presentation, mediastinitis. Other causes include, which are not very common, but yes, need to be kept in mind, is pneumothorax, pulmonary embolism, subdiaphragmatic abscess, Tietz syndrome, and herpes. Out of this, our prime importance should be to rule out life-threatening cardiac causes, because if we diagnose these cases early, then only we can save the patient. So life-threatening causes of chest pain are acute coronary syndromes, pulmonary embolism, tension pneumothorax, aortic dissection, esophageal rupture, pericarditis with tamponade. So that creates a dilemma in our mind, what kind of chest pain I am presenting with. And this dilemma is as equal as like we are selecting bride for us or maybe our son, and it is always difficult. Many times to select a groom is not difficult because women are much more focused and they are much more clear what they want. But as a man, we are more confused. So while selecting a bride, we should answer what is the past history, what is family history, biodata, kundli. And when we are talking about chest pain, everything will be replaced by this. Here also, past history is very important. When you are dealing with any kind of chest pain, past history is important. Family history, again important. Old reports are again important. Most important is vital parameters, investigations, and sometimes reevaluation can be required. So with this, I am stopping the theory and we are starting with the clinical presentations. All are real life cases. If we can interact in between, that will be much better. So our first patient was a 67-year male, hypertensive, diabetic, chronic smoker, came to us with squeezing type of chest pain of acute onset radiating to left arm. In past, patient had occasionally chest pain on exertion. So this was the history in past history. And now he's experiencing pain at the rest. His father died at the age of 70 years with myocardial infarction. Cardiac enzymes were negative at this time. And this was the ECG. For those who are not familiar with ECG, I'll just say this ECG did show some left ventricular hypertrophy, but no STT changes. So what is this? Is it non-ST elevation MI, unstable angina, muscular chest pain, or anxiety-induced chest pain? So NSTEMI rules out because cardiac markers were negative. What is non-ST elevation MI? It has no ECG changes. Patient is having chest pain, cardiac marker has to be positive. So NSTEMI rules out. Unstable angina, will keep it aside. Muscular chest pain ruled out because we have multiple past histories. Past history of hypertension, diabetes, father having ischemic heart disease. So that favors more towards the cardiac side. Anxiety-induced chest pain, there are no point in history to suggest anxiety. So that brings us to one diagnosis, that is unstable angina. Now, what is a cardiac pain? A typical cardiac pain is what we have learned in our Braunwald, Harrison, A typical cardiac pain is stabbing pain, burning pain, sometimes it is twisting, tearing. Patient will tell you that I have something kept on my chest and which is very heavy. A heavy stone is kept on my chest. Or somebody is squeezing me from around the chest. So that is a typical cardiac pain, and that is generally associated with what we call it as a ghabraman. In English, fancy letters, we call it as a terrifying, nauseating or sickening kind of chest pain. A WHO definition of acute MI involves 2 of the 3 characters, which is typical symptoms, a rise or fall in cardiac biomarkers, and typical ECG patterns. So that brings us to the second patient. Now we'll make it more complicated a little bit. A 78-year female attended emergency room with acute onset chest pain since past 2 hours. So history is very short, only 2 hours. Past history and family history strongly positive for ischemic heart disease. ECG I'll show you. So what condition this lady is suffering from? Very simple. This is typical ST elevation myocardial infarction. This is initial cases, that's why I am keeping it simple. So this is ST elevation myocardial infarction. How ECG behaves in ST elevation myocardial infarction? A typical patient who presents to you very early, like within half an hour, within 1 hour, the first sign which appears on ECG will be tall and peaked T waves. And it will be tall, symmetrical peaked T waves on ECG. This is followed by, after couple of hours, this is followed by ST segment elevation, followed by appearance of abnormal Q waves. What is abnormal Q waves? A normal Q wave should be less than 1 small box in height as well as width. So any Q wave which is broader, more than 1 small box, or deeper, more than 1 small box, is abnormal Q wave. This abnormal Q wave appearance, now infarction has already progressed. The myocardium is already infarcted. So after this, there will be decrease of ST segment elevation followed by T wave inversion, and later on patient will develop a frank Q wave MI. Causes of ST segment elevation, one we already discussed, acute myocardial infarction, variant angina, acute pericarditis. Some other causes are left ventricular aneurysm, can lead to a persistent ST segment elevation. LV hypertrophy can also have certain ST elevations. Other causes, non-cardiac causes, are hyperkalemia, hypothermia, although in our country hypothermia is not very common, and sometimes hyperventilation also. Miscellaneous causes which are very rare but acute abdominal distress can also have ST segment elevation, particularly pancreatitis or cholecystitis, which irritates the inferior wall of diaphragm, creates inflammation at the inferior wall of heart or inferior myocardium, and that leads to inferior segment ST elevations. Sometimes body habitus and idiopathic also. Moving on, a 58-year female came to emergency room. This is very interesting, at 3 a.m. at night. So any patient comes to you in night with chest pain, don't ignore that. Advise admission, at least. So she came at 3 a.m. in night with acute onset retrosternal crushing type of pain radiating to left arm associated with excessive perspiration. Patient was hypertensive diabetic with strong family history. Cardiac markers done in ER was normal. And this was the ECG. Except certain mild T inversions, mild ST shagging in lead V3, rest of ECG is not very alarming. What will you do? Admit in ICU, reassurance and discharge, muscle relaxant, or refer to psychiatrist? So I said already, anybody coming to you in night after your OPD hours, admit and reevaluate. So that brings us to the parameter. Reevaluation is required in certain cases. So what happened next? This lady was admitted. Cardiac markers were repeated after 4 hours, and now it has jumped. Troponin has become negative to 1.24, significant, 10 times jump. And now ECG is like this. ECG showed significant ST elevation in lead AVR, and multiple other leads showed ST depression. So this is a typical case of myocardial infarction where patient presented to you very early, cardiac markers were negative. So that brings us to the importance of cardiac markers. What are the cardiac markers? Commonly we use CPK, CPKMB, troponin. Other markers are myoglobin, SGOT, SGPT, and hard type fatty acid binding proteins. Out of this, hard type fatty acid binding protein is very early to rise. It can rise within 5 to 10 minutes of myocardial infarction, but it is very non-specific. So that's why it is not being used. So commonest marker we use is CKMB troponin. CKMB troponin rise after 3 to 12 hours. So patient presenting to you early, within 1-2 hours. CKMB troponin can be negative. So when you have good amount of suspicion, admit that patient, repeat cardiac biomarkers. If you have high sensitivity troponin, you can repeat it 1 hour also. If you have normal troponin, you can repeat it 4 hours or 6 hours and look at doubling. If it is doubling, it is myocardial infarction. If not doubling, even if it shows rising trend, according to the definition of WHO AMI, rising biomarkers in view of chest pain is considered as a myocardial infarction until proved otherwise, and that patient needs further evaluation. Many non-SES situations also can have raised cardiac biomarkers like myocarditis, pericarditis, pulmonary embolisms also can have troponin elevated because of the RV strain. Sometimes atrial fibrillation and heart failure can also have increased cardiac biomarkers. Moving on to the next patient, a 38-year male admitted with chest heaviness, 4 hours duration, associated with retrosternal burning and perspiration. No significant past or family history this time. Younger patient, patient is heavy smoker and obese. This was his ECG, which showed broad QRS complex, right bundle branch block. So in this case I have kept to note that sometimes we need to ask patient, do you have any prior ECGs available? So fortunately this patient had undergone health checkup 2 months ago. That time this was the ECG. ECG was absolutely normal. And now with chest pain, patient had this kind of ECG. So what you will do? Again confusion starts, whether it is myocardial infarction, is it unstable angina, muscular chest pain, anxiety-induced chest pain. So this is not muscular, ECG head changes. This is not anxiety-induced, ECG head changes. So we are dealing with 2, unstable or myocardial infarction. To call it as unstable angina, yes, we had many things. We had chest pain, but we had ECG changes also. So out of 3, 2 points are being proven. ECG changes are there, chest pain is there. We are not aware about cardiac biomarkers as of now, but still it is myocardial infarction. So the point to stress over here is any acute onset bundle branch block, may it be RBBB, may it be left posterior hemiblock, may it be left anterior hemiblock, consider it as a myocardial infarction if patient is having chest pain or altered cardiac enzymes. Now, it is very interesting to know that right bundle is generally supplied by single artery, that is right coronary artery, but left bundle is supplied by dual artery. Left anterior bundle is supplied by left-sided coronary system, posterior bundle is supplied by right coronary syndrome. So, when we have acute LBBB, it is not always possible to have dual artery occlusion at a time. So, that's why ACCHA guidelines does not involve LBBB here. For the simplicity, we will consider that any broad QRS complex with chest pain should be considered as a myocardial infarction and needs further evaluation. Moving on to the 5th case. Now coming slightly out of the cardiovascular system, a 40-year male came to your room with history of 101 degree Fahrenheit temperature since 3 to 4 days, which is now associated with sharp and pricking kind of pain in retrosternal region, which increases on deep breathing. And this is the ECG on presentation. ECG did show some ST segment changes in lateral lead, if we can see in V4, V5, V6, in lead 2 also. So these are certain type of ECG changes which you need to keep in mind in view of history of fever, pain which increases on deep breathing. That brings us to the diagnosis. So the diagnosis is very clear only on history only. So what is your diagnosis? Is it anterior wall MI? Is it pericarditis? Is it early repolarization, or it is aortic dissection? Yeah, so this is pericarditis. Aortic dissection, I'll come in the next question. So this is pericarditis. The changes of ECG in pericarditis, it has a smiling upward phase or concave upward ST elevation in certain leads, PR segment depression, and appearance of J wave at the end of QRS or notch at the end of QRS. But again, in view of history, this is helpful. Now I have not added auscultation here. Sometimes when you auscultate patient on leaning forward position in sitting, that will also brings you to the diagnosis. You will hear crunchy sound or crunchy pericardial sound. It typically in patient of tuberculous pericarditis. Viral pericarditis, generally that crunchy sound doesn't come, But yes, in India, tuberculous pericarditis is very common. So, in paucity of time, I'll move on directly to the next question. A 38-year male came to emergency room with paraplegia. Now, a cardiologist dealing with paraplegia is again very difficult subset since 4 hours. Patient had sudden onset tearing chest pain radiating to back. On examination, you find that patient has absent dorsalis pedis, bilaterally, popliteal, femoral pulses on both the sides. What do you think? Is it myocarditis? It is some kind of cerebrovascular accident because patient is having paraplegia, pericarditis, or aortic dissection. This is very dreaded complication. Aortic dissection, if you don't treat it early, it's a certain mortality. In aortic dissection, it is said that 50% of patient dies before they reach hospital, 50% dies before they reach operation table, and 50% dies on operation table. So hardly we can survive only 1 or 2 patients out of 100. Next question is a 54-year male came to, last question. So let's move on to the last question. That is one of my favorite questions. Yeah, this is the last one. A 46-year male presented with left-sided pain.
Hello.
And this kind of patient will come to you often with gradual onset pain radiating to back. ECG taken on same day. Diagnostic center was found to be normal. Cardiac biomarkers within normal limit. Respiratory cardiovascular system. Examination found to be normal. Everything normal. And as he removed his shirt, anybody can guess? You see this. So this is herpes. So every time you need to think out of the box also sometimes. All pains are not related to organs. Skin is an organ which is the largest organ of the body. So skin can also give you certain kind of chest pain. So stay focused, stay attentive. Don't always focus on the beautiful girl. Focus on the real problem that is in backside. And always be watchful. Disasters can happen anytime. You need to be tentative enough to prevent disaster to your patient. Thank you.
Ronak sir, it was a wonderful presentation. Just one question from behalf of the audience.
Yeah.
So if we get a case of chest pain in our OHCs, apart from loading dose, like everyone knows about the loading dose. So loading dose we give. But apart from loading dose, what can be done to save his life?
If you have possibility of giving subcutaneous LMWH, give it. There is no harm in subcutaneous LMWH. Many times people think that if patient is undergoing coronary intervention, subcutaneous heparin should not be given. But there are many papers available where subcutaneous injections was given and coronary angioplasty was done, and that was very successful cases. So apart from loading dose, give subcutaneous LMWH, or if you have intravenous heparin available, you can give 5,000 intravenous heparin. That also saves the purpose. Many people give sorbitrate. So basically I would say in case of acute chest pain, avoid giving sorbitrate until and unless our pressures are on higher side. If it is inferior or myocardial infarction, if you give sorbitrate or nitrate, that will lead to resistant hypotension that cannot be corrected even with fluids, and that requires multiple inotropic support. So better to stay away from that sublingual sorbitrate. If you have ECG which is showing clear-cut anterior wall involvement, involve sorbitrate, give sorbitrate. Otherwise, inferior wall, avoid sorbitrate.
One more question. Even if the ECG is normal and there are signs of chest pain, perspiration, so can we give loading dose on normal ECG?
Yes, you can still give loading dose. There is no harm in giving loading dose. If at all patient is having GERD, that GERD symptom sometimes might increase, but it is not going to create harm to your patient at least. Thank you.
Thank you, sir. Thank you, Lord.
See, Brilinta, generally it is said that Brilinta is to be given whenever we are going to do intervention in that kind of patient. So if you are referring that patient to a cardiac center, you can give loading dose of Brilinta. That is 180 milligram. Yes. That can be given at primary center also. Thank you.
Thank you. Please give him a warm. From Baroda he has come. Yesterday he had 10 angiographies. Finished that and came in the late night yesterday, sorry. So thank you, Ronak bhai, coming from all the way to Baroda. Our next speaker will be Dhanashree, and she is from Reliance MedLab, Reliance Life Sciences, and she is going to talk on a very relevant topic today, that is predictive diagnostics. It's a very hot topic today, and thank you, Dhanashree, for accepting our request to present on this topic of predictive diagnostics. You may start your presentation.
Very good morning to all of you. Thank you for arranging this conference, Gujcon team, and that also at wonderful place. I'm from Reliance Life Sciences, and I know everybody generally is synonymous with albumin for Reliance Life Sciences, but that is not true. We have other products also. We have largest pipeline of biosimilars in Asia and lot of latter generation oncology based product. And there are many firsts on our name. We were the first one to have BRCA, medullary thyroid carcinoma, genetic counseling, PGD, PGS, and so on. Coming to diagnostic plays important role, especially influences over 66% clinical decision making. But still, only expenditure is 2%. And why world is moving to preventive care? Mainly because of the recent pandemic which has happened. There is a risen awareness among people, among medical team as well as general laymen, and because of this, we are moving towards preventive care more. And what you need for preventive care, for that early detection, risk assessment, is the targeted intervention. So what was the approach earlier? Earlier wellness approach or prevention approach was more of to do the tumor markers, to do the sugar, HbA1c at the most. But now the trend is changing because one size doesn't fit all. So we have to be very personalized. Now the trend is of everything personalized. Even people want TV on their mobile, that is also personalized. So let's come to that personalized. What makes it personalized? It's your genetic makeup. You get the disease because you have susceptibility to the disease because of your genetic makeup. People in the same family might have the different genetic makeup because even brothers and sisters, there is a chance that they will not have same genetic makeup and they will respond differently to the medication as well. So what are the advantage of these? So as I said, you can do early intervention, personalized prevention strategies. It reduces healthcare costs because you are, as sir said just now, you have to do early. So it's a proactive control over your health. So as Gujcon has a theme, healthier workforce and transforming healthcare through digital innovation. So all these genetics has a lot of to do with digital innovation. And why I'm talking to you on this? Are you an oncologist? Are you an allergy specialist? Yes, because employee come to you first and they want you to look at your reports. Even they do the testing outside, even the patient is admitted outside, they are the one who bank upon you. So what are the applications? The application majorly is oncology, which is known, CVD, diabetes, transplant, gut microbiome, nutrition and fitness. So these are the common ones. We are going to look at few of them. So how can we do this? So I'm not going to be very technical. You can use Sanger method, which is the old one, wherein you can just look at the targeted mutation. One region you can see and whether you have that mutation or not. Going forward, nowadays very popular exome sequencing, which will look at single nucleotide variants, insertions, deletions within coding region. Coding region is where your protein, whatever we eat, whatever we do is because of the protein. So we will look at this coding region. MLPA is a technique where you can look at copy number variations or DNA methylation abnormalities. I'll come to you that how we can do that. And chromosomal microarray. Here, if there is a loss of chromosome, gain of chromosome, you can look at this. Any gain or loss of genetic material is this. Why there are different strategies? Why we can't have just do the exome sequencing, genome kar do aur aa gaya sabka report? It's not that, because different strokes are for different folks. So what is the output? So this is the output of the report which I am showing. This is 21-year-old male manifested with weak body, weakness in the muscle, and there was a difficulty in getting up. So this was the report of that person. So whenever report comes, there you can get either benign, which doesn't, means it is a normal variation. You can get variant of uncertain significance, and pathogenic. Pathogenic is where you have to look at it. And VUS also, there is chance once there are multiple studies ongoing, you can get that VUS into either benign category or into pathogenic category. So for this case, the whatever variant we got was homozygous, and it was pathogenic. So you can give targeted therapy for such patients. Now coming to very popular technique which is used in fetal health, it is very common. After dual marker, quadruple markers, gynecologists are doing NIPTs. NIPTs is mainly screens your 13, 18, XY, 21, and very popular for Down syndrome. And I can assure you, if all the females which are pregnant are screened for NIPT, at least you can get rid of these chromosomal abnormalities, aneuploidies, which are very common. And another technique which is common is chromosomal microarray. It has higher resolution. Rather than karyotyping, you can get these aneuploidies detected in a better way. You can look at copy number variation. It is done in where there is unexplained developmental delay, intellectual disabilities, autism, or multiple congenital anomalies. So how it looks like? These are some chromosomal abnormalities I want to look at. These can be picked up on CMA. If it is not picked up on karyotyping and FISH, you can surely pick it up on chromosomal microarray. So the very popular implication is in cancer, because in cancer you have to treat the patient as per their genetic makeup. So you can detect mutations which are with respect to DNA and RNA and hypermethylation. So here, if you get genome sequencing, this is Angelina Jolie who has done BRCA testing. It's a famous story. And then she has done breast reconstruct because her BRCA gene was showing mutation. So you can do early detection. Accordingly, you can predict the response of the treatment. There are few popular tests. Once in early stages of cancer, Oncotypes DX and Mama Print has a chemo. It will evaluate how the chemo will work, whether there is a recurrence in the patient, there is a chance of recurrence in the patient or not. And why it is important? Because if you are detecting the case early, there is a chance you can treat the patient, and you can get diagnostic modalities also. So in cancer, we give the report like this. This is the carcinoma colon case where there is a mutation in BRAF gene, and these are the there are tier 2, means there are well-established implicated therapies are available. So this patient should be given fluorosil. If you have seen yesterday's Dr. Sanyal's presentation, he was talking about all this only, that if you give if you have genetic makeup of the patient, you can give treatment in a better way. So these tier 1, tier 2 and tier 3, 4 are from the Association of Molecular Pathology guidelines to categorize somatic variants into tiered systems so that doctors can give the right treatment to the right candidate. This is the extension of pharmacogenomics which I was talking about. It is not limited to only cancer, but it also has another implication such as warfarin. Depending on the VCORC mutation in the person, you can decide the treatment modality for warfarin. How much dose should be given to the patient, and same is with other cases. And gut microbiome. This is becoming very popular because your gut is the dependent, it can give you the dependent on mental health, immune-mediated diseases, digestive systems, and so on. So if your gut is happy, your belly is happy, it all happy. So it has, it can be used for IBS, IBD, bloating, constipation, diarrhea. In such cases, you can give tailored therapy to the person, and you can monitor the patient accordingly. It has utility in autoimmune and inflammatory diseases also. Depending on this, you can decide the personal nutrition of that person. Suppose you get what are your bacteria in your gut. Depending on that, you can give what should be diet of that person. The similar way, you can use this modality in personalized nutritional plans to treat chronic disease, to prevent the chronic diseases, food intolerance and sensitivities. It is especially utilized in sport performance and recoveries. So your genetic load is the gun, and your lifestyle is the what which pulls the trigger. So these FTO, MTHFR, CYP2, these are the different genes which can be used for this nutrigenomics. What we have to offer as a Reliance, what we can offer you is, we have exome-based testing for all of these. There is a hereditary cancer test, there is a gut microbiome, there is a nutrigenomics and comprehensive panels which can give you the what are the chances of cancer, risk cancer plans, and methylation panel. Methylation panel will give you the score, risk score of what is the score that you can get cancer. Now we are coming with array-based technique which has more than 7 lakhs marker. But as I said, in chromosome microarray, you have limited probe, you have those probes, and you will not be able to give novel mutations. But it will cover intronic as well as exonic, what I was talking, protein making as well as other non-coding regions, which can give you, this includes cancer, autoimmune, inflammatory diseases, mental health, cardiovascular disease, diabetes, pharmacogenomics, obesity, allergy, and what-not. And this is based, all these testing and reporting is based on American College of Medical Genetics and Genomics, which we called a ACMG.
Ma'am, last 3 minutes.
Sorry?
Last 3 minutes.
Yes, sir. It's the second last slide. So we need helper 3 for each and every individual, I'll say, which can give us astrology, health astrology, dependent on the positions, influences of genes, mutations. Mutations are like Rahu and Ketu, and whether it is good and bad. So I'm open for question and answer. It is difficult for me to cover this in 15 minutes. So if you have any doubts, any questions, you can also ask me later. So we have 2 minutes.
I forgot to tell, she is the head operations of Reliance Life Sciences, and she is pursuing PhD in transplant molecular genetics. And ma'am, thank you for finishing well ahead of time. So we'll have just two questions before, and I request everyone please come on the front. Next is our Soch Oration speaker, Dr. Rajesh. So just the people who are sitting in the back, please come in the front. Any questions? So, thank you ma'am, please be on the stage. As a request, Ronak sir, please come on the stage. This is just a token of love and affection for you. And I'll request Kamath sir to please come on the stage to hand over the mementos to our speakers. And ma'am, please, hostesses, they requested. Ma'am, please come in the center. Dhanashri. Kamath sir, thoda center mein. And just want to tell you that this is going live on YouTube. I don't know how many views will be there. As you can see, Sardar Patel statue, which is a symbol of the Gujarati Asmita. We'll have a photo together. आइए मैम. And last not but the least, the chairman. Ma'am, आइए, we'll have a photo together.
Guys, can we have a huge round of applause for the valuable contribution by our speakers and by our chairpersons for the session. Thank you, Shubham sir. Thank you, ma'am. Next, I would request Shubham sir and I would request Dr. Aditya Paliwal sir and Dr. Vishwajit Kaul sir to Paul sir to please join us on stage. And next speaker is absolutely, as Shubham sir also said, the heart of this wonderful Gujcon 2025, Soch Oration, redefining workplace wellness, bridging health, safety and sustainability. And who better than Dr. R. Rajesh sir with us. Can we have a huge round of applause for Dr. R. Rajesh sir, Group Head Medical and OH Services, Reliance Industries. R. Rajesh sir, it's an honor to have you over here. I would request you to please. And we have sir for the intro. Please sir.
Dr. Rajesh sir. Sir. Good morning, ladies and gentlemen. At the outset, I welcome you all to the Soch Oration. To introduce Dr. Rajesh, everyone knows him, but a formality, just a little bit of whatever he has achieved is on the stage, is on the screen. Dr. Rajesh is the Group Head Medical Services of Reliance Industries Limited. He is the current board member of ICO, the International Commission on Occupational Health, 2024 to 27, and past president of IOH, national body. He is a member of the steering committee of World Economic Forum on Mental Health and recipient of the CKR Centenary Award for Lifetime Achievement. Congratulations, Dr. Rajesh, on the oration, and the stage is yours. Thank you, sir.
Good morning. Good morning. I hope this mic is working. You are able to listen, those who are backside? Okay. Morning, it looks like Daman ka effect aa gaya hai. Those who are inside, they are real want to love. They are academician. Those who are outside, they are enjoying the maja masti of Daman. Let them enjoy. So both things are important in present circumstances. The second thing is thanks to Surat branch for giving this Soch Oration. President, Secretary and Surat branch, I am thankful to them, on the organizing committee especially, all. The reason is two reasons. Whether they thought it or not, I can understand why they have given to me. The reason one is, I did my MD Public Health from Surat. That is the one thought they might have thought of that. Second thing, initial 7 years from my OH beginning was from Silvassa. And Daman is very nearer to that. So they thought that both place belongs to me, so let's give him to him. So that may be the reason. So thanks to Surat for that thought process. But before that, give a big hand to Surat branch and organizing committee. This Gujcon is crossed some landmarks. So give them a big hand. Their efforts, their things they have done it. Now, why I am here? There were 2 incidents happened in last 1 month, and which I want to tell you. Yesterday, a young physician was telling OH physician mental health. And yesterday morning, we started with the Dr. Naveen's unorganized sector, and today morning, we are talking about organized sector, how the best is that. So, 2 extremes in the 2 days morning. The 2 incidents which happened, one day one guy, young, we say 59 years, no diabetes, no hypertension, a senior leader, working in the office, afternoon 3:30, as usual doing a meeting on MS Team without video on nowadays. I don't know why. He got collapsed, cardiac arrest. So there was some sound went to some other room, they came immediately, and he got the AED team, medical team, in 2 minutes time. Everything done. Within 3 to 4 minutes, he was in the hospital, a very good hospital where everything has been done. For half an hour, 45 minutes, we could not save him. The thing was, what is happening in this world? Post-COVID, if you see, world is changing, totally changing. And for us, and for young OH physician, it's a different world now. So then I talked to next day their colleagues. They told he was a very good guy, very sincere guy, everything, but usually not to share anything. Okay. After 2 days, I had a sitting with family, with the wife. And they are staying in one of the topmost BRC colony of Mumbai. I was talking to her. What happened? Well, previous day he came, sir, at 8:30 at home, had 1 or 2 samosas. Then generally nowadays you all believe the children are staying abroad and parents are alone in the old age. So he told wife at 10 p.m. go to bed. Wife slept. And after finishing IPL, he went to bed, but night went to washroom plus twice or thrice. Generally he gets up at 6 o'clock, but that day he was sleeping up to 7:30. Then wife just told him, why you need not to go to office? Well, no, I have to go to office. I'm already late. There is a meeting at 10 o'clock. Then he asked, before going to give me 1 Pentop D. 1 Pentop D. Wife, okay, thought of might acidity only. She gave the Pentop D. He took the Pentop D. He came to office, even not shared with any colleagues. One important aspect is sharing. Please, something is happening you and early is happening something acidity and other things, so you have to think over something else is also there. The second incident, which was more alarming for me, a young, roughly around 26 years guy, retail guy, he had a severe chest pain at home. He told wife, I have to go to hospital. Yes, both started for the hospital, but he started driving the vehicle. And wife was sitting the side. Before reaching to hospital, he met with a cardiac arrest. And vehicle met with an accident. And the guy who came in front of the car, he died. And this guy, because he reached the hospital, defib applied everything, he survived. The second moral of the story is, when you are having a severe chest pain and something, please ask either ambulance or drive somebody else, friends and families or anybody else. You don't drive the vehicle. Now, with this brief story, something is changing in the world, and especially those who are diabetic, especially those who are old, and those who are women. The typical heart chest pain which he described just now, a very fantastic presentation, may not be there. You may be having a certain time back pain in the shoulder between 2 blades, severe pain, or you may be having a terrible weakness, nothing else. Or recently we had a case, Only palpitation, nothing else. So certain times you have to detect with the early rising cases also. So the best important thing is nowadays for young OH physician, pre-hospital care. The patient reaches hospital, hospital will take care. The importance is pre-hospital care from home to hospital. That is the important nowadays. So coming to my presentation now, I hope this is working. Yeah. Now workplace is changing. Before few years we used to talk about only of physical health, but at workplace we talk about mental health and emotional health. The second thing, what is changing take places in the world is the physical health is replaced by holistic health. No question of only physical health, it is the holistic well-being. Work-life balance change into work-life integration. Reactive rather than reactive, proactive mental health support. Rather than individual, it is now team, it is family, which is more important, and friends. And nowadays, no employee works for perks. It is purpose-driven now. We have seen in Reliance also. Yesterday, I was talking to one head. He was telling me, sir, now they don't want to become the site head. Our managers, well, we are where we are happy. We don't want to take that unnecessary load and other things which don't need it. Traditional wellness program has changed to target driven. Now, HR has to change in this country. Calling some doctor and taking a session for 1 hour is not important. One has to be focused on targeted diabetic, hypertensive and other cases, target driven approach. 70% of employees says wellness programs directly impact job satisfaction. 1 in 3 employees reports mental health issues. And going to this slide, this is an important slide. You need not to go in detail, but as we are growing older, I am telling you our life expectancy has gone up, and most of the children are staying outside we have to be fit up to 75, 80. Our fitness is the most important, otherwise somebody who will take care of us. And keeping in the mind that our fitness has gone up, our diabetes, blood pressure cases are also increasing. This is the slide which shows you cardiovascular disease. In 2050, government is talking about India is going to be one of the best economy, but at the same time, we are projected to reach 24 million deaths per year of cardiovascular disease, hypertension going to affect 1 in 2, and diabetes cases may exceed 1.3 billion, and last, over 50% of population may be suffering from some sort of mental health issues. These challenges which we are going to face in next few years. Now, just I'm not going to describe too much. Some of you well aware of the something, what our chairman says, that's you are well aware ki make the world most healthy company and all the promoting, enhancing health. The scope is very big. We are taking care of 5.5 lakh employees across businesses with family members, roughly around that counts 15 lakh all over India. Then generally Reliance Medical Services on preventive, promotive and curative, depending on all the things, employee well-being and happiness is the most important. Coming to our operating managing system, there is a defined operating managing system for all the things to deal with our operations more safe. This is the thing, medical infrastructure, each industry, there are very good other centers are there, Reliance is there, HUL there, L&T is there, Procter Gamble is there, other centers are there which are very, very good having advanced occupational health centers. So one is occupational health center, second is OPD care, IPD care, emergency care. This is the one of the modern occupational health center which you can see it is of the Surat occupational health center, and gradually we are changing all our old occupational center to become a modern occupational health center, and there are going to be all NABH accredited. Already our 3 occupational health centers are now NABH. Across India, we are going for NABH accreditation of all occupational health centers. And office wellness, and this is the occupational center. We have a well-defined rooms for young OH physician to aware what are the occupational health center should consist of. Somebody yesterday was talking about no decontamination room in the hospitals, but he should be aware each OHC is having the decontamination rooms, and hospital has to think over it. This is our well-planned decontamination room. This is one of the area. Yes, one of the things we implemented post-COVID in our casualty department is heart score. By this heart score, we are able to define whether patient is really having a chest pain or something, and whether needs what care. Coming to the sustainable program, change agents for safety, health, environment, those who are young and they don't aware, this is the project started, something is 23 years ago, most sustainable, it is around CASHE 2.0, where included wellness programs also. It is basically at the plant level, improvement of occupational health, safety, hazards. That is the base. And across the Reliance, these projects are running. Then second is task-based health risk assessment. This is the individual employee worker who is working at the workplace. What is his health risk to exposure to gas, exposure to acids and other things. Now this is the thing. This slide yesterday you have shown, Monica has shown you. Now we have changed from occupational health to basically holistic health. Now physical well-being. Now before going in physical well-being, there are three things are important. One, exercise. How many of you do a daily walk or some sort of exercise? Raise your hands. Oh, very good. At least most of them you are doing it. So exercise is any form is good. Keep in mind. And 30 to 40 minutes walk for 7 days a week is a good exercise. So don't worry about that. The second thing is, this is any form of exercise you should be aware. Diet. The Indian diet is the best diet. Veg Indian diet is a good diet. You have a morning breakfast, you have a lunch and you have a dinner. That is a good diet. But only harm is, in Gujarat, if you are there, you take one mango is okay. Don't take 4 or 5 mangoes. If you are taking one gulab jamun, that is okay. Don't take 4 or 5 gulab jamuns. Yesterday, the organizing committee was behind to take me 5 6 jalebis. Make okay, 2 jalebis are good, yaar. 5 6 jalebis are dangerous, but they have made a good thing. So they have to sell their products also. So they are right in their place. But what we do nowadays, whatever the sweets come to me, Atiti Devo Bhava. I don't take it, I give it to others. Okay, it is up to them whether they want to take sweets or not. In case of diet, the second thing I want to reduce, across organization, we are going with less oil, less salt, less sugar. These things already Indian government has, now this year they have in the project pipeline, they are going to tell across less oil, less salt, less sugar across canteens, and that is depend upon what is the consumption of raw material in the start in the year and what is the last raw material used in a year. And last year, one of my site, Nagarjuna site, they have done a wonderful job. The raw material drastically reduced, reducing the cost. And sugar, no sugar at all. One of my canteens, which union was there, strong union, and they were taking the sugar in the chai and coffee. We have spoke to them, make okay, we will keep sugar separately, whether you want to take 1 teaspoon, 2 teaspoon, up to you. But keep it sugar separate. They agreed for that. So that's the thing. What happened? Can I have next slide, please? Next. Yes. And something we implemented, my thali concept in some canteens, which is having a good thali, and yeah. This I already talked to you. Third and most important, post-COVID study has published, sudden cardiac death, some reasons is improper sleep. Good quality sleep of 6 to 7 is mandatory. Please, after 10 p.m., even Mukesh Bhai has told in one family meeting, I have no worry about geo losses, but after 10 p.m., please stop your social media. and WhatsApp University. Until unless only emergency calls are there, that is important, but after 10 p.m., no use need of social medias. So that's the important thing. So sleep is one of the important factor, keep in mind. Now, this is the slide. See, the mental health. I still have one story to tell you. Before 7-8 months, one young girl came to RCP Geo. She was having some training. She went back to Ratlam. Next day, I got a call 8 o'clock. She had a suicide at home. I got surprised. She was last week in the RCP training. She has not told anyone what is happening with her. So that is the thing. Mental health issues are there where gradually we have to understand, where manager has to understand what is the problems is going on. So you can have an anxiety, but at workplace still sound confident. Okay? Like me, I'm having anxiety inside, but I'm confident while talking to you. You can have a depression, but still smile and make jokes. You can feel suicidal, but still turn to work on every day. The whole scenario, global changes are taking place, and mental health is one of the things. So one, managers, they have to be sensitized. What are the mental health symptoms? Either somebody is very active, is totally withdrawn, not doing anything, or mood swings, changing in the mood swings, or having a loss of interest totally, no interest. Physical symptom, unexplained symptoms, having a poor sleep patterns, cognitive symptoms, worrying thoughts and other things, behavioral changes, taking some drugs, taking smoking and other things. So these changes takes place. So now before raising your hands, one thing is very particular, smoking. So whoever are smoking, please stop smoking today. I don't want you remember me after 10 to 15 years, because somebody has told me before 10 years, and where I will be, I don't know. So better to stop smoking today itself. Smoking is the most dangerous. Smoking and tobacco. Yesterday, Dr. Anil Dikru's slides also showed same thing. Tobacco and smoking in any form is most dangerous. So that is the first thing where all the industries and everyone has to think over it. So mental health, okay, we have a 24/7 call center where we can call and other things. Emotional health, this is the one of the important thing. Emotional health basically have a positive aspect, but basically it's a family which they have to take care. It is a family, it is the friends. They are more important, and L1, the manager has to understand. He has to listen to their subordinates if they are facing anything. If listening to 50 to 60 minutes, roughly around giving a counseling, solve most of the things. Social health, yes. Job is not only important. Apart from job, one has to some other hobbies, and occupational health, IOH is some of the hobbies. Some enjoys in this apart from the job. Like me, I enjoy in IOH. So Kamath also enjoys in the IOH too much. So you have some hobbies separately where you can enjoy. You can have a passion for that. Yes, yoga and meditation should be there in the usual practice. And meditation, daily 7 to 10 minutes, make a habit of meditating. That we have a structured monthly programs. Every month is given for some time, and every month is given for some awareness. This is the things which we have started in last 6 to 7 months. Diabetes control mission. We have those who are HbA1c level more than 8, we have a scientific approach like continuous blood glucose monitor application, then physician opinion, then psychologist opinion, then wellness specialist opinion, and then dietitian opinion and physiotherapist. Combining all, we are thinking in next 3 months to 4 months, they should come under the control things. So that's our team is doing, and my team is there. Those who want some details, they can connect with my team. Yes. Recently, before 4-5 months, seeing all these things, we have started hypertension control management across organization, focusing only uncontrolled hypertension to take care of them very well in a systematic way across organization. Hello, next please. Yes. There are some businesses doing, but they are doing something like Jio has taken a Jio Fit HR challenges, something like retail has taken a different way. So everyone is taking something how to take these fitness challenges. Next please. I already told you NABH accreditation is going on next for quality accreditation. Yes, our journey is that which young occupational physician from 96 onwards, but this year now we are focusing more on what I had told you, non-communicable diseases, and second mental health, NABH accreditation, and most important is artificial intelligence in healthcare and predictive analysis. That is one of the important thing which is coming up very well. And next please. Yes, some of the awards which are received for across globe. We have received last year Arogya World Hall of Fame Award, first time in India for our functions, and Reliance, okay, well known in everywhere, that's the thing. Next. This is the most important slide, last slide. I'm here for all of you, and your health is most important, nothing else. So for your health, keep in mind, you own your own health, nobody else. That is number one. And when you own your health, I tell them to get a health checkup done every year. That is the mandatory. Health checkup is important every year. That is mandatory. Somebody was talking about PSA yesterday. All the health checkups which we are aware, we should be, those who are doing above 40 should have a PSA. At least early detection of cancer is the one of the thing. And lifestyle, which I talked to you, most important is vaccination. You may be aware of childhood vaccination, but IOH already published a book, and we are having adult vaccination. And the 3 adult vaccination important. One is pneumococcal vaccine, second is shingles vaccine, and third is flu vaccine every year to prevent from that. These 3 vaccines are important. Emotional health, I talked to you, and last was the happiness. Don't worry. Happiness, if you are happy, you can keep others happy. To keep that thing in the mind. Happiness is the most important. This last slide, you can't believe, 15 days ago I was in the Chennai, that side corner is showing my business head of state working on the laptop standing down. And he told me clearly, Rajesh, I don't depend upon my company to give all these things. This small stand, I purchased it. Working on the laptops, now on the standing has started. You can't believe on that, most of them now working on that. And basically, understand that movement is medicine now. Walk, whatever time you get, whenever you can move, move. Without movement is not possible for all of you. Next. Yes. I'm here for something to tell you about. I'm using my 30 minutes for this also. I hope organizer permit me talk to about ICO. We are organizing International Congress on Occupational Health in 2027. And after 10 years of continuous working hard, of 2 times another thing, we got it. This is going to be organized in Mumbai at Jio World Convention Center, February 2027. Why I'm talking to you, registration is going to start in November, December. That is number one. Second thing, it is mostly scientific. I was just thinking of that. In Europe, whenever you go abroad, we take the breakfast at 7 o'clock and we join sessions from 8 o'clock. There is no other work, nothing. In India, it happens, the second day hall is half. In other countries, if you go Congress, morning 8 to evening 5 is learning, learning, learning. And ICO Congress will be only scientific driven. It is going to be scientific driven. To 2027, and maybe the registration charges will be high, roughly around something is coming up, approximately maybe 50,000, to start saving the money for that. Start saving the money for that. Because that Congress, we have a lot of expenditure, something 20 crores. And we want a big support also for that. So those who are various sponsor hospitals, if they want international exposure, start thinking for that. 2027 January. The second, my announcement sitting here, yesterday in Gujcon, some good papers were saying, so whoever the best 2 papers comes out, and I think so Divyang is a scientific committee member, and Nikunj, whoever the 2 best paper comes out, they apply for the ICO paper. If they got shortlisted by ICO to make a presentation that, on Jamnagar behalf branch, I am announcing that their registration charges at least we will support 25% if their paper is selected in ICO. The second announcement is those who are coming to Jamnagar into next year for paper presentation, and those top paper 10, including students, including those who students are the top paper 10 get the same thing if their paper is selected in ICO. And the same time, my request is when your paper selected, before paper selected, become an ICO member, because by becoming an ICO member you are paying only 3,000, but you are getting saving of 10,000. Your registration will come down. You are going to save $100 US. So one thing is that get the paper shortlisted, get the ICO presentation. So that is the support we are going to provide you for that thing. So with this, I hope you all support for the ICO. But before going to finally, I have something to say for Surat and for all of you, and especially conference organizing chairman and organizing secretary. दोस्त वो है जो हमें हंसाते हैं, दोस्त वो है जो हमें सिखाते हैं, जो मैंने सीखा है सब आप लोगों से सीखा है। दोस्त वो है जो साथ निभाते हैं, दोस्त वो है जो जीना सिखाते हैं, जो जीना सिखाते हैं। दोस्त वो है जो जिंदगी जीने की वजह बन जाते हैं, आप सब। दोस्त वो है जो तन्हाई को मिटाते हैं, दोस्त वो जो है तन्हाई को मिटाते हैं। दोस्त वो जो हैं एक दूसरे पर जान लुटाते हैं, दोस्त वो जो हैं हर वक्त एक नई सुबह बनकर आते हैं, दोस्त वो हैं जो हर वक्त एक नई सुबह बनकर आते हैं, और दोस्त वो हैं जो हमारी ज़िंदगी की वजह बन जाते हैं। दोस्त वो हैं जो हमारी ज़िंदगी की वजह बन जाते हैं। अगले साल हम मिलेंगे जामनगर में। ओके फ्रेंड्स।
Hello. It's a wonderful presentation you all has witnessed, and the formal way to conclude about the very few take-home messages which Dr. Rajesh has very nicely elaborated. Yes, he shared something about the early reporting of the symptoms. See, at Occupational Health Center, and whatever we are doing at first aid point of view when the patient comes to us, that early reporting of the symptoms, whether it is clinical or from the mental health perspectives, we should take care of that. Secondly, on nutrition front, we have to involve ourselves at the ground level from where the food is prepared. Like the way Dr. Rajesh has presented about the trim the trio, that is less salt, less sugar, less oil. That how we are involved and how we can take this message forward to take care of the nutrition part from that involving ourselves from the Newton or the canteen level. So that is one. And yes, from reactive to proactive approach. See, this is very important. We have the data available with us when we are managing the cases for pre-employment, periodic. So we know who are high risk, who are medium risk. So we have to, it had to be target-based approach. And that is the point when it comes from reactive to proactive approach. And lastly, the importance of sleep and some of the programs which at Reliance we are sustaining the long term, the CASHI, and the involvement of the occupational health physician at all the aspects plays a very crucial and important role in overall well-being of our employees and all stakeholders. So with that note, Since it's an oration, so we cannot take questions. But thank you, sir, for the wonderful presentation.
I would request both our chairperson and Rajesh sir to please join us at the center stage.
Got it. मेरे को मिल चुका है.
As a speaker. Yeah, for a Soch oration, I would request our esteemed chairperson, Aditya sir, Dr. Paul sir, to do the honors. Can we have a huge round of applause for our Rajesh sir for the wonderful presentation.
Thank you. Arey, wow. Thank you. Good. Good. If anyone have any question, they can send me a email r.rajesh@ril.com. I will answer that.
Thank you, Rajesh sir. Yeah, I would request Dr. Parmar sir, Yashwant Parmar sir, to please join us on stage, and both our chairpersons. A token of love from Iaoh Surat, Gujcon 25 for the valuable contribution. Can we have a huge round of applause? And can we have a group photo? Dr. Rajesh sir, Dr. Shubham sir, Dr. Parmar sir, Dr. Paul sir, and Dr. Aditya sir.
Good. Thank you. Good, Paul.
Thank you. Thank you, sir. Okay, so next.
Yes.
For the next session, I would request as a chairperson, thank you, Rajesh sir, Dr. Kirti ma'am, Dr. Kirti Chudasma ma'am, and Dr. Balwant Gadhvi sir to join us on stage. And next presenter, we have Dr. Jenny Gandhi to join us on stage, consultant vascular and interventional radiologist. Okay. Can we have Dr. Amit Patel sir to please join us on stage?
So good morning, everyone. Today I'm going to speak about the neurovascular intervention. So the term appears little new, but the disease is very common. Like much is said about today morning when I heard about the heart attack, aortic dissection, cardiovascular health, but very less said about the neurovascular health, and even the awareness is even little less. So today I am going to throw some light about the neurovascular intervention that covers hemiplegia. In a common language, we are all known about the LACWA. When the stroke word comes or any neurovascular disease comes, like there is a hemorrhage in the brain or there is a ischemic stroke, we all get scared. There is one myth in the mind that it's a deadly disease. Either patient will die, and even if he survives, then there will be lot of morbidity. Patient will always be bedridden. Patient will never stand up from the bed, and he or she will not able to lead a normal life. But that's completely wrong. Now the medicine and the science and the research has changed so much. In past 20 years, that even the deadly disease of brain, like a brain aneurysm which leads to hemorrhage in the brain, or ischemic stroke which leads to lakwa or paralysis of the body, we can treat it, we can reverse the effect of a stroke and hemorrhage if the disease is being treated timely and appropriately by a specialist. So today I'm going to take some topic, so I have chosen a name, neurovascular intervention. It's a future of neurovascular disease. In next 10 years, in India, this neurovascular intervention is completely going to change the landmark of neurovascular treatment. So what all are the diseases which we treat by a neurovascular intervention? So it is a stroke. The treatment is mechanical thrombectomy, like yesterday Dr. Manoj Satyavani sir said, that it's a collaborative work with a neurologist and neurovascular interventionist. Second, the critical stenosis, like how we get a heart attack. But before heart attack, there are some warning signs like a chest pain, acidity, the scapular. Just Dr. Rajesh sir said that there are some other uncommon signs and symptoms of heart attack. Similarly, the brain also shows signs and symptoms of major stroke before it comes. There are some warning signs like dizziness, vertigo, reduced vision for a fraction of a second, or like a temporary weakness or numbness in a hand or arm, speech difficulty. So these are the warning signs. When we diagnose it by a health checkup or consulting an appropriate doctor, then we can completely prevent the major stroke, and I will show it in subsequent slide. Then the brain aneurysms, which leads to brain hemorrhage and paralysis. And the third entity, which is little less common for a common man, but it's a brain or spinal AVM, which can also lead to vertigo or a hemorrhage in the brain. But all of this disease we nowadays treat without opening the skull, without needing a open surgery that is done by a neurosurgeon. So this all major complex surgery we do with a small needle in the groin through a common femoral artery, like how cardiologists treat the coronary interventions through radial artery. So we similarly does it without opening the skull. It's a advanced vascular treatment which is done in a cath lab. So stroke, first we will come for the stroke. So the treatment which is done for the stroke is a mechanical thrombectomy. So now there may be a question that whether if we have a stroke, we should go to a neurologist or a neurointerventionist. So the neurologist and neurointerventionists work very closely, collaboratively. It's a teamwork. Whenever there is a stroke, the patient should go to a stroke-equipped hospital which has a neurologist, neurointerventionist, and neurosurgeon, along with the emergency department, the full-time 24 hours radiology service. So whenever there is a stroke, any patient comes with a stroke, immediately CT or MRI has to be done. And in CT or MR, the doctor has to differentiate whether it's a ischemic stroke, that is because of a blockage of a blood vessel, or it's a hemorrhagic stroke because the symptoms are same. So when the US has released a guideline in 2018, and there is a surveillance which says that 87% of the stroke is ischemic, that is due to blockage of one of the major or minor blood vessels of the brain or the neck. And the remaining 13% are the hemorrhagic stroke. So we can treat both this ischemic and hemorrhagic stroke by a neurovascular intervention. So when patient lands up in emergency with ischemic or hemorrhagic stroke, immediately CT scan is done. CT is the most sensitive modality to diagnose whether it's a ischemic or hemorrhagic stroke. Once this diagnosis is being done that it's a stroke, then we do angiography of the brain vessels and we come to a diagnosis. Suppose if it's a ischemic stroke, then we need to differentiate whether it's a major vessel occlusion or the minor vessel occlusion. If it's a minor vessel occlusion, then neurologists will give a small injection which is called the IV thrombolysis in first 4.5 hours. But if there is a major vessel occlusion, then along with neurologists and IV thrombolysis, neurologists will require a neurointerventionist which will diagnose a major vessel occlusion in the brain, and we can treat it by a mechanical thrombectomy. So like I said, how do we treat it? We take a small catheter through groin through a common femoral artery. We go in the brain where the vessel is occluded, and we take the clot out, which is seen now in this video. We go in a very small vessel like here through a catheter and wire. It is called a stent retriever and suction aspiration. We reach up to the clot and we just retrieve it. The procedure is called mechanical thrombectomy. If this procedure is done in first 24 hours of the stroke, we can reverse or reduce the effect of stroke, and patient can lead a normal life. So this is a suction catheter, which is taking out the clot completely. Once the clot is taken out completely, the blood vessels gets open and the recirculation of the brain gets started. Hence, we can prevent the damage of the neurons. So this is one patient treated 1 year back. 16-year-old kid, on the day of his birthday, he had acute stroke. He was cutting the cake. At that time, he just got collapsed. The parents brought him to the neurology hospital. I got a call at night, 11 o'clock, that there is a kid with a major vessel occlusion. We treated with a mechanical thrombectomy, like you can see here. There is a major vessel occlusion. There is a complete cutoff of an artery. We treated with a mechanical thrombectomy. There is a complete re-establishment of the blood vessel, which was not seen previously. And this is the clot which we retrieved. And this is the kid at 3 months. He was in a 10th standard, 16-year-old kid. And he appeared for his 10th board exam, and he could clear with a flying scores. You can see that patient is completely normal. The kid is normal. We could save his life because of this mechanical thrombectomy, which was done within 4.5 hours of the onset of stroke. So we'll move to the next slide. This is one patient dissection of a carotid artery. Like, we have a habit that whenever we have some spasm in the neck or headache, we go to a salon and have different type of massages of the neck, which is very deadly. Never go to a salon or parlor or any therapist which gives a massages of the neck, because it can lead to a vertebral artery dissection or a carotid artery dissection. Similarly, very well-renowned gynecologist of our town, in his 40s, he had a headache for past couple of days. He went to a salon and had a massage, and he landed up in an acute stroke. He had a dissection of a carotid artery, and there was a stroke. We could diagnose it at appropriate time. So you can see this is a MRI diffusion images, and there is a hyperintensity. Here, the neck artery was completely dissected. There was no flow in the brain. Similarly, on the left side, there was no flow. And we treated at midnight in emergency. We could treat the dissection as well as we could retrieve the clot. And we could save the patient. Right now, he has started his practice again. This is in the initial 15 days. We could save his life. And this is the brain. We could completely re-establish the circulation. So this is the lateral view, completely normal TK3 flow. So like I said, whether we can prevent this stroke, yes, we can. There are warning signs like reduced vision, transient blurring of vision, dizziness, vertigo, transient speech difficulty, drooping of mouth, hand or leg weakness. So whenever there are some warning signs, consult the respective specialist and get done a color Doppler scan, get done a CT angio or MR angiography or DSA, and if there is a stenosis in the carotid or any of the blood vessels of the brain, and if stenosis is more than 70%, then we can treat this stenosis like how we treat a coronary artery stenosis, and we can prevent a heart attack. We can completely prevent the major vessel occlusion in the brain by a stenting. The procedure is called carotid or intracranial stenting. So some case which we treated, left side MCA recurrent stroke, there is a occlusion on the left side of ICA like angiography shows, and we treated with carotid angioplasty stenting. Normally this patient gets discharged in 48 hours. Similar other patient, carotid stenosis with acute stroke. We treated both carotid stenting and mechanical thrombectomy, and we could save the life. Sometimes there is a stenosis on the both side of the neck, both side of the brain. So we can treat both at the interval of 1 week, right, left, simultaneously, and both carotid stenting. Radiation, patient who has a cancer and of head and neck, they received surgery, neoadjuvant chemotherapy, immunotherapy. Along with that, some patient receives radiation, especially the buccal mucosa. So in such patient, the carotid stenosis happens after 8 to 10 years of this radiation. So we can treat even the radiation-induced carotid stenosis, which are symptomatic and which leads to stroke. So these are some, different patients of carotid stenosis, which we have treated. Intracranial stenting. Whenever there is a stroke due to narrowing of the blood vessels in the brain, which are symptomatic, then we can treat similarly with angioplasty and stenting. And all are done without any open surgery. So here you can see one side the artery is completely blocked, other side there is a very tight stenosis, and we accurately treated with angioplasty and stenting, and the patient has become symptoms free. Similarly, stenosis of the brain, and we did intracranial stenting. Basilar artery stenosis, this patient was suffering recurrent posterior circulation stroke and very critical stenosis in one of the critical artery of basilar artery of brainstem, and we treated with angioplasty with just 45 minutes treatment, and it saves life.
Ma'am, 2 minutes only.
Yes. So stroke is treatable, preventable if timely treatment has been done. Now the next topic is brain aneurysm. The aneurysms are the bubble which gets, when there is a hemorrhage in the brain, it's deadly. If appropriately, timely treated, we can completely save the life by treating the aneurysm. Initially, 20 years back, there was a treatment, open surgery and clipping, in which the morbidity was more. Patient was not out of ICU for 10 days, 15 days, and then the recovery will be long, and there is a lifelong scarring. There is a very high chances of infection. So we treat all forms of aneurysm. This is a DACA aneurysm. We did coiling, and the patient was, this is a failed neurosurgical treatment. The clip has slipped from the aneurysm. We treated by coiling. This is a giant aneurysm of ICA. Giant is more than 15 mm, 1.5 centimeter, 2 centimeter. We treated with flow diverter and the coil. And at our center, we are the one who does highest number of this coiling and the neurointervention in entire South Gujarat belt. We treat all forms of simple as well as complex aneurysms and neurointervention. Another patient, right ICA, drooping of eye, and we did flow diverter plus coiling. Similar, another patient, giant aneurysm of ICA, we treat with flow diverter and coiling. Initially, such treatments were available in a tertiary like Mumbai and Delhi, but now, since past 6 years, we treat all these conditions in Surat itself, and we treat highest number every month. The large ICA bifurcation aneurysm, again flow diverter coiling. Blister aneurysms where neurosurgery is just not possible, so we get all these references from a neurosurgeon, and we have treated with a mini flow diverters. And this is patient after 15 days. Like you cannot even recognize this is the patient or the wife is the patient. The patients live so normal life. Age is never a bar. 87-year-old woman with a ruptured brain aneurysm and hemorrhage, and we could discharge her normally after 3 weeks of the incident. Young patient, very deadly aneurysm, dissecting aneurysm of a basilar artery. We put a double flow diverter, and within 48 hours, the kid was normal. We have treated some complex aneurysm with advanced devices like contour, and we are the one who started this treatment in Gujarat. It was the first case in 2021 with a contour device, and it had a media coverage also. the brain AVMs. So this is one case, 6-year-old kid, he had a paraplegia, hemiplegia, because of hemorrhage in the brain. He was not able to lift his one side of the body completely. Like you can see, he is not able to move his left hand and leg. Family is prompting, but he is unable to. So we treated, the cause of the hemorrhage was AVM in the brain. That's a complex disease of the blood vessel. And we treated, and within 3 months, the kid was completely normal. I mean, enjoying his childhood. During the Makar Sankranti, the father sent me this video of flying the kite. Similarly, another 12-year-old kid with a brain AVM and a hemorrhage on MRI, we treated, and within 48 hours, patient is out of ICU and completely normal. Spinal AVF, patient had a complete paraplegia. It was just postpartum lady. There was a complex connection of the blood vessel within the spine. We treated by embolization, and the patient could walk with walker in 6 weeks. This patient has been treated 3 years back, and she's living normal life now. So it's not just the angiographic image. The aim is to treat patient and provide them a normal life. These all patients, I mean, at least more than 2,000 patients are being treated till now in Surat for the neurovascular disease. The results are excellent. So it's a collaborative work with a senior-most neurologist, neurosurgeon of the Surat and us. And we are trying to achieve a world-class center. And in coming next 4 months, we are coming up with a facility for this neurovascular treatment in Surat, where the most advanced machine of Siemens is being installed in Surat, and we are going to take this treatment to another higher level. This machine will be the second in India after AIIMS Delhi. It is nowhere in Gujarat, Rajasthan, Maharashtra, as well as in Madhya Pradesh. So thank you so much.
Gandhi madam, within a stipulated time, you have very nicely explained the radiological intervention, particularly for saving and morbidity and reduce the morbidity and mortality of the neurological disorders. On behalf of this audience, we are thankful to you.
Thank you, sir.
Thank you.
Thank
We
you
can
so
invite
much.
1 or 2 questions, please. Okay. Fine. Okay. Question will be taken during tea times. Thank you, ma'am. Thank you very much.
Thank you so much.
And now I invite Dr. Manu Sharma from Shelby Hospital, an orthopedic surgeon. And he is going to talk on joint replacement and prevention of arthroscopic disease.
Sir, stage is yours.
Hello, good morning everyone. So my topic today is arthritis prevention and role of joint replacement in industrial workforce. Actually my this prevention part I would love to like to talk with you guys, because people are more interested when they are young to prevent this problem, but once they have with age and sometimes with some injuries or because of some inflammatory arthritis, they do get a lot of arthritis, then the only good solution which remains is a joint replacement. So first we will cover, next. Okay, fine. So I'm based out of Shelby Hospitals, and in team with Dr. Vikram Shah, you might have heard his name. He's a very famous joint replacement surgeon. We are partners at Shelby now. So since 12 years I'm with him, and 5,000 joint replacements at Shelby Hospitals, Ahmedabad, and 8,000 done in Surat till date. I might be, I don't know, the youngest in the world to complete 13,000 joint replacement surgeries. I have fellowships, fellows are training under me, and even I'm operating outside India. Even patients from abroad, which usually don't prefer Surat as a medical facility, they are coming now for joint replacements at Surat. So what is arthritis and why do we need all these joint replacements is because the cartilage covering which is there in our joints, that gets damaged and our bones get exposed. So we need to replace that damaged cartilage. And why do we have so much of arthritis? We don't see in other animals or living beings, is because that when we were primates, we used to walk on 4 limbs. Even today, many animals, they are using 4 limbs. We got an erect posture and all our body weight, it went on to 2 legs. And particularly you might ask why only knees? We don't get so much of hip arthritis, we don't get so much of ankle arthritis. Because knee is a very complex joint, it has so much complex movements, even rotational movement, one directional movement, inflection, extension. So there's a lot of movement, there are so many structures inside, the meniscus, the ligaments, ACL, PCL. So much complex joint, and that complexity adds to the injuries and the joints get damaged more. So I sometimes say that God has given us a very faulty design in the knees, because our hips, they are very good, they don't get so much of arthritis, so knee gets arthritis. Osteoarthritis most commonly affects our hands, the terminal interphalangeal joints, the lumbar vertebra, then comes knees and hips, then all others. So what is arthritis? We have a space between our bones, and with the cartilage loss, our bones start touching each other. These are various stages. Initially, there is some decrease in joint space, some later on second stage, more decrease, third stage, the bones start touching each other. Then comes a stage where the bones start rubbing and they put some defects in the bones, and later is a stage of complications. If you understand what happens with us, then initially we have some pain. In second stages, we can't walk without a stick. Then we move on to a walker, and then a stage of wheelchair, then we get bedridden. So how to prevent this? Completely preventing arthritis is not possible. You cannot stop aging. This is aging. But there are certain things which we do. We can at least stop or decrease the progression. Okay, if you have healthy joints, you don't have any problems, you don't need to bother much. But there are certain things like if you keep your weight in check, you have a control over your weight, you do regular exercises. Certain things which should be avoided, like climbing stairs and standing for long durations, can be done if you have that facility. Again, sitting on the floor and squatting is not a very good thing for knees. So if it can be avoided, we should avoid it. Walking is excellent for knees, and swimming, cycling are very good exercises. They don't put weight on your knees. So if you want to be fit, if your knees are troubling, you can go for swimming and cycling. If you are doing jogging, running, giving impact to the knees, that can be a little harmful if you have knee problems. Why this arthritis is more common nowadays is because our accessories have become thin and we have become thick. Lifestyles should be avoided, like junk food, alcohol drinking too much, and sitting idly. Junk food again, even did not spare the animals. One thing this is important I need to discuss, and we do ignore our knee injuries a lot. Whenever we get up at home, our knee usually gets impacted every time we hit our knees with table corners and all those things. We fell down, we get injuries, and we usually think it might go away, we ignore it. That should not be done. You should consult a specialist immediately if you have knee injuries, and proper scans. An X-ray will not show anything in 99% of the cases. You need to go for better scans like MRI, and if it shows a particular amount of damage, then a good amount of rest has to be done. If you don't go for investigations, we just rely on X-rays, we won't be taking a proper amount of rest or therapy. So proper investigation by a specialist are very important, because these injuries, they start accumulating and they progress to cause severe amount of arthritis. Early diagnosis of some inflammatory arthritis like gout, rheumatoid arthritis, if we detect them early, we can start medications and then we can stop or at least slow down the process of degeneration. Now, it is about preventing arthritis. If we do happen to get arthritis and we lose our cartilage, what can be done for that? So, initial stages, as I talked, stage 1 or 2, we can have some medications to relieve the problems. There are non-surgical interventions and surgical. We can have some painkillers if they are needed for a small amount of time. Taking too much of painkillers can be detrimental to your kidneys and other body organs. There are some supplements in the joints. They can help you in initial 1 to 2 stage, like glucosamine sulfate, chondroitin sulfate. And you can take some rest, you can take physiotherapy, and some intra-articular injections are also there, like hyaluronic acid. In stage 1, 2, all these will help you. But sometimes we go for physiotherapy and injections. The course of arthritis is like that. You will have some periods of more pain and you will have some periods of less pain. It is not going to pain you in the same extent all the time. So when there's a period, naturally the pain is going to go down, and we do take some physiotherapy, do take some injections. At that time pain decreases, we do give credit to the therapy or injections. But actually, if you don't do anything, the pain will be less for some time and will be more pain for some time. That's a natural course of osteoarthritis. Among the non-surgical part, there's a minimally invasive, minimal intervention called genicular artery embolization. This is a new procedure, and vascular intervention doctors, they are doing it. If you don't need a knee replacement yet and still do have knee pain, that is because of the increased vascularity or increased inflammation in the knee joint. That can be taken care with a small procedure. That's a needle hole procedure called genicular artery embolization that can help you in some cases where you don't need a knee replacement yet. Ultimately, the thing I do, the surgical treatment, there are certain surgical aspects like arthroscopy that can be done, but right now it is being outdated. You should not go for arthroscopy for arthritis. If you have severe cartilage loss, arthroscopy is not going to help you. Second thing, some patients are choosing, because of their young age, they can go for this aligning techniques to change the alignment of the legs. But I do not agree too much, because I have found 9 out of 10 patients still complaining of pain after going this procedure. Now for young patients, we do have a half replacement procedure, which is very definitive, very successful, and that half replacement will give you 10 to 15 years of good quality life. That can be done in place of this procedure. If you do this procedure, you change just the angle, still the arthritic part, this arthritic part is going to remain in the knee and it's going to continue giving you pain. So knee replacement, ultimately you have lost your cartilage and you are having troubles. When is the time to get a knee replacement? This is the question often people ask me, when is the time? So if you have continuous pain, you are daily needing painkillers to carry out your activities, you have deformities, you are not able to do your daily activities, you are not able to walk 4 to 5 kilometers per day, because that walking is important for your overall health. If you are not able to do that, you need a knee replacement. Age is not at all a criteria for knee replacement. I have done knee replacement in a female of about 25 years and up to 90 years. So if you are having all these troubles, you are not able to carry your life, then you need a knee replacement. Currently, half knee replacement can be done. That will last up to 10 to 15 years, and total knee replacements are nowadays with good implants and good surgical skills, they are lasting 25 to 30 years. So you don't need to worry much about that. So if you require a knee replacement, get it done. This is again the same X-ray. I showed you the joint space. Now, as you are doctors in the occupational corporates and other places, Sometimes patients will come to you and ask you, they will show you your x-rays. Doctor Saab, घुटन में दुखे छे, you have pain in the knee, and they show you the x-rays. What do you look at? You look at the joint space, okay? So this is the joint space. You tell them, okay, there is no joint space, so you might need a knee replacement. They do ask you before they come to us. But sometimes it can happen that you have good amount of joint space, and patients completely all the time has pain. He is not responding to therapy, not medications. So can he still have requirement of knee replacement? Yes, because sometimes x-rays are not able to predict completely. This is the same patient I showed you, good x-ray, good joint space. Still you can see there is complete destruction of articular cartilage. I operated this person, and these are, and I'll tell you, till date I have operated almost 500 patients of this sort who have good x-rays. We get an MRI done. The MRI shows there's a complete loss of joint space, some complete loss of cartilage, full thickness loss of cartilage, and that definitely requires a knee replacement. Whether it can be half or total, but it requires. So x-rays alone are not sufficient. Now, you get your deformities corrected. If you have crooked legs, we can correct it with knee replacements. You get a very stable walking. You can have any amount of weight. We have operated up to 150 kgs, and all patients are very successfully walking. They're doing their activities. So you should have a good range of motion. You can fold your leg completely. This is just a video 15 days after surgery. So what is a successful knee replacement? You should have no pain in your knees after a few weeks. You should get your deformities corrected.
Sir, 2 minutes only.
Yep. Okay. So good range of motion. You should not get infection. You can sit on the floor. You can drive two-wheelers, four-wheelers. Important things. Where to get a joint replacement done? You should have a good operation theaters with laminar airflow systems. Surgery should be done with proper spacesuit systems, because infection in a knee replacement is a nightmare. Again, you can see this is again a knee replacement. I don't know where it is being done, but you see, not a very good condition of operation. A good expert surgeon should be there. Just having a fellowship in knee replacement or 3-4 months of experience is not good. You should have at least a good experience in knee replacement, because these kind of fellowships where a surgeon sees surgeons operating, it's like learning swimming by watching. It is not possible. Computer navigation, a new thing has come up, robotic knee replacement. I would like to tell you, there have been so many papers, so many guidelines that robotic knee replacement does not give any advantage over the traditional good surgeon. So it is just a kind of marketing gimmick being used right now. So don't fall prey to robotic knee replacements. Australian Orthopedic Association have given clear-cut guidelines. Please do not claim to the patient that robotic knee replacement has better results. Even there's a Yorkshire knee clinic in UK. They have stopped doing knee replacements by robots because they had no advantage over the traditional ones. So extra cut is there. We have holes in the bones during robotic surgeries that can lead to fractures in future. This is again a wrong placement of implant. I had one case, came from US, wrong placement of implants during knee replacement. It was done by robotic surgery. So just ending my talk with some myths about people feel like knee replacement would last for 5 to 10 years. It is not true. It will last 20 to 25 years at least. You would be able to do cycling. You can sit on the floor. You can drive a bike, or you can drive a car within 15 days. You can do swimming. So you can do swimming within 2 to 3 weeks. Obese patients, they don't need to fear. The results are excellent in obese patients also. Old age patients up to 90 years can be helped. You can do farming within 1 month, and even you can do horse riding. These are all results which we have given in Surat since last 8 years. So you can do all kinds of activities, enjoy your life. Even your workforce, I have operated so many patients in the corporates. They are doing, like this is a nurse. She is easily doing all her activities now. She is from Gujcon, I think. And one of my patients, he used to play tennis. He was also from Gujcon. So he was, he liked to play tennis, but before he could not. Then we did his knee replacement. And now he's again playing his favorite thing in Surat, Gujcon. This is again a teacher from AMNS. She is now currently doing all her work, teaching students, standing for 5 hours. Again a corporate employee, again doing all his works, stair climbing and everything he is able to do. These all patients we have done from all the corporates. And these are again nursing staff from SMC. She is again doing all her work herself. Again, I think some corporate where they are dancing, enjoying their life. I have 2 patients here. They are teachers and they are dancing in corporates. And this is one lady from Airport Authority of India. And she used to stand for a long time. She could not. She got a knee replacement. Now for 24 hours she can do work. And this is again one important thing. I call it magic. She was a teacher and she could not walk few steps. Now with the help of knee replacements, you can see I call it magic because some people say this is not the same lady, this is someone else. Again, one thing last, I am based out of Surat, but I am still operating in Vadodara also since last 1 year. Dr. Kamath, he is aware we had a very nice CME in Vadodara. And these are all patients in Vadodara I am showing you. I am going every week there, and I've done so many operations there also. Recently we operated Mr. Trivedi, Ajay Trivedi ji. He is HR head in GUNL in Vadodara. So knee replacement is a very good option now, but the most important thing is a triad. Good surgeon, good hospital and good implant. They should be there and you have very good results. Thank you very much.
Sharma sir, thank you for elaborating the prevention of arthritis and the corrective measures. Sir, Iaoh is, let me tell you, Iaoh is working very hard across the India to prevent the arthritis and other ergonomical problems in the industrial workforce. But there are many people outside the industrial area, particularly the white collar job offices, they also have the ergonomical issues. And I think we all together needs to address that population as well. But you have rightly said to correct the many problems of joint pain, arthritis, exercise and the reduction of the weight. It is very sad. That is saying in Gujarati, 40 પછી 40 नहीं तो तू क्या 40 नहीं बराबर है. But the obese person if starts jogging for the weight loss, then आसमान से टपके खजूर पे अटके, he will spoil his knees. So everybody has to see their limitations also as well as while programming their exercise. But I am really thankful to you for elaborating it very nicely. Thank you very much.
Thank you very much.
Can we have a huge round of applause for Manu sir? And I would request ma'am to please join. I would request both our chairpersons to felicitate, give a token, a memento to Jenny ma'am and Manu sir. Can we have a huge round of applause for both the presentations? Thank you. I would request Dr. Mili Dodia ma'am and Dr. Rita Singhala ma'am to please join us on stage and give a token of love and appreciation to both our chairpersons, those who have given their valuable time and contribution. Thank you ma'am. I would request both our chairpersons to please join us on the center stage. We have a token of appreciation from Gujcon 25. I would request both our ma'ams to give. Dr. Gadvi sir and Dr. Kirti Chudasma ma'am. Guys, come on, हम लोग ताली तो बजा सकते हैं यार. Come on everybody, show some जोश हो जाए.
Now tea is served there in the pre-conference area, pre-function area. So just 10 minutes we'll have tea and come back in 10 minutes. Then we'll have sessions from HNRF hospital. 2 sessions from HNRF hospital. So cheers for the 3 ladies from Jamnagar. Again, one more clap. And ma'am, Kirti ma'am is the organizing secretary. Organizing chairman or secretary? Secretary, na? Chairman. Organizing chairman for the Gujcon. So she needs all your support, sponsors. Yeah. Gujcon 26. Next year. So she also needs all your support. So please register and use numbers. Thank you. The tea is open. We'll come back in 10 minutes.
Hello.
Thank you.
So once again, I invite all of you for Gujcon 2026. And whoever is not registered yet can register in stall number 18 at present with early bird discount and surprise gift.
He has done his MS DNB Surgical Gastroenterology from MRCS ED and fellowship in liver transplantation from Catholic University of Korea. He has several years of experience in the field of hepatopancreatobiliary surgery and liver transplantation, and he has successfully performed more than 3,000 liver transplantations till date. So, sir, floor is yours. Thank you.
Okay. So, unfortunately for me, in the beginning, I was a little bit shocked at the topic because here I wanted to come and stand up and talk all about how hotshot a surgeon I am and how many transplants I do and what all I end up doing in the theater. But unfortunately, this being Gujcon and related to the IAOH, I thought, why not? Why not talk about liver wellness? You know. Anyway, getting on with the topic, why liver health matters is basically because it is one of the most dynamic and most busy organs in the body. I'm not going to compare it with the heart and the brain, obviously, but it's one of the most neglected, I would say. It's essential for metabolism, detoxification, and digestion, but that metabolism part probably takes about everything in the body, which we don't even realize. More importantly, liver diseases are mostly silent. Till you damage around 70 to 80% of the liver, you probably won't even notice that there's something going wrong. And that's probably the principle why we even do a living donor liver transplant, because the donor ends up donating almost 70% of his liver unscathed. There's no problem at all. He just gets up and lives about his life, no problem, and the liver regenerates in 4 weeks because it's a healthy liver. So this is a principle we use for liver transplantation. But it's also the reason why nobody complains about liver diseases till they are very late in their disease period. Lifestyle and work-related stress also contributes to liver dysfunction. The whole list and gamut of liver functions, I won't ask you to go through it, nor will I. But basically, it involves a lot of
production of nutrient metabolism, basically protein, carbohydrate, and fat. It stores vitamins, it makes minerals, it produces bile as well as clears bilirubin. It removes toxic substances, which is the detoxification and purifying functions of the liver. And it produces most of the products of the clotting cascade in our body. Production of ketone in terms of starvation, which we will allude to a little later on, and also a part of immunity, a major part of immunity in terms of dealing with the infections. Common liver conditions that we'll talk about briefly in this period is the fatty liver disease, becoming more and more common in our country, hepatitis B and C, alcohol-related liver disease, and also cirrhosis, as well as cancer in the advanced stages. So what are the stages of liver damage? This is what we usually see it may be irrespective of the etiological factors, but a healthy liver usually ends up becoming a fatty liver following an onset of any kind of inciting factor, where there's deposit of fat and the liver gets enlarged, what we usually see as hepatomegaly and altered ecotexture on ultrasounds. Liver fibrosis usually then in an advanced stage or a prolonged fat deposition leads to inflammation, which leads to fibrosis. This is a presence of scar tissue in the liver, and this is where majority of the injury occurs. And when this is also not stemmed, then you get scar tissue in the form of cirrhosis, which is irreversible, and this damage is permanent. So when does what causes it? Dyslipidemia, insulin resistance, obesity, type 2 diabetes, and metabolic syndrome. They all lead to lipogenesis, which is enlargement in the number and the size of fat cells in the liver, which gets deposited. This over a prolonged time leads to inflammation, where the body reacts with a cytokine response, and you get the stage of NASH. And this also, when unstemmed, leads to cirrhosis, which is the formation of scar tissue. Now, if you realize, as it depicts, I would like a pointer, if somebody can help me with that. Excuse me, pointer? Anyway, so it is irreversible to the stage of inflammation, but once it crosses inflammation and fibrosis sets in, then it becomes irreversible. And this is regarding all liver diseases, whatever format is the inciting factor. So a very comprehensive, and I must say this is a must read for everybody. This is the guidelines which is set up by in association with the Ministry of Family Health. Yes. So our very own Professor S.K. Sareen is the lead in this, and they've put down guidelines, and this is purely for non-alcoholic fatty liver disease. Now you can imagine if the country is setting out guidelines, what is the extent of the disease perception? It's not a perception, it is the presence in the country, the prevalence. What are the risk factors? And a few of these slides I've taken straight from those operating guidelines itself. So what are the risk factors for NFLD? You can go through the entire, but basically it is sedentary lifestyle, high blood pressure, type 2 diabetes or insulin resistance, abdominal obesity very specifically, and hyperlipidemia or dyslipidemia. Poor nutritional quality, sleep apnea, and genetic factors also contribute, but the rest are significantly much more than these three. Now, what is important is a bidirectional increase or the link in these risk factors. You will notice that each one contributes to the other one also. So it is not that you prevent one and the other one automatically gets removed. Obesity has a 60 to 90% NFLD risk. It also has a strong risk of progression of liver disease. Type 2 diabetes and metabolic syndrome, just take a look at it. 70% and 53% is the prevalence, and it has strong risk to progression as well as progression of the comorbidity from NFLD is also a strong risk factor. So at the primary health care in the PHCs or us at the corporate level in this particular meeting, I would say, what would you do or what would you look for is high-risk individuals which need to be identified. Abdominal obesity, where a waist circumference more than 90 in men and 80 in women. This could be converted to inches, would be somewhere around 35 in women and 40 in men. Overweight and obesity, BMI of 23. Previously, the world over, BMI between about 26 was considered as obese, but now Asian guidelines have been revised, so we've come down to 24 for Asians because they're much shorter as compared to the Caucasians. So diabetes, hypertension, coronary heart disease, dyslipidemia, liver disease, gallstones, cancers, all these are related and all these are risk factors. So you need to start looking out for this when you look at your employees' health conditions or their reports when they come to you. Any patient with abdominal LFT report or a report showing incidental detection of hepatic steatosis on ultrasound, which is available to the patient, should be further evaluated. No exceptions. Family history of diabetes, hypertension, coronary heart disease, liver disease, gallstones, and cancers, they all should be evaluated, because this is coming to a conglomeration of syndromes which we'll be speaking about soon, and that it will make me look like I've encompassed all the talks in the last 2 days for prevention and talking about it. So there's something called a FIB-4 score, which is based on AST, ALT, age, and platelets. It's freely available on the internet, and you have calculators for that. Anything above 2.67 is a high risk. So you have to start categorizing your employees and your patients for stratification of risk factors when they come to a for a FIB-4 score. This is provided you find out that there's some kind of liver disease. So you have low risk, intermediate, and high risk. And the low risk can be on a follow-up. Every 3 years, you need to follow them up. Intermediate risk need further evaluation to see if there's something else associated along with this to rule out other diseases. And high risk should definitely be sent to a tertiary care center where the liver needs to be evaluated as to whether they need to proceed with further medical management and what kind of reversibility still exists for them. So NAFLD with intermediate risk for advanced liver fibrosis, you need to perform a elastography. This could be an ultrasound based or an MR based, and look for low risk or high risk depending on what risk factors they already have in terms of diabetes, dyslipidemia, hypertension, and weight. They need to be either on a follow-up or need to be sent to a liver care center for further evaluation and management. One study that was done in the urban population of Goa, there were some very startling facts. I just got the abstract for you there, but I marked it out in red. So the prevalence of NAFLD was 34.8%, and this is just a random cross-sectional study that they did in the urban population, and that also in a state like Goa. Men obviously were significantly more than women having NAFLD. More than 35 years was directly a high prevalence as compared to less than 35 years. There was a religious bias also, but I don't understand the significance of it as of now, but probably diet related is what I would think about. Higher socioeconomic status, that is the class 1 and 2, look at the difference between them and the lower socioeconomic strata, class 4 and class 5. It is directly double. In fact, 5 is 20%, 4 is just 4%, whereas 1 and 2 is 44 and 48.9%. It is startling. Non-veg diet, classically more as compared to a vegetarian diet. And the prevalence is significantly higher. Look at the significance. The P is 0.0001. People with diabetes having NAFLD. 52% as compared to those without diabetes is just 25%. That's, the red is not seen on a LED screen. Anyway, so this was absolutely startling, and it was a very small study done in Goa. So why I've been talking about all this? Because now NAFLD has been renamed. It's now called as metabolic dysfunction associated steatotic liver disease, which is MASLD. In a few years, you'll stop hearing NAFLD because it's going to be, everyone is going to get on with this term. Why MASLD? Because they found that when they exclude just alcohol and cirrhotics out of this group, everything else comes into one single category of symptom complexes, where you have insulin resistance leading to fat accumulation and other contributory factors like overweight, atherosclerosis or dyslipidemia, high blood sugars, coronary artery disease, all this leading to metabolic dysregulation and then onwards leading to the same subsequent stages of liver disease. What happens with this high fat, genetic factors, glucotoxicity or excessive glucose intake is that there's a lot of cytokine stimulation and cytokine release, and that leads to a lot of free radical release in the body, and then we get the same symptom complex and the same disease process, which is also seen in coronary artery disease, diabetes, and everything else. So it's just to encompass everything and make everything in terms of management, treatment, and screening, it go into a single direction. So everyone coming and talking about their specialty here and then referring to either weight loss or diet and trying to prevent that disease is, in fact, I think is a part of the same disease complex that we need to start looking at. And us as doctors and treating our patients, we need to start seeing them as a part of a bigger complex rather than a one-pointed view as to what they're presenting with. Most diabetic countries, in absolute terms, just look at the figure, 9.6% prevalence, but what is that number? 77 million, and this was only in 2021. So we have had 4 more years to go at it. I don't know what the figure stands at right now. But if you look at it in absolute terms, see China, it was 10.6, but they go to 140. But these are all population, large countries with large populations, and so the prevalence of these diseases is massive. The figure on the right, if you look at India, it's in the center and it's in the orange. I don't know if you can't see my cursor, but it's in the orange on the third one. The cross-checked one or the checkered one is the...
3 more minutes, sir.
Yeah, is the diabetes which is not even evaluated. The dark orange is the one which is evaluated, but this is the lower middle income group. And if you look at the figure on the right, you have circled the rural Indian population and the urban Indian population, and you'll see the difference is almost 50% increase. It is nearing 10% in the rural India prevalence, and urban India, it's almost 25%. Obesity, we stand at 6% of healthcare related costs. And why I'm saying this? Because it's also prevalent in our younger age group. Childhood obesity already crossing 10%. And where we stand, how few number of countries are above us, please take a look at that. And this is, COVID hasn't done anyone good. You know, this is where childhood obesity took a startling rise, and it's just gone on increasing from there, considering the high calorie food, the number of screens that's available, and the lack of activity that is available, that is present to our children nowadays. Coronary artery disease, you see the heterogeneity in the states across the country. We have the dark range colors, which are the high burden of cardiovascular disease, to the light also. But overall, the disease burden is increasing. You must have realized from the cardiologists and the cardiac surgeons also giving their talks. So metabolic dysfunction associated, they compared what is the all-cause mortality with alcohol-related liver disease along with metabolic dysfunction as compared to anything else. And absolutely startling, if you look at the hazard ratio on the right, you'll see that ALD with metabolic dysfunction is higher as compared to any other cause. All-cause mortality, whether it is pure MSLD, cancer-related disease, or even coronary artery disease, when you look at ALD with metabolic dysfunction, higher death rate as compared to anything else. I think this is the only slide you'll need to see, and probably is a wake-up call for everyone in the country and all the doctors in the country, that this is what we need to be looking at and preventing. Steatosis, fibrosis, cirrhosis, what are the interventions? This is again according to the guidelines. But yes, in the brief, it is what is written in the green. It is increase daily physical activity levels, decrease total sedentary time, and break up the sedentary time. Don't have it in long periods of time. Aerobic or resistance exercises, aiming for at least 150 minutes of exercise in a week, which leads to at least around 20 to 30 minutes a day if you keep it at 7 days. If you decrease it to 5-day weeks for exercise, then it makes it almost around 40 minutes a day. Managing this would start with obviously lifestyle modification, but then targeting individual components of metabolic syndrome, then proceed with pharmacotherapy, and then if you still end up facing patients with end-stage liver disease, then they need to come to a liver center where cirrhotics will eventually end up getting transplanted, or earlier if they have HCC. A very good website which is created by one of my very close friends is fibroliver.com. You can easily go onto it. Just check the questionnaire in there and then fill it up, and you'll know what the risk factors for each individual patient and even the suggested management for them. So workplace risk factors, as I've already stated, sedentary lifestyle, poor dietary habits, excessive alcohol consumption nowadays, and chronic stress and lack of sleep also not given enough importance. Signs of liver dysfunction, we all know: fatigue, weakness, jaundice, abdominal pain or swelling if there's ascites, nausea or loss of appetite, and unexplained weight loss. What is the importance? I already suggested you find liver disease very late because of the reserve of the liver. So the altered liver functions, ultrasound and imaging, when they show that, screening for hepatitis B and C, and prevent irreversible damage through timely intervention. What you do for prevention at workplace is healthier food choices. We all, I'm sure, have a say in in the place we work. We need to ask for liver-friendly options, at least MASLD-friendly options in our cafeterias. We need active breaks, so encourage walking in the workplace as well as standing meetings rather than sitting. Awareness drives, either monthly through health newsletters or awareness ways, and stress management of the employees. What are the management tips? Limit, abstain alcohol intake, maintain healthy body weight, eat a balanced diet, which should be low sugar and low fat. We always focus on the fat. It's low sugar, low carb. Get vaccinated for hepatitis A and B, and regular exercise and sleep. A very poorly known in terms of, besides the addiction, people don't know what it takes to become, have alcohol-related disease disorder. So just 7.4 grams of alcohol per day can be permissible, but it's only half a glass of beer or half a glass of wine. Nobody stops at that. So it's very difficult to permit these kinds. I would say as doctors, please stick to abstinence of alcohol. But just for your information, this is what it is. None of this in terms of one glass, one peg, one pint can maintain limits. They're all beyond limits, whatever the spirit is. So alcohol use disorder defined as consumption of more than 3 standard drinks for men and more
One
than
more
2
minute,
for
sir.
women. Yes. And binge drinking more than 5 standard in men and 4 in women with over a 2-hour period would be called as binge drinking. What would be the diet recommendations? I won't go through that. This is the same which everybody probably knows in terms of healthy diets. But yes, limit added sugar, sugary beverages, because I keep insisting and stressing on the fact that sugar and carbs need to be focused on more, because we're traditionally or culturally, all our diets are very high in carbohydrates, whichever part of the country you are in, whether it's rice, chapati, bajra, roti, fulka, whatever it is, it will consume a lot of carbohydrates. We need to cut down on that if you're talking about any diet control in these. So benefits of physical activity, weight loss and maintenance, improved insulin resistance, reduce the liver fat, cardiovascular health, enhance the metabolic rate, and improves longevity. Already proved there is significant studies which are showing that lengthening of telomeres take place with regular and consistent exercise activity. Hepatitis B and C, very important to be screened at all your health checks. So we need to have vaccination drives. We need to insist for people to complete their vaccination schedules even at home. Screening of the families of affected individuals. Counsel them. It's very important. There should be no social stigma associated. Take appropriate antivirals if you're already experiencing the disease, and regular follow-ups. And obviously refer to a team if they are way beyond in terms of the disease process. Cirrhosis and liver cancer, I'll skip on this, but these are just the indications when patients should be referred to tertiary care centers, because these cannot be managed at local levels. Corporate wellness initiatives, we are happy as a group in Apollo Hospital to tie up with a lot of you all to conduct these drives, conduct these awareness campaigns, on-site wellness workshops, partnership with liver specialists or hospitals, and confidential employee assistance programs is a must. So this is a call to action for all, as you all represent one corporate over here, I'm assuming. Please take note of this and take action. This is my lovely team back home. Thank you so much. I'll be happy to take any questions or later.
Thank you very much, sir, for your insightful presentation on liver wellness. Your session has provided a comprehensive overview on your latest research data and as well as best practices in the field. So thank you very much, sir. Due to time restriction, we are not accommodating right now the questions. If you have any questions, you can meet Dr. Guru Prasad Murthy, sir, Secretary, sir, during the break. Thank you very much, sir.
Thank you.
I am inviting Dr. Navneet Saraiya on dais for his valuable lecture on ERAS of spine, a paradigm shift in result-oriented spine surgery. He has passed his MBBS from BJ Medical College. He has done his MRCS from Edinburgh, FRCS from Glasgow. He completed his NHS orthopedic program and spine fellowship, trained orthopedic spine surgeon. He is British Orthopedic Association designated clinical leader in spine surgery. I welcome him on the dais and ask him to deliver a nice lecture. Thank you, sir.
Thank you very much, Chairman. I'm very grateful for a very generous introduction. I am Dr. Navneet Saraiya. I provide my services to Apollo Hospital Group and Ahmedabad unit as a consultant spine surgeon. And today, I've taken this opportunity to bring you up to date in a way with the world of spine surgery as we are now. It is one of the most rapidly advancing orthopedic surgical specialties since the turn of the decade. And so many advances are happening so quickly that it's difficult for the general population as well as the doctors even sometimes to keep in touch. So what I'm going to bring today is a management perspective of a surgical spine patient. This is an attempt to bust a few myths as well as have a holistic idea around spine surgery as we have been practicing both in the Western world where I've trained and worked, as well as then bring it down to our Indian practices. So just going back, ERAS. We all know what ERAS is. I'll just quickly elaborate. Enhanced Recovery After Surgery is a global term. It applies to all major surgeries. However, in the last 10 to 15 years, it's been very successfully incorporated into spine surgery with a view to improve the results. So it's a result-oriented approach to managing a spine patient perioperatively so that the results can be achieved in a more predictable and a better way. So, as I said, we are heralding a new era of spine surgery. A lot of advances are happening in technology. We all have heard about endoscopic spine surgery. We have all heard about navigation, expandable cages, new implants coming in. They have got their own advantages in individual patients as they are selected for surgery. As well as that, there are various skill advancements. Up until the turn of the century, it was just posterior open surgery or anterior open surgery that spine went through and had varied results depending upon the surgeons and the unit's experience as well as their expertise. This has to be viewed in the perspective of a spine patient as a whole. A spine patient undergoes different kind of stresses to any other major surgical patient. And the most important thing is majority of the spine surgery is prone surgery. It puts different kind of metabolic demands on a patient. Because of the compression of the abdomen, a lot of venous pooling happens in the periphery, in the brain, in the spinal cord itself, and that has to be taken care of. And majority of the spine surgery nowadays is hypotensive surgery, which again has drawbacks, the side effects on the spinal cord system physiology as well. So this was quite poorly understood up until the turn of the century. So this has led to a new approach towards the physiology of a spine patient during the surgery. These surgeries are usually long duration. The vertebral anatomy is unusual. It's not a long bone, it's not really accessible, it's an irregular bone. To instrument that needs a special kind of skill, which is the reason why the technology has developed, and also the fact that average age of a spine patient is above 60 with the inherent comorbidities. So, considering both of these factors, in general, what determines success of any spine surgery is first and foremost of a rule that underlines every major surgery is an accurate diagnosis. Now, there are much more number of factors involved in making a diagnosis in spine surgery as compared to orthopedics or general surgery. Also, it has to be a complete diagnosis. If you miss one particular aspect and that's ignored in your treatment, we will not get a good result. Time is also important. Majority of the spine patients that we see here come with a phobia. Sir, spine surgery nathi karavi, beek lage chhe, paralyzed thai jaish. This is the phobia that has been prevailing for the last 50 years and has kept going on. What that leads to is that the patient delays surgery till they can't get out of bed, and by the time the clock has turned so far that it can't be turned back. And then the amount of effort required, the complexity of the surgery required is so much that it becomes a very high risk-benefit ratio for the patient. So timely surgery, again, makes a big difference when it comes to bringing good results to spine surgery. Pre-op physiology optimization is general with every major surgery. Intraoperative anesthetic requirement. So GA, because it's a long GA, it has demands on the brain and spinal cord physiology. We have tried to reduce the duration as well as the quality of the anesthesia that is provided to the patient with startlingly good results. And that is then now been incorporated into the ERAS system, which has led to consistently good results. Post-op day one after spine surgery is extremely, extremely important. This has been again ignored. Surgery ho gayi, theek hai. Nurses ko post-op instructions bhej diye, physio ko instructions bhej diye, that's the end of the story. No, that first day post-op management sometimes is the make or break for the complete recovery of the patient. Historically, post-surgery, bed rest for a month, bed rest for 6 weeks. That is now almost considered criminal when it comes to a successful rehabilitation of a post-op spine surgery patient. And obviously, the rehabilitation in a dedicated way goes a long way in bringing good results. So these are the important determinants which decide how good a successful surgery that you're going to provide the patient. So ERAS of spine is an extremely important rung. It's a rung, I say. It's a part of the surgical ladder. Surgery itself is only 10% of spine patient management. And of that surgery, around the surgery, the ERAS then tightens up the bundle very nicely for the patient, for them to go ahead and then have a successful recovery. So in a lot of cases, we have realized that it is the actual perioperative management which has decided the eventual success. 2 weeks after any spine surgery are extremely important, particularly if you're looking at cord compression or significantly complex spine surgery. You are going to get 80% of your recovery potential achieved within the first 2 weeks. And if this is not managed appropriately, then you have missed the boat. Then you're only left with the rest of the 20%, which can be achieved somewhere between 2 months to going up to 2 years. So the first 2-week management of any post-op spine patient has now been determined as a golden time. Therefore, the myopic view of just doing the surgery and let the body recover is almost as outdated as firing with a 303 gun. You know, we are now in quite a modern era, and compassing the entire holistic physiological approach towards perioperative management is the determinant of successful surgery, and why we will look at in the next few slides. So just to elaborate on what ERAS, the principles, the foundation of what ERAS is, that it is a evidence-based multidisciplinary approach. So it's not just the surgeon who takes the lead. He has to have a team which is geared to take care of majority of the perioperative aspects of the patient's physiology. So that's the most important word here. Yeah? If a surgeon ignores the patient physiology, he's bound to have a failed surgery. So the approach which was originated in the West, incorporated successfully, works in all the settings, because human beings are eventually human beings everywhere. And we'll prove that in our discussion later on. Functional recovery is what it aims at. It doesn't aim at pain relief. Yes, it is an important part, but what this ERAS aims is towards the functional recovery, getting the patient back into the society, reducing the time lost to disease. That is one of the main objectives of ERAS. So let's just go straight to the results. This is a study that we were involved in Salford when we were working and training, and it's a very important paper in ERAS of complex spine surgery. So these are the number of patients which were treated with a specific protocol. There are 24 components of ERAS before and after surgery that were incorporated into a protocol of treating all the spine patients. And these are the results in front of you. If you look at particularly the surgery complications, the post-operative complications before discharge, and you can see that there was a significant reduction. The p-value is I'm afraid I've typed it incorrectly, but you have to put one more zero in front of the 0.4, 0.2, 0.7, and 0.5. So these are the values which essentially indicate that the complications following surgery and the need to revise any spine surgery following ERAS had significantly reduced up until that point in 2019 when the paper was published in Salford. This is the graphic significant reduction in post-op length of stay before and after the ERAS era, and the 30-day readmission rate. Readmission rate in spine surgery is usually next to a complication or an ineffective rehabilitation post-operatively. So we'll quickly go through what are the components of ERAS here. Requires preoperative preparation, perioperative management, immediately post-op management, and discharge. So these are the only 4 components. We are looking at up until 2 weeks from surgery. And this involves the surgeon, the anesthetist, the ward staff, and physiotherapy. So we at Apollo have dedicated team which looks after all of my ERAS patients, and it's the same team which looks after all of my ERAS patients consistently, so the same quality and same steps in the care are delivered time and again repetitively, so that we get good at it, the patient gets a consistent result. So to start with the preoperative preparation, patient does get a very good counseling, 15 minutes discussing all their phobias, all their discussions, particularly focused on expectation management. What is the patient expecting out of it? And at the end of this consultation, we make sure that there's a clear goal at the end of that surgery. If that goal is not clear, patient goes away very fuzzy, and then that eventually affects their motivation towards rehabilitation in the end. The rest of it is all quite there, but medication-wise, we have realized that these are the factors which really make a big difference in post-op spine recovery. Vitamin D levels are checked at consultation, and they are corrected whenever possible before surgery. We have realized that this has a significant impact on any skeletal surgery recovery post-op. So vitamin D levels, immediately before surgery, carbohydrate loading is done, fluid loading is done, and we also provide neuromodulators when there is a nerve compression. So the nerves are already calm before we perform surgery. Anesthetist does a proper pre-anesthetic assessment, make sure that operating table is set properly, and also plans the analgesia beforehand, whether it's unimodal or multimodal. Intraoperatively, perioperatively, the surgical plan is made with a view that the surgical timing is kept to the least. So this is where all the different modalities, endoscopic, MIS, anterior, oblique, transthoracic, all of those approaches are tied down to get a plan which causes least duration of surgery with the maximum effect. So risk-benefit ratio is reduced. The benefit is increased as much as possible by reducing the anesthetic time. We use early reversal and the least use of GA by using local anesthesia so that the pain levels are low post-operatively as quickly as the reversal can allow. And post-operatively, majority of the lumbar spine patients get a diclofenac suppository, which then reduces their requirement for IV and other parenteral type of analgesia. So we have got a complete comprehensive protocol sorted out for all of these patients, which falls under the category of ERAS. And we've got a dedicated ERAS anesthetist and a dedicated ERAS physiotherapist who looks after all of these aspects by having a documented standard pathway in place for all of these aspects. Importantly here, I'm stressing as much as I possibly can, early mobilization. After a discectomy.
Sir, conclude karen, 1 minute mein.
Yes, thank you. I'm just about finishing now. So, discectomy patients get up the same day. Fusion or complex surgery patients get the next day. There's no patient, unless they are completely paralyzed, that are not physiotherapized the next day. And that has helped with a lot of aspects, including thromboprophylaxis and reducing the need of thromboprophylaxis as much as possible. Any drains, they get removed early to reduce the risk of infection. Patients don't get catheterized till they have, until the surgery is more than 3 hours duration. And early bowel management. The quicker they open the bowels, the quicker they are up to discharge. So these are the few post-operative, immediately things that we have taken care of to achieve these results that we are now about to publish out of our unit in the next few months. So these are the preliminary, these are probably the first reports of the ERAS results that I'm giving you out here for 2 different categories of our surgeries. So we've got microdiscectomy, which is one of the commonest surgeries that we do for spine surgery. And if you look at the average length of stay for ERAS patients, it's almost half, as you can see. Mind you, the length of stay is before admission before surgery to after. So you reduce 1 day out of this. Patients get admitted the day before surgery to have all of these surgeries. So actual length after surgery in microdiscectomy is about 1 to 1.5 days. And for fusion level surgeries is about 2.5 to 3 days. As compared to And these are concomitant non-ERAS patients, and you can see the length of stays in majority of the cases at least 50% more than ERAS patients. Now that tells us a lot about how quickly these patients are not, we're not pushing them out, they're ready for discharge, but they're ready for discharge in a way that they can carry out those activities at home that we have achieved at the hospital. And this is all possible through this comprehensive ERAS program that is not only here for today, it is being implemented in all the different aspects of surgery, simple or complex, in spines, as we are doing now, incorporating that with the advances that the technology and the skill improvement provides us in the form of endoscopy, MIS, navigation, that we all have access to wherever complex spine surgery is performed. So with that, and with that last slide, I'll thank you again for being a very patient audience, and we'll be open for questions now. Thank you.
धन्यवाद नितिन सरवैया सर। रीढ़ की हड्डी पर एक बहुत ही अच्छा हमें संभाषण सुनाने के लिए उम्मीद करते हैं कि आपका दिन शुभ हो।
Thank you very much. Thank you.
Thank you so much, sir. I would request Shetty sir and Saraiya sir, Dr. sir, to please join us on stage. And I would request both our chairpersons to give a memento to our presenters. Guys, can we have a huge round of applause for both the speakers over here, Dr. Shetty sir and Dr. Saraiya sir. And I would request Dr. Mishra sir and Dr. Tejas sir to give a memento on behalf of Gujcon 25 at Daman, hosted by IAOH Surat. Guys, come on, you can clap better. And on behalf of committee, I would request Jain sir to please join us on stage to felicitate a token of appreciation to both our chairpersons and give a token of love. Both our chairpersons, Dr. Mishra sir, Dr. Tejas Vashi sir, to please be on stage, as I would request Jain sir to give a token of appreciation. Thank you so much, sir. Thank you to the dignitaries. Thank you, sir. Thank you, Jain, sir. Okay, moving to the next segment, guys. An exciting one coming. We have Dr. Asutosh Kothari, sir, joining us on stage for the presentation. And as a chairperson, I would request our very own Dr. Rajesh, sir, along with Jyoti Kumar sir, to please join us on stage to be with R. Rajesh sir for this esteemed chair. And I think Asutosh Kothari sir, the subject is innovations in breast cancer surgeries. So Rajesh sir, over to you.
Yeah, good starting the previous sessions, before that Shelby session, Apollo session now, and afterwards there is a KDA session. So good academic feast is going on. So let's, lunch may be delayed little bit. Don't worry about the lunch. Lunch every time we will get it. But get a good academic feast, that is more important. So now, agreed? Very good, that's the thing. Now, you all were aware about the Reliance Foundation HN Hospital is one of the premier quaternary hospital. From there, we are having two eminent persons today. One is Dr. Ashutosh Khatari. Now the topic, I got it changed before 1 hour. I spoke to him. I told him, sir, these are my industrial doctors, and they should be aware early breast cancer detection, how to detect early, and when to send patient to the surgeon. That is more important, and what is the innovations has taken place in the breast surgery. So he's kindly considered in the last half an hour, he prepared all the things. So that's great on his part. And he's the director of breast cancer, oncoplastic and reconstructive surgery, a globally renowned breast cancer, and bring expertise with former head of the Breast Surgery Cancer Institute, London, pioneer of UK's first rapid diagnosis breast care clinic, global mentor educator shaping the future of breast surgery, principal investigator cutting edge, advocate for patient-centered care. One of the most experienced surgeon is post-mastectomy, immediate whole breast reconstruction. Sir, floor is for you.
Thank you so much for the kind invitation, and thank you to the organizers for inviting Reliance to present our clinical expertise. So as the chairperson rightly alluded, I've just changed this half an hour before to make it more appealing for you. So the slides might be a little back and forth, so bear with me. So we're going to focus on early detection. Early detection, and why is early detection important? I think it's very self-explanatory. Early detection is important because it detects cancer early, we treat cancer early, and the outcomes improve. So the earlier we detect any cancer, the better the outcomes. And I think this is a very lovely slide to show your patients or your employees within your organizations, is love your breasts. So L stands for look for anything, lumps, bumps, changes. O is observe your breasts while dressing, if you observe any changes. V is voice your concerns. Don't bottle it inside. Go and talk to your experts or talk to someone in your family, including your GP. And E is talk to your sisters. Talk to your fellow colleagues and explain that I found this lump, this is what I did, and this is why I had a better outcome. So love your breasts is a very important message which we should give all our employees and colleagues. Now, how do we do an examination? You can do your examination while getting dressed once a month, lying down, sitting up. You cover the whole breast in a circular movement starting at the nipple going outwards. You also check under the arms and above the collarbone. And that should be taught to everyone, and also observe your breasts while getting dressed, if there's any change in shape. So these are the signs we're looking for. We're looking for lumps, indentation, skin erosion, redness, any nipple discharge, any new lumps, any vascularity, growing veins, erythema, nipple retraction, breast asymmetry, one breast looking different suddenly from the other breast, and an orange peel appearance or a thickened erythematous skin nodule. So once you see any of these things, we would advise your patients to come to what we have at Reliance. We've started a triple assessment clinic. So in the West, it's a gold standard. All patients that have breast symptoms are referred to a triple assessment clinic. And triple assessment basically means examination by an expert, and then he makes up his mind, or she makes their mind, the clinician makes up their mind on what is the best thing for the patient, and if a biopsy is required, that is done. Now, in the UK, we used to also do touch imprint cytology, which we have now started at Reliance. So before you go home in 2 hours, we'll tell you whether your lump is cancerous or benign. 95% of lumps that are found in the breast are benign. They're not cancerous. So you just need a reassurance. But those 5% will make a difference. And this is why. If you look at the survival rates for breast cancer, if you look at on the right of the screen, you'll see stage 1 and stage 2. Most people don't die of breast cancer, they live. And that's why it's very important that we get them in that period. If you look at where India is, the blue color is the West and the red color is India. So if you look at stage 1 and stage 2, India is way below. And stage 3 and stage 4, which we don't want, we overtake the West. So all this is because we are not breast aware, we are not acting on symptoms early enough, and we're not going to specialist breast clinics. Breast screening, very important. What kind of breast screening should we do? Usually in India, breast cancer happens at an earlier age, 10 years earlier than it happens in the West. So between 50s and 60s as opposed to 60s and 70s. What happens in those breasts? So those breasts are still dense. Dense meaning there's more white. If you go back, there's more white than black. And as I'll show you, cancerous changes are white on a black background are easily seen. So we have this machine which I insisted on buying when I came to Reliance. It's called a 3D tomosynthesis. It's a cheap CT scan of your breast. It's a mammogram. It doesn't give you much more exposure. Your radiation exposure is the same. It takes multiple shots and then uses AI to make one composite image and shows you what the breast looks like. This is the machine. It's within 3.7 seconds, 45% less radiation, and we pick up between 20 and 60. That 65 is a bit of an exaggeration by the manufacturer, but we pick up between 20 and 65% more breast cancers using this method of screening. And this is what I mean. If you look at it on your right, that's what the breast looks like, which is, oh, they've taken it away, okay. On your right, that's the breast, and on the left is the cancer. Now, if you'd gone to a 2D mammogram, that patient would be passed off as normal. But if you get a nice tomosynthesis, you'd pick up that small cancer on your left. And the same thing happens here. If you see, now on your left is the normal breast, 2D, and on the right is the cancer. So this is why it's important to get the right screening for the right age. This is something that we've added. MRI scans are expensive, they're time consuming, there's a lot of demand on MRI scans. So what we do at Reliance is we also do what we call as a contrast enhanced spectral mammogram. We inject an iodine dye and it works exactly like an MRI scan. So these are the images that you get. They look very much like an MRI scan and we know the extent of the disease, any multicentricity and the multifocality. Now let's talk about what do you have to advise your employees. If you look at this slide, it encompasses all the risks, okay? And the main thing here is your lifetime exposure as a woman to estrogen. So the culprit here is estrogen. 70 to 75% of cancers are ER or estrogen receptor positive. And anything that adds to estrogen or uninterrupted estrogen exposure adds to your risk. It's very, very simple. And let's look at how. So we look at what are modifiable risk factors, so what you can actually advise your employees to change, to modify, and what is unmodifiable, but we action them. So if you have a mutation in a gene, BRCA1, BRCA2, PALB2, TP53, CHEK2, you must come to a specialist clinic because you can talk about risk reduction and chemoprevention. If you have a family history, but you're not sure that you have the gene, you must send your patients to a specialist clinic for risk assessment to see whether they qualify for genetic testing and to put in a surveillance program. If you look at the age distribution, the largest risk factor for breast cancer is age. Like I said, the longer you live, for women, it's breast cancer, for men, it's prostate cancer. So that you cannot change. So the problem is people believe after 60, I don't need a mammogram. If you actually look, your risk for breast cancer goes up after you're 60. So on your right is there, age, at 70 it's 1 in 26, at 60 it's 1 in 28. So your risk never stops for breast cancer. And the earlier you pick it up, the more likely you are to stay alive. So let's look at why, and like the previous speaker said, anything that lowers estrogen and reduces fat. Why fat? Because fat produces estrogen. So you add to estrogen, especially in postmenopausal women where the ovaries don't produce enough estrogen. So we know that high levels of estrogen are linked to increased breast cancer. So if you exercise, you get your estrogen levels down. You also improve your immunity. And through improving your immunity, you facilitate DNA repair, you reduce oxidative stress, and you enhance immune surveillance. That means abnormal cells are dealt with by your own body. So exercise 150 minutes a week, again, as Dr. Shetty said, is what we say. And why it's important is because it reduces your fat, improves your immune surveillance. Alcohol, again, every cancer has a relation. Breast cancer is no different. Again, if you look at the risks, it's there. So drinking alcohol every day is not an option. If you're a social drinker, yes. But even if you drink a small amount of alcohol every day, you see the risk keeps on going up, up, and up. What do you eat? You are what you eat. Whether it's liver disease, whether it's diabetes, whether it's blood pressure. It's the same thing goes for cancer. If you eat a diet which is rich in fat, again, and carbohydrates, because you get these glycemic spikes, you are going to put yourself at a risk of breast cancer and other disease. So if you eat diets which have anti-inflammatory and oxidative benefits, such as fruits, vegetables, whole grains, and legumes, you protect yourselves from DNA damage, cell repair happens, and cancer doesn't get a chance to peep in. Again, we come back to the same things: insulin, blood sugar, hyperglycemic spikes. So what is it that your patient should eat? Sorry. These are the things that we would recommend your patients to have. And the benefits are there. They're explained. Why? So things like jamun, which are cheaply available, they have antioxidant properties, and we should be using them. We have jawar wheat, we have chana, we have matar, we have dal, we have all these things that are available, and this is what we should be eating and reducing our risk to breast cancer. Hormonal factors. So these are the two most important things that people ask us. And let's look at how hormonal factors. Remember what I said, your lifetime exposure to estrogen matters. So anything that reduces the lifetime exposure to estrogen, breastfeeding. Breastfeeding reduces your ovarian cycles and interrupts your estrogen exposure. The longer it is, the more beneficial it is. Having your children early. Oral contraceptive pills, very slight increase in the risk. But when you stop it, it reduces your risk to breast cancer after 10 years. Why oral contraceptive pills? Because you're delaying your pregnancy. By delaying your pregnancy, you're adding uninterrupted estrogen stress, increasing your risk to breast cancer. IVF does not increase your risk to breast cancer. It does only during the short period that you're having the injections. So you have to do a mammogram before and after, but nothing else. Radiation exposure, of course, for all of you who have your employees who have radiation exposure, you need to stop that or minimize that to less than 20 millisieverts a year. Now, that's my spiel, and this is where I'm going to come and try and show off about what happens at Reliance. What is new in breast cancer is we now realize that breast cancer is not a single entity. It's not treated by surgery alone. It is a multidisciplinary approach. So biology is king. The techniques are second best. What is important is treating the biology of the cancer. And we've now started understanding the biology of the cancer, and we've approached a less is more. Less meaning do less to the patient, but do more to the cancer. So cure the cancer, but don't harm the patient. And we are advocating more and more lumpectomies. Why? Because survival following lumpectomies is actually better. I'm going to say that again. Survival after a lumpectomy is better than survival after a mastectomy. When I came from the UK in April, all the patients wanted to have a mastectomy because they did not have the proper counseling. Once you give them the percentages and the survival benefits, all the patients converted to a lumpectomy, including 70-year-olds. So it's how you tell them. And a lumpectomy means removing the cancer and a healthy margin of breast tissue around it. So that is a patient who's had a lumpectomy, and you can't tell the difference. This is a patient who's had a lumpectomy, but you've got a 25% chance of a poor result because of poor technique, poor planning. So what we do, and we know that if you have bad cosmesis, it's worse than actually having a mastectomy because it reminds you of the cancer every day that you get ready. And the patients want to move on. They want to become survivors. So if you do a surgery that is properly planned, on your left is a badly done surgery for a tumor in the upper outer quadrant, and on your right is a surgery done in our unit for the upper outer quadrant. So it's called a lateral mammoplasty. The same operation done, but the results are totally different. This is, again, tumor in the lower part of the breast. On your left is a bird's beak deformity that you can see. On the right is a perfect mastopexy. And this woman is 70 years old. So looks do matter. Three cancers in the upper outer part of the breast. So this patient was told to have a mastectomy. And that is the cancer effect. And I did a lateral mammoplasty in this patient. So that is the defect. That is the tumor. And this is how she looks now. So breast conserving surgery, no change in the shape of the breast. And this is done by a technique called oncoplastic breast surgery. This is a round block. So what we do is we deepithelize the skin and access any part of the breast through a circumarular incision. So the incision is just around the areola, and you can take a tumor out from anywhere in the breast. So it's called a round block or a donut mastopexy. Now we've also got another way, which is called tissue replacement. So, or volume displacement, and don't worry about the technical bits. Basically, it means that if the breast doesn't have enough fat or enough volume, I borrow it from somewhere else. And somewhere else means from the women have a fold here and they have a fold here. So I take the fat from there and move it into the breast, and this is how it happens. Yeah, so let me just show you, rather than showing you these animations, let me show you an actual patient. So let's fast forward because I only have a minute left.
Sir, 1 minute more.
Yeah, I know, I'm watching that. So, sorry. Let's go back to this lady. Now, that lady has a tumor here. Now, if I want to put a scar there, she's going to see the scar. And she told me, I don't care what you do, but I don't want to see the scar. So you see she has fat in the lower part of the breast. So what I've done is, sorry. This thing is, yeah. So what we've done is we've taken the incision in the lower part of the breast. I've raised the whole breast up. I've removed the cancer from the back rather than from the front. And then I've used that skin to put and fill the defect there. So you see this woman has had a breast cancer surgery, but you can't see the difference where the scar is. This is someone who had a defect done in another hospital. I won't name the hospital. Came to our hospital, and we used the fat from the side, and that is how she looks now. So this is all oncoplastic breast surgery. This is an implant, again, not important. So this lady had a whole breast reconstruction using the fat from her side. And you can see that's how it looks. And just in the lower part there, there's a skin bit island that I have taken. And the other thing that we need to tell you is, again, this is called a reduction mammoplasty. So you see big tumors, 2 tumors removed. And I'm just going to take 1 more minute. And that's how she looks now. So that's how she looks. So big cancers in the lower part of the breast. And the only other thing we do is we don't do flat mastectomies. So this is what our mastectomies look like. This is a lady who had a bilateral mastectomy in our hospital versus that patient who's had a bilateral mastectomy somewhere else. And that is because we've got this new mesh. I'm the only trained surgeon in India to use this mesh. It's called a tie-loop mesh. It's made of titanium. And again, it's not moving. That's how the mesh looks. We put the implant in. And let's just hurry that up. Implant is put inside. It's not going forward, sorry. Okay. This is how the breast looks after it's done with the mesh. So we can match the droopiness, we can match the perkiness, we can match whatever you want. And the breast moves as well. So if you see, it's not fixed. The breast has movement, so it's natural. And that's my 15 minutes done. Thank you very much for your time.
Thank you, sir. Thank you. Please come here. We are not taking question answer because the paucity of time. We have from HN Hospital afterwards. Rohan is there, marketing guy. You can connect with them. And we have a Surat center also where we have a facilities. Now I'll request Jyoti Kumar to introduce second speaker.
Thank you. Thank you, sir. Thank you, Dr. Ashutosh. Gives me great pleasure to introduce Dr. Vipul Gupta, our next speaker. He is the Director of Neurointervention Surgery at the Sir H.N. Reliance Foundation Hospital and Research Center, Mumbai. A globally renowned neurointerventional expert with over 28 years of experience in stroke and vascular brain disorders. He has treated over 3,000 aneurysms and 950 AV malformations, which is among the highest in the country. Performed more than 6,000 therapeutic interventional procedures. Is a pioneer in cutting-edge treatments. Mechanical thrombectomy for stroke, which involves flow diverters, onyx embolization, 3D imaging, carotid and intracranial stenting. I'm sure he's going to take you through all those one by one. Over to you, Dr. Vipul.
Thanks for the kind introduction. So I'll quickly go over how neurointervention is changing treatment outcomes in stroke. We know stroke is one of the 3 most common causes of death and disability, and most common cause of disability, and sadly, it is increasing in our country at a rapid rate, particularly in the younger population. All right, so So I'll divide my talks into two parts. What difference we are making in hemorrhagic strokes, hemorrhagic stroke in ICH when it's non-hypertensive bleed, particularly by vascular malformation. And my major work has been subarachnoid hemorrhage in diagnosis and management of brain aneurysms. In ischemic stroke, really a revolution has come in acute ischemic stroke. If the patient come in within golden hours, we can actually reverse stroke by reopening the blood vessels, same way has been done in cardiology. And stroke prevention, treating atherosclerotic stenosis by endovascular means. Now coming to the first part, what we really started to do first 25 years back was the carotid artery stenting. Now I want to make a point that most of the coronary stenosis, they manifest by hemodynamic reasons. By carotid artery stenosis, usually is if the plaque ruptures, I wonder whether the pointer is working, plaque ruptures and forms a clot and embolism happens, means that most of the strokes due to carotid stenosis are thromboembolic in nature, not hemodynamic in nature, meaning if there is good collateral flow, even if whatever flow is fine, if the significant stenosis is there, then patient can have repeated strokes. So what are the guidelines say? When it's a symptomatic stenosis, non-invasive, that means Doppler, CTA, MRA shows more than 70% stenosis or DSA shows more than 50%, we should go ahead. Now, it is much more controversial regarding the asymptomatic stenosis. Guidelines say when it's more than 70% and it's a low-risk procedure, personally, medical therapy is really advanced. We'll tend to reserve for more than 80% stenosis, particularly in younger age groups. And there are certain criteria also which we take into account before really thinking about stenting in asymptomatic stenosis. Sorry. So when should it be done? So this should be done within first few days of any symptoms when it's a minor stroke, because high risk of stroke is within first few weeks, particularly first 2 weeks. So if a patient like this, like we are seeing DWI images with small bright spots, when the infarcts are not too big, severe carotid artery stenosis is there, then we go ahead with stenting within first 3 to 5 days. That's regarding as the optimal time after TIA or minor stroke that we should go ahead with revascularization of stenosis. And it has become a very safe procedure. When last analyzed 6 months back, or my consecutive last 350 cases, interestingly, we didn't have any major ischemic stroke. We had one hypoperfusion bleed, one ocular hypoperfusion, vasospasm, and MI. What I want to say, strokes can still happen, but in selected cases, done with good protocol, we are talking about 1% chance or less of any serious complication of this procedure, which is quite amazing. A typical case, this patient lady had a coronary stenting, they had a stroke, what you can see white DWI lesion on the right side, but again was put only on medical therapy, and the second DWI image shows repeat embolism which happened, then the CT angio done which shows the calcified stenosis with severe stenosis as well. So moral of the story, the same thing, medical therapy can fail when there is severe stenosis, number one. Number two, to me, MR angio with contrast enhanced MR angio particularly, or CTA are more accurate than Doppler. I've seen enough number of cases. On basis of Doppler, I don't even go ahead with stenting when patients are referred. I always get CTA or contrast enhanced MRA. Otherwise, MR angiography can really overestimate. Very frequently, I've seen Doppler also overestimating, but if not done in very experienced hands. So this patient, on the left side image, you can see very severe stenosis over there, and the brain hypoperfusion was present. All these cases, we place a filter device. It's like an umbrella with a fine meshwork, and we stented it with improving brain perfusion. And in this case, a small clot, cholesterol deposit actually found in the filter device. So we do all our cases of filter device, but still 99% of cases we don't find any embolism in it. So there are many centers, like I was faculty in All India Institute of Medical Science at Delhi. There even now they do it without filter device, quite safe, but I think in 1 or 2% cases it does make a difference. Just like cardiology, we are beginning to do it through the radial route as well. So in this case, we have gone through the radial route, and then you avoid arch manipulation, severe stenosis we could stent. So summarize, carotid stenting is extremely safe, less than 1% serious complication, but we also do, I can't go into the detail, transcranial Doppler to prevent hyperperfusion, and we are doing that actively at Reliance Foundation Hospital as well. Coming to intracranial stenosis, now around 20-25% of ischemic strokes are intracranial stenosis. And, but those are the ones we don't target straight away by stenting. First attempt is always medical therapy. If medical therapy fails, they have repeated symptoms, or it's very severe stenosis, then only we do stenting in intracranial stenosis, just like a patient like this. This is a basilar artery. This is a young man, smoker, had repeated symptoms in spite of medical therapy. and both the views show severe stenosis. So this is the image which shows a stent has been placed. Now one may wonder what kind of image, this looks like a CT angio-like image. But if you see the axial image, one can see even the perforators into the brainstem. You can't see them on CT angio. So this is something known as vaso-CT. That means that bioprinting lab, like which we have Reliance Foundation Hospital, we can rotate, do an intra-arterial injection and get a CT scan-like image. Only difference being this is very high resolution. Regular CT will have like 0.5 millimeter resolution. This is 0.1 millimeter resolution. And we call this vaso-CT. So we can trace each and every perforator, and that really helps us to judge whether the procedure has been fine, because as you very well understand, in brain, each and every small artery matters a lot. So to summarize about intracranial stenosis, case selection is very important. Even if we do, in this case, we don't rush. We wait for a week. Precision, guided intervention. Sometimes we use drug-eluting balloons in the brain. But still, whatever we may say as interventions, regular lifestyle changes, medical therapy remains very, very important in all these disorders in the longer run. And at the moment, we can do even intracranial stenosis around 2% complication rate. As I said, the holy grail of neurointervention has been acute stroke. I think that's the most feared disease, a paralysis attack, and you're permanently, not only the patient, the family suffers for the lifetime. So what is the principle behind doing intervention in acute stroke is that when the stroke initially happens, what the black area you see is the core. Some part of the brain get damaged, but the green area around it, which is hyperperfused, not functional, but revivable. It is the same concept as cardiology, where they talk about stunned myocardium. But as the time passes by, this black area increases, the core increases, infarct expands with time. So if we intervene in time, we can stop this infarct expansion, and rest of the brain slowly can take over the function, and patient can recover pretty well. So the TPA thrombolysis has been done, but thrombolysis can only be done up to 4.5 hours. And sadly, for major strokes, whenever there's a big clot, big artery blockage, thrombolysis doesn't work very well. So that is where, and these are the worst strokes anyway. And then came mechanical intervention. So as I mentioned, brain, usually it is thromboembolic. That means a thrombus has gone into the brain. So we don't do stenting. We just take out that clot, call it procedure as mechanical thrombectomy. So we take a microcatheter. What you can see, a stent-like device is released, but still attached to a wire. And then this stent sort of sinks into the clot, and we drag out the stent as well as the clot from the body and recanalize. There are many other methods which has come in. That means aspiration method, where there's a aspiration tube to take out the clot, or sometimes we combine aspiration and stent method to take out this clot. So, and these were the trials which came in 2015, which came all thrombectomy trials very strongly positive all over the world, and therefore the guidelines came in. If the patient is well preserved before, major vessel blockage, is not a big infarct, has significant clinical deficit, please go ahead. If TPA can be given, please give it. Initial guidelines were up to 6 hours, but as I told you, they have been expanded to 16 to 24 hours now. But the key remains, and this is the difference it makes, number of good outcomes if we don't do versus if we do. So it's a very dramatically successful procedure in a selected number of patients. But the key remains to do it very, very fast. Like this patient, she was a doctor herself, had a major stroke, went to a local hospital, small infarct on the right side. You can see internal ICA was occluded. She came to us. Here we were prepared. We call it drip and ship. They gave thrombolysis and shifted to our center, and we were prepared for the intervention. ICA blocked, stent retriever placed. We took out the clot. In 15 minutes of arrival, we were able to recanalize. So the time really, really matters in this disorder, and she recovered completely in this patient. Another patient with vertebral basilar block, we did the thrombectomy. In this case, 20% of cases, there is underlying stenosis, so we had to stent at the same time, and patient recovered. Now the guidelines have come, trials have shown that this process is successful up to 16 to 24 hours. That doesn't mean you wait. If you wait, they will become ineligible. But yes, some selected patient in late hours, also we can go ahead with this procedure, like this lady. And nowadays, even at Reliance Foundation, what we are using is AI-based software in CT angio, CT perfusion, MR, which straight away, soon after imaging, in a minute or two, the AI tells us that this patient is eligible for thrombectomy. So this saves a lot of time and improves the accuracy as well. As I told you, majority of my work has been subarachnoid hemorrhage. And so how do we treat these brain aneurysms? Okay, I started treating brain aneurysms in AIMS in 2001. And that's where the whole program was starting. The first biplanar lab of the country was installed at that point in time in AIMS. Still, most of the ruptured aneurysm we do by balloon reconstruction, like this complicated aneurysm, multiple arteries coming out. Even then, we can go ahead, place coils, place the balloon in the normal blood vessel, place coils, enter various part of the aneurysm, and do a reconstruction. So in most of ruptured, still we like to do balloon assisted. This is another patient with very small aneurysm. In such a small aneurysm, also we could go ahead, place a very small 1.5 millimeter coil twisted around. In fact, I had published the first paper in 2008 of coiling techniques of less than 2 millimeter aneurysm in American Journal of Neurointervention. And thereafter it became acceptable that we can coil such small aneurysms. So we placed that coil in the middle image, and patient did quite well. I have a personal experience of more than 3,000 aneurysms, and what we have shown is that procedural rupture rate is less than 1% with a clinical complication rate of 2%, and we have published our outcomes as well in Asian Journal of Neurosurgery, where we showed if patient reaches a reasonable awake condition, then around 85 to 90% patients can go back to their lifestyle. So it's a treatable disorder provided they come on time. So we are getting now very good devices where we can reconstruct very complex aneurysms as well, something known as flow diverter. Regular stent looks like open cell holes. Flow diverter is fine meshwork. When you place in the vessel, it reduces the blood flow, leads to thrombosis, and intima grows over the device to repair it. Like an aneurysm like this was one of the first flow diverters done in North India. We place a flow diverter with some coils, and here you can see on the follow-up on the right side, if you cut out the coils, it looks like a normal blood vessel. So all these complex aneurysms we can treat like a long segment fusiform basilar aneurysm, again a vasosity of a long flow diverter, and you can reconstruct. So these were the difficult aneurysms which we are treating quite with a very reasonable safety nowadays using this device as well. And even in ruptured aneurysm, I have published myself in British Journal of Radiology how by loading of passogural and in blister pseudo aneurysm, we could go ahead with flow diverters pretty safely. Like this patient, all right, so a pseudo aneurysm, we could place a flow diverter, and that's the follow-up. Very small vessels also, we are getting mini flow diverter, 1 millimeter vessels also. This is a posterior inferior cerebellar artery. Young patient with a ruptured dissected artery, we could cross such an artery and in an acute stage, and then place this device with this follow-up and a reconstruction. Complex bifurcation aneurysms, we use stent-assisted coiling. Sometimes they're difficult to because there are two vessels coming out. We overexpand the stent to cover the neck of the aneurysm, and again a vasosity shows how we have placed a stent and coils into a very small aneurysm as well. We are getting cup-like devices nowadays, which you can just place into the aneurysm, and in 20 minutes you can do a brain aneurysm.
Dr. Vipul, you have 2 more minutes, sir.
Yeah, I'm just trying to, there's some issue with the slide changer as well. I'll just finish it off. And here you can see an aneurysm where we got a cup-like device, 15 minutes procedure, and we could reconstruct. The last part is about the AVMs, which are much more complicated disorders. Sometimes we do surgery, radiosurgery, embolization, or we combine these methods as well. But if need be, we can go ahead with curative embolization, like this patient with a deep-seated AVM with a bleed. We do complex 3D imaging, take microcatheter deep into the AVM, and that's the Onyx injection, and we achieved a complete cure in this patient. Sometimes we can go retrograde better into the AVMs through the transvenous route. Like this patient, we went through this long tortuous vein into the base of the AVM and then embolized it, and again we have published this transvenous approach of embolization. My last part, 1 minute, I'm going to take about some new disorders and new treatments which are coming in. A lot of young stroke, we couldn't find a cause, and now we are finding it that there's something known as carotid web. This DSA looks, young patient with a stroke, DSA look normal, but 3D shows a small flap-like thing at a carotid artery origin. Doppler shows that flap. This is known as carotid web. It's an idiopathic thing, and the only treatment is to place a stent, because even medical therapy, they will have repeated strokes. Chronic SDH has been a new revolution. Chronic SDH, now they're finding, is a vascular disease. Small trauma, dural gets vascularized and keeps leaking into the subdural space, and that's how it expands. So what we have discovered, if you embolize the middle meningeal artery, the chronic subdural collections, they regress with time. So like this patient with a chronic subdural collection, we embolized, and it is gone without open surgery. Sinus thrombosis, usually we treat medically, but if need be, same thrombectomy and thrombolysis can be done if the patient can't wait for medical thrombectomy to work. And the last part is intracranial hypertension also. Sometimes we place a stent and get done with it. So I'm very pleased to announce we have got this very advanced biopneumonia lab installed, and which is one of the first few in the country. And happily, we have established this neurovascular intervention unit at Reliance Hospital. And I want to thank you on behalf of my team. Thank you.
Thank you, Dr. Vipul, for elucidating so well, given the paucity of time, and knowing that's such a complex topic. kudos to you and Dr. Ashutosh for elucidating it so well. Thank you so much.
Thanks a lot
With
for the
paucity of
opportunity.
time, we won't take any questions for both the speakers.
Thank you.
Good, thanks. Remain on the stage. What we learned in the breast cancer early diagnosis, so treatment is possible in the stage 1 and the stage 2 as early as possible. In the stroke, it's important thing is door to hospital reaching time. As early as a hospital you can reach, these guys, they can do wonderful. And the hospital always prefer, which is having CT and MRI. At least tertiary and quaternary care. That's the thing we should learn. As the patient early goes, they can do radiological intervention and they can take care. Thanks all of you. Now I hand over the mic to organizers.
Thank you, sir. I would request both the chairpersons to felicitate, give a memento to Dr. Ashutosh sir and Dr. Gupta sir. I would request Rajesh sir and Jyoti sir to please join us on the center stage. Yeah. Can we have a huge round of applause for the lovely combined experience on stage, or all 4 doctors? थैंक यू। और मैं डॉक्टर बीके जैन जी को इनवाइट करूंगा स्टेज पे टू Dr. B.K. Jain, Rajesh sir, I would request you to please be on stage along with Jyoti sir. Dr. B.K. Jain, senior doctor, I would request on behalf of committee कि आप felicitate करें. Yes, Jain sir. दोस्तों एक बार जोरदार तालियां होनी चाहिए. डॉक्टर बीके जैन जी हमारे शुभम जी के फादर है. ही इज़ द फादर ऑफ डॉक्टर शुभम जैन. थैंक यू राजेश सर. थैंक यू ज्योति सर. थैंक यू. सो नेक्स्ट आई वुड रिक्वेस्ट टू चेयर डॉक्टर Jyotirmay Jain sir and Dr. Balwant sir to please join us on stage to chair the next segment. And I would request Dr. Yogesh Kulkarni sir, Surgical Oncology, Head Gynecology Oncology, Robotic Surgeon, MBBS, MD, DNB, KDA Hospital, Mumbai. I would request sir to please join us on stage.
Jai Ma. Thank you organizing committee for giving space. Now we will move the next topic on robotic surgery in gynecological cancer. Our speaker is Dr. Yogesh Kulkarni. He is a surgical oncology head, gynecologic oncology robotic surgeon at Kokilaben Dhirubhai Ambani Hospital, Andheri, Mumbai. Sir, carry on.
Thank you. Thank you, sir, for the kind introduction, and thanks to the organizers for inviting me to be part of this meeting. I know I'm standing between you and the lunch, and I don't want to be the villain here, so I'll try to finish it within time as fast as I can. I think, over past 20-25 years, we have seen evolution in cancer surgery. We have moved on from radical resections to organ preservation wherever possible, feasible, and safe. And we have moved on from open surgery to minimal access surgery. And the whole idea of it to have rapid recovery, less morbidity, improved quality of life without compromising outcomes. So when I was a resident at Tata Memorial Hospital, I think the talk with my seniors would always be how much we are removing, in a cancer. Nowadays, the talk has totally shifted to how much you can actually save. So that's a paradigm shift, in terms of cancer surgery that we are looking at. Gynecology as a specialty has been using minimal access surgery for years, probably the first specialty to use it. All of you must have been aware of the laparoscopic tubal ligation camps. So we have laparoscopy and we have robotic assisted laparoscopic surgery. And the question is, do we really need robotic assisted laparoscopic surgery? There were always people who doubted whether laparoscopy or keyhole surgery is safe in cancers. But I think over a period of time, with a variety of trials, it has been proved beyond doubt that minimal access surgery is as safe, effective, without compromising outcomes as open surgery, as long as it is done by people who have been adequately trained to perform those surgeries. So then why robotic assisted surgery? Because we have a lot of people with basic laparoscopic skills, but people who are doing advanced laparoscopy are quite less, and you need a technology to bridge this gap. So what you want is a lot of patients being provided with or offered minimal access surgery, and this is where the robot comes into play. We should not consider it as a competition to laparoscopy. We should see it as an evolution of laparoscopy. Just like we moved on from a manual car to an automatic car, this is something like that. And then now probably we are moving to a driverless car, and probably tomorrow there might be a totally automated machine, and this robot would go out of the window. The advantages that robotic surgery provides over conventional laparoscopy is in terms of vision, in terms of magnification, in terms of wristed movements. I think the biggest problem with laparoscopy was the movements were like, the instruments are like chopsticks. You don't have very much flexibility with the instrument, which the robotic surgery in a miniature form provides. So with the robotic instruments, it's basically your mini wrists which are operating inside the abdomen. And that's, in my view, the biggest advantage of robotic surgery. And when you put it on in terms of value, you learn it much quicker as compared to laparoscopy. You can easily move on from open surgery to robotic surgery. It's easy anatomical dissection, easy suturing, and probably first time there is a computer interface between the surgeon and a patient. All other specialties of medicine have been, sort of computer has inverted it. Surgery was one, but here the robot is basically a computer interface between the surgeon and a patient. I will skip this here, but these are the two videos, which just tells you, how it is exactly the same as open surgery. So the upper video is open pelvic lymph node dissection, which is basically a procedure where you take out all the lymph nodes along the external iliac artery, vein, internal iliac artery. And the lower video is what we do with a robotic assisted form. The idea of showing these videos is you can see the movements, the steps are exactly the same what you would be doing with an open operation. And that, in my view, is the biggest advantage. So especially when you are working in close approximation with major blood vessels, you injure the external iliac artery, within 5 minutes the patient will lose about 500 to 700 ml of blood. And to be aware of that and to be able to avoid that, you need instrumentation that provides you that kind of control. And that's where the robot comes into picture. The fine tip of the instrument and the control of the tip of the instrument is fantastic in terms of avoiding injuries to major vessels. So you can see here, you can see that blue thing is the external iliac vein, and you are doing it exactly the same way as I would do in an open surgery. And that, in my view, is the value of robotic surgery. Where we can use it in gynecological cancers, I think endometrial cancer is probably the biggest indication. Cervical cancer, there is a bit of controversy, but I think eventually we'll get to doing it regularly for cervical cancer. We use it for groin node dissection for vulval cancers. There are sentinel node procedures, trachelectomies, exenteration. So technically, apart from advanced ovarian cancers, practically all gynecological cancer surgeries can be done using the robot. Endometrial cancer I want to highlight because this is probably the bulk of our surgical work with the robot. Majority of the patients are like this. They have a very high BMI, previous surgeries, medical comorbidities, and you take an incision or do an open surgery for them, I think your assistant is going to curse you for rest of his or her life, because you know it's a torture, you know, in terms of assisting these surgeries as well as, you know, taking care of their you know, post-operative wound. And so one of the important aspects of you know, endometrial cancer surgery, or the difficult part of endometrial cancer surgery, is the para-aortic lymph node dissection, where you take out the lymph nodes along the aorta and the IVC. And I think again here, you know, you are dealing with major vessels, ureter, and you need a technology and instrument that allows you precise control while you are doing that. And the robotic platform, again, as I said, you can see here, that's the IVC. Unfortunately, I don't have a marker here, but you can see the blue thing is the IVC, which is my thing is retracting. So the way you can remove this lymph node, it just gives me a lot of confidence to go ahead and do complex cancer surgeries with the help of the robot, because I am in control of the movement of the instruments. And I think the biggest advantage or the biggest thing in surgery is being able or being sure of your movements while you are inside the abdomen, be it open surgery, be it robotic surgery, be it laparoscopic surgery. Yeah. So sentinel node mapping is another thing, you know, which is basically a standard of care in variety of cancers, especially breast cancer. It is coming up in a big way in endometrial cancer. Here, we give a small dye. Oh, sorry. Yeah. We give a small dye into the cervix prior to surgery. So the whole idea of sentinel node mapping, if I have to put it in a nutshell, so you can see that there is a lymphatic tract which is going from the cervix into a lymph node. And the idea is, if I can get to know whether the lymph nodes are involved or not by removing only one lymph node, why do we need to remove 35 lymph nodes? Because lymph node removal has its own problems in terms of patients developing lymphedema and all the other problems. And if I can get the information by doing that, and with the robotic technology, this is called as a firefly technology or near infrared imaging, and that is integrated in the robot. So here you can see the lymph node which is green. So I just remove that lymph node. I don't touch the other lymph node. If this lymph node is negative, the patient is considered as lymph node negative, and this has almost 98 to 99% sensitivity. So it is fairly accurate. So nowadays, you know, we don't do extensive lymph node dissection in endometrial cancer. We just stick to sentinel node mapping, especially in early or low risk endometrial cancers. Groin node dissection is again another procedure which we are sort of probably have the highest series in India. You know, where you do an inguinal lymph node dissection, because the biggest problem with groin node dissection is the wound infection that happens. And if you can cut down on the size of incisions by using the ports and using the robot, I think the morbidity post-operatively is significantly less. Cervical cancer, as I said, it's a little bit of controversy currently, because there have been few trials which were published a couple of years back which said that minimal invasive surgery, be it laparoscopy or robotic, is inferior in cervical cancer. So currently, you know, worldwide there is a stop, but there are few trials which have shown encouraging results. We are waiting for that. Once that comes in, I think cervical cancer will also be an indication, you know, for robotic surgery. Now, I have personally only experience with the intuitive surgical, but there are few other robotic systems which have come. There is a Hugo RAS, the CMR, and there is our own Make in India, you know, SSI Mantra. Now, obviously, these systems are in the process of evolution. Okay, I personally, as I said, I don't have any experience with them. But in times to come, you know, once there is competition, that will not only improve these systems, but that will also bring down the cost of the intuitive surgical, you know, system, because once there is competition, the cost is bound to come down. The future, I think there is going to be an impact of AI and machine learning in the robotic surgery that we do. We are going to have enhanced imaging and visualization. Remote surgery, there have been attempts, few have been done successfully, and it's going to be the way forward, because then that allows us in a country like India to provide healthcare in far areas where good healthcare facilities are not available. There will be increased automation. Right now, the robot is at the mercy of the surgeon. You know, the instrument does not move a millimeter till the surgeon wants it to move. But there have been, sort of research that is going on for increasing the automation, and that eventually will lead to expansion of robotic surgery indications. Obviously, it's a new technology. It has its learning curve. In my view, I have done over 900 robotic surgeries for gynecological cancer. I think 20 to 25 cases is what you need to do to be well aware with the system and the problems that you are likely to face. And your operating time more or less stabilizes after 50 cases. There are limitations, okay, obviously, and the last, but not the least, is the cost. I think currently the cost of robotic systems in India is prohibitive. Not only the capital cost that is required to buy the equipment, but per case cost is also quite prohibitive. But I think that's why we all want the competition to come. We all have paid, for mobile phones 18 rupees per meter to now it's almost free. So the moment there is competition, the cost of everything is going to come down, and we expect the cost of robotic surgery also to come down. So how to use a new technology? I think this is probably my last or second last slide. Whenever there is a new piece of technology, we all get excited. We all want our hands on that piece of technology, and we feel that's the best. Okay, when the moment iPhone 16 comes, we don't think what's the difference between iPhone 14 and 16. We just want iPhone 16 because we believe that's the best. But I don't think that's the case with medical technologies. I think the technology has to be backed up by the skills of the surgeon or the user of it, and most importantly, a case selection. Just because we have the robot does not mean that every patient that walks into my OPD is offered robotic surgery. I think the best use of technology is done by who understands the limitation of technology. And if you don't understand this, you'll end up with this. You have the most expensive car in the world, the most powerful car in the world. You don't drive them on the right roads, you are bound to get stuck. So once you understand this, I think you are ready to shake hands with any technology that comes your way. Thank you very much for a patient hearing. I think I finished in time.
Hello. Thank you, sir. Finishing well in time. You can join here with us, Manoj sir. Very informative. Now for next speaker, my colleagues will introduce him.
The next topic is Innovation in the Rectal Cancer Management by Dr. Manoj Mulchandani. He is Consultant General Laparoscopic and Robotic Colorectal Surgeon in Kokilaben Dhirubhai Ambani Hospital, Andheri, Mumbai.
Good afternoon. Thank you to the organizers for inviting. And I'll start my talk, and I'll keep it on time because I don't want you all to wait for lunch. So I'm going to talk about rectal cancer mainly, but in general colorectal cancer. It's the third most commonest cancer. In fact, 10% of all cancer cases are colorectal cancer. The most distressing thing is it's the second highest cause of cancer deaths. It predominantly affects older individuals, though I would say now we are seeing a very high number of young people with rectal cancers. Lifestyle plays a big role, and this is generally diagnosed at an advanced stage in our country like all other cancers. Now, this is statistics which is very worrying. 2004-5 to 10 years old, and now it's still bad. You will see our country, the incidence 5.8, gone up by 20%, and major cities where these cancer rates are high. The reason why we've included major cities is because diagnostics is more available. Probably if we'll be getting the latest statistics of this decade, and this number is worse. So you will see on an average 20 to 25% increase in colorectal cancers in 10 years. That is a bad statistic. Now this is a slide picked up from WHO, where red shows incidence of colorectal cancer and blue shows mortality from colorectal cancer. And as you come from top to down, we are basically talking of advanced countries in healthcare. And unfortunately, India at the moment, for healthcare reasons, it's still less developed. So you will see blue and red very close together, which means mortality and incidence are very close. That means very high number of mortality compared to other Western countries where there is a big difference. And the main reason is because of screening. In our country, we don't have a screening program for colorectal cancer. In the West, in US, Europe, they do colonoscopies at a fairly early age, and they can remove polyps which will turn cancerous or pick up early cancers. In our country, where people are dying of infectious diseases, cardiac problems, I think we are looking at another 10 or 20 years where we'll get screening for colorectal cancer. So as doctors, as primary health physicians, we are the ones who are going to be screening them. So when somebody comes to you with bowel problems, bleeding PR, one should investigate, because majority of them are treated as just piles. Maybe large number of piles, but we miss a lot of cancers. This is from an anatomy textbook where we look at parts of the bowel and cancer, and you will see majority of the cancers are in rectum, sigmoid, and then cecum. So about 60% cancers are in areas where actually patients will present with symptoms. So in rectum and sigmoid colon, very likely they'll have bleeding or marked change in bowel habit. In cecum, they will present with iron deficiency anemia. And I would just highlight, iron deficiency anemia is something very casually treated in our country. Give iron injection, give iron tablets, that's it. Unless most common cause of iron deficiency anemia is blood loss, then is nutritional. So one must look at where somebody is losing blood. In a female, it could be menorrhagia. In a male, it could be either urine or bowel. So one should check. Stool occult blood tests have their problems with percentage of accuracy, but not a bad test to do. Before just randomly giving them iron therapies. We get invariably a lot of patients in our OPD with anemia. They've been treated for 1 year, 2 years on iron therapies. So somebody who's had iron therapy, changed his diet, and needing iron therapy again, please investigate. Somebody who's having a regular diet and suddenly drops hemoglobin, it is because of blood loss, and colorectal cancer is one of the causes. So important, anemia and bleeding PR should not be investigated. Should be investigated, should not be ignored. Now this is bad statistic, just to tell us what stage colorectal cancers are detected in our country, and you'll see 90% are stage 3 and above. That's very disturbing number, meaning very small number come early to us. They come in an advanced stage. Unfortunately, they need more therapy, and that's why mortality is high in colorectal cancer, especially in our country. Now, treatments are, surgery is still one of the gold standard treatment. We have radiation treatment, chemotherapy, and biological therapy is now most important because you actually look up genetics. I think a speaker before me discussed about this, but genetics of an individual, and you can individualize the treatment, which has lesser side effects and far higher chance of succeeding than just randomly giving systemic therapy. So we have all treatments available, and now these are available in a lot of centers. So 10 years ago, where these were only available in few cities or few centers, now with advancements, they are available in higher centers. Majority of cities have this. Now, what is newer advancements in colorectal cancer? Now, when you ask a patient or when a doctor refers a patient, the fear in the patient is, if I have a rectal cancer, means I'm going to have a permanent stoma. And majority of them, are disturbed by it. And in fact, a small number of them don't take treatment because they said, we don't want a stoma. We don't mind dying, but we cannot live with a stoma. But permanent stoma, with advancements in stapler technology, with advancements in minimal access surgery, stoma rates have significantly gone down. Meaning, out of rectal cancers, probably 10% or at the highest 15% may need a permanent stoma. That number is also going to go down. If it is done in centers who routinely do rectal cancer surgeries, that number is single digit. So very, very low number of permanent stomas. I think that fear should go away. Also, stoma devices have improved. So people who actually need a stoma, they are so good devices that a lot of times they don't need to wear a bag. The most important advancement in rectal cancer is role of multiple specialties. It's not a single person treating. A surgeon individually doesn't treat a rectal cancer. All rectal cancers in our hospital go through a multidisciplinary team where there are multiple specialties sitting, discussing about the patient, looking at the scans, looking at the reports and deciding what is best for them. Rectal cancer is not individually treated. Precise oncology. This is something where you talk about precision and precise oncology. It involves precision surgery. As my colleague Dr. Kulkarni said, it's not just removing more and more, it's removing less and less so that quality of life is not affected. So we are not looking at treating cancer, we are looking at treating cancer and also giving a good quality of life. So precise surgery with minimal access, we can do that. Precise radiation. Radiation machines have improved. The side effects have come down and you can actually radiate precisionally small areas. And precise systemic treatment. Depending on your genetic makeup, you decide what chemotherapy, what target therapy, what immunotherapy you give to these patients. Early cancers, we operate, but unfortunately in our country, we find very small number of early cancers. Advanced cancers, we initially downstage them, which would be either with chemotherapy, combination of chemotherapy and radiation, and then surgery. We are now talking of total neoadjuvant treatment, and we are seeing 25% of patients, rectal cancer patients, who actually have their cancer completely cured with total neoadjuvant treatment. So we are moving away from radical surgery to permanent bags to actually no surgery. So these are rectal cancer surgeries. We have transanal excisions, we have anterior resection, abdominoperineal resection. If the cancer is involving multiple organs, multivisceral surgeries. Now, local excision is done minimally access way, or if the lesion is very low down in the rectum, you can remove them transanally. There are certain, it has to be an early lesion and MRI can help you pick them up. We can do these through minimal access. This is a patient who had a villus adenoma on biopsy, but it was very large, T1 on MRI, which is very early cancer, and he had a transanal minimal access surgery where we put a single port through the anus and we removed it, and it came as T1 cancer. So he's on surveillance but doesn't need any open surgery, no scars on the abdomen. So minimal access surgery is oncologically same. So the surgery is absolutely same, but it has remarkable benefits to the patient, how they recover, and to the surgeon as well. These are techniques for doing minimal access surgery: laparoscopic, single port laparoscopic, robotic, single port robotic, and now we are doing these transanally. So you have no scars on the abdomen. I'll just talk about one or two cases because that will just help the audience to understand the complexity of work we do. Now, this was a 54-year-old lady, 6 months of rectal bleeding and increased bowel frequency. Otherwise, absolutely fit, has a 3 centimeter from the anal verge growth. In about 5-10 years back, she would have had an APR. But now with advanced technology, we downstaged her. So on investigations, we did CT scan, MRI, a CA level. We got a biopsy done, and the MRI showed that it's a low growth, but T3 growth and N1. So this is the third stage cancers are commonest in our country. This is the time most of them are diagnosed. We discussed at the meeting, she had neoadjuvant chemotherapy and radiation, And 6 weeks later, she had low anterior, we did an MRI which showed that the cancer has decreased in size, and she had a low anterior resection. She had excellent response, ultra low anterior resection. She had a temporary stoma which was reversed, and she received chemotherapy afterwards and is doing very well now. It's been about 7 years since her surgery. This is another case which is slightly advanced. A 47-year-old gentleman has 1 year of rectal bleeding, who was treated previously for piles. Majority of the people in that age, we would think it's piles. You know, it's nobody's fault. Till somebody put a finger in and found that actually he has tumor. And his whole world shook, because 47, he working abroad, came back to India because he had family support here, and got investigated. CA level came as 1205, tumor markers very high, deranged LFTs. On colonoscopy, a large lesion. Biopsy shows moderately differentiated adenocarcinoma. Because of high CA, undergoes a PET scan, which shows cancer, which is advanced, as well as liver mets. So his liver has multiple metastases, and few of them are very large in size. 20 years ago, this patient would have been left to best palliative care, and the survival would be 3 months or 6 months. Now, because of advancements and precision oncology, he underwent chemotherapy. We did a genetic profile. Chemotherapy and target therapy was given. And you can see after about 4 cycles of chemotherapy and target therapy, he had remarkable improvement.
Sir, 2 minutes left.
Yes, I will finish. This is my last few slides. So you can see the left and right, the liver mets have responded. Locally, he responded. He underwent rectal surgery along with liver resection at the same time, possible in our center because we have all specialties available. Histopath showed still high-grade tumor, received treatment, more chemotherapy, underwent scans. 6 months to a year later, no cancer detected, but these cancers tend to come back. So then on 1 year post-surgery, no growth in the rectum, no growth anywhere. Unfortunately, 6 months down the line, that's about 18 months, develops another liver met. Now this is treated by our interventional radiologist by doing radiofrequency ablation. So this is the liver met, small liver met treated with radiofrequency ablation. It will keep on continuing. It's not that he's cured, but previously where his survival would have been 6 months, now we are looking at close to 3 years where he's still alive. He may get 1 or 2 small mets somewhere, but they can still be treated. So this is what has changed in cancers overall, and especially colorectal cancer in metastatic setting. So 25% of cancers will develop, will have liver mets, and now we can treat them because of various specialties and various advancements. We can do these surgeries, minimal access, laparoscopic and robotic. I won't talk about this because my previous speaker has spoken. Now, these are the advancements. Now we are going to go on to single port robotic, and we are going on to go to surgery which is done transanally. Most important is removing the specimen completely. And this is my last slide. Cancers now are multi-modality treatment. You need multiple specialties to decide a patient treatment. Better to go to places where all specialties are available, because otherwise you may have half-hearted treatment. And with that, hopefully, prognosis and survival will improve. Thank you.
Thank you, both the speakers, concluding in a time, Yogesh Bhai and Manoj Bhai, and with updating us in our latest technology for robot and most challenging issues of neoplasia we are facing nowadays. For management, further proceeding.
Can we have a huge round of applause for our speakers? I would also request Dr. Yogesh Kulkarni sir to join us on stage along with Manoj sir. And I would request both our chairpersons to give a memento to both our speakers for giving this valuable presentation at IOH Surat, Gujcon 25. Dr. Yogesh Kulkarni sir and Dr. Manoj Mulchandani sir. Thank you so much sir on behalf of IOH Gujcon 25 hosted by IOH Surat. Guys, एक बार जोरदार तालियां होनी चाहिए for this wonderful presentation and wonderful event happening at Daman Gujcon 25. With that, I would also request on behalf of committee, Kirit sir, Shubham sir, Shekhawat sir, Khemawat sir, Dr. Prakash sir, Jen sir, please if you can join, to both our chairpersons give a memento token of appreciation. Guys, एक बार जोरदार तालियां होनी चाहिए for the whole team. I think they are doing a wonderful job. Gujcon 25. Thank you so much sir. So दोस्तों, it's time for lunch and sharp 2:30 we meet up for दोस्तों, this is the lunch time and sharp 2:30 again we meet up post lunch with the presentation by Dr. Prashant Dave sir, Parul University, Vadodara. उसके बाद सर, उनके बाद
Good afternoon, everyone. Our next speaker is Dr. Prashant Dave, and his topic is AI tools in occupational health, AI tools for occupational health physicians. He has done his MBBS, MD, PGCIH, PGC, MDM, and currently is Assistant Medical Superintendent at Parul Sevasram Hospital, Parul University, Vadodara. He is Associate Professor for Community Medicine, PIMSR, Parul University, and he is ex-occupational health physician at RIL as well as SR Oil. Now, floor is yours, Dr. Prashant. AI is now widely used in occupational health as well elsewhere, everywhere. And he will focus on where we can use in occupational health services.
There's a beautiful slok in Sanskrit. Na chor haryam, na raj haryam, na bhatru bhajyam, na cha bharakari. Vyaye krute vardate eva nityam, vidyadanam paramdanam. It means that this knowledge is the only thing which you keep on spending and it keep on increasing. Why I mentioned this slok? Because same is true with artificial intelligence. So it's not only artificial intelligence that is important. We are living in the era of big data, data science, artificial intelligence, machine learning, deep learning, then machine learning, deep learning, then augmented reality, virtual reality. So these are the buzzword of today's tech. And only artificial intelligence or only big data is not something we need to know. But we should have at least little knowledge of whatever buzzword I have told. Because artificial intelligence, the root goes back in Second World War. Scientist Turing actually invented that first to decode the German codes. And in recently, Turing test was passed by AI tools, and it is indistinguishable from the human text. So there later on it pick up the speed. But we are living in an era where gigabytes and petabytes of data is there as a big data. And when you feed AI with this big data from the Hadoop and all that software, and a system known as cloud computing. We all, whatever data we are having with our hospital, now small cloud we are sharing, and that cloud computing speed is enormous. So all this makes sense when they are integrated. AI, big data, data science, cloud computing, AR, VR, deep learning, machine learning. So, and this is applying to all. You use all these tools more and more, and the more and more thing you archive from it. So once you start using ChatGPT or Gemini AI, whatever customization happening at every day-to-day uses, it will going to assist in a superhuman kind of thing. So I already mentioned the history that in 2020 it passed the Turing test in generating text, and it is almost indistinguishable from the human text. ChatGPT launched in 2022, 13th of November, and within 5 days, 1 million downloaded. So that shows how in thing it is. The technology is natural language processing, and through multi-layer neurons processing it works. And ultimately, all these tools, which might be wrong, is nothing but the AI hallucination. Then different AI mode of ChatGPT or Gemini AI or Copilot have different IQs that you should be knowing that which model suits for your work. Then every these tools having their free and paid plans. So if you are using and if you find some tool very helpful in your day-to-day task, you can go for paid tool, because this is the next era, future. We know that we were using somewhere around 128 MB, 512 MB plan. It comes to GB, and now it comes to 2 GB per day or even unlimited data plan. Same, it is the starting of AI. So the early you start using it, the early you start using paid version, the more you can adapt with that system. Now coming to data control and privacy policy of each AI tool. Basically, AI tool will use your feeding as testing for themselves. So you should keep in mind that what I want to share with AI tools that can go to the world and what I don't want to. We all were making, when there was viral Ghibli style images. So indirectly we were giving AI tools that imaging family images, and that will be processed and give you the Ghibli style image, but then there is lot of lack of trust in that your data will be utilized for some other person's data. So actually it was planned in a hands-on practice, 2 or 3 hour PDC session, but now it's just 20 minutes. So I'll give some outline only. But then I will tell that how to protect this data by ChatGPT, Gemini AI, Copilot, Cloud like tools that will not go to the other person, will restrict it to you only. Then there are different sub-function known as reasoning, think, or deep search with different tool. When to use what, that is also priority. And these video are available on YouTube. What is the function of deep think or deep research in individual AI tool. And in AI tools, whenever you are talking first time, the detailed prompt you will give, it will be considered as a new thread or new topic. So anything that goes on below and below will be considered just like the first prompt. You need not to give that prompt every time. So later on, just once, and keeping in mind the above scenario, give me this kind of help, and it will help you. Coming to the prompt, that is the most important thing, because as a doctor, we are not that much tech savvy. So how to give a good prompt, that is the most important thing whenever you are using any AI tool. So what is that? So in prompt, there are basically 3 parts. First, you need to activate the head, that is the brain. Suppose you are giving prompt to the ChatGPT or Gemini AI, you have to give the role first. That assume yourself as a veteran researcher in occupational health, having 3 decades of experience working with the so-and-so chemicals. So that will assume the brain of that 3-decade experience occupational health physician come researcher. Now whatever comes as an answer will be from that person. So you need to activate in first 1 or 2 sentences the head of the AI tool. Then comes the backstory or micro detailing of the description. See, this is the area where actually hands-on practice is much needed, because as much as specification you will give to the AI tool, it will be tailored, custom made. Okay, and just one thing you need to keep in mind, you need to consider that AI tool as newly recruited subordinate under you or your personal assistant. उसको आप जैसे माइक्रो प्लानिंग के साथ बात करते हो वैसे आपको बात करनी होगी. फॉर एग्जाम्पल इफ आई टेल माई डॉटर कि मेरे लिए बेटा नीचे प्रोविजन स्टोर से जाके एक दूध की थैली ले आओ, मिल्क की थैली ले आओ, तो वो लेके जाएगी. देन दैट प्रोविजन स्टोर विल कॉल मी, सर आपकी डॉटर आई है, मुझे कौन सा दूध देना है, गाय का दूँ, बफेलो का दूँ, अमूल का दूँ, कौन सा दूँ. तो स्पेसिफिकेशन इज रिक्वायर्ड कि भाई अमूल का चाहिए. अमूल का कौन सा दूँ, गोल्ड दूँ, शक्ति दूँ, ताज़ा दूँ, कौन सा दूँ. तो आपको बोलना पड़ेगा अमूल गोल्ड, फिर बोलना पड़ेगा मुझे को 500 ml वाला चाहिए. ओके, सो दिस इज हाउ आई एम exactly precising, narrowing down the specification of whatever you want. The more specific and detail-oriented backstory you give to the AI tool, the precise will be the outcome of the AI. So this is all regarding prompt. Then these are the different AI tools by OpenAI, ChatGPT, Gemini by Google, Copilot by Microsoft, recently launched Grok by Elon Musk, Twitter, X, Cloud.ai, Notebook LM by Google, Perplexity AI, Ideogram for image generation, Micro Designer for poster and image generation. This is the list of few tools. There are n number of tools, and every day while I'm delivering this talk, there might be few newer AI tools might have been discovered. But these are the basic tools. At least we should be knowing. It has been said that AI will not replace the humans, but the human knowing AI will be definitely replacing the person. Okay, so if you are there in the market and want to remain relevant till your career lasts, you have to learn AI today or tomorrow. There is no choice left. So considering the time constraint, I'm just highlighting when to use what tool, their strength, weakness, and practical uses. Say if you are using ChatGPT for your day-to-day occupational practice, what can be the use? So its strength basically in exporting files to Word. Whatever prompt you have given, just in the last sentence mention that export the content in a ready-to-use export Word file. So it will be a Word file downloaded. You can just download that Word file and you can ready to use. For example, you want to know the guideline of Nipah virus. अभी आपको एम्प्लॉई में सर्कुलेशन में एक मेल डालना है कि डूस एंड डोंट्स ऑफ निपा वायरस, मिथ्स एंड फैक्ट्स ऑफ निपा वायरस. तो आप चैट जीपीटी को प्रॉम्प्ट दे दीजिए कि यू आर एन occupational health physician with 3 decades of experience, well versed with the WHO bulletins and whatever, from wherever you want to take the information, and prepare do's and don'ts guideline related to Nipah virus for a company situated in so and so area, petrochemical industry in that part of the world. So that will give the guideline, and then you need to just in the prompt last you need to mention that it should be a ready to export word file. तो आपको ready made word file मिल जाएगी. Then एक्सेल, पीपीटी, देन अगर आपको कोई इमेज दिखती है जिसमें टेबल्स वगैरह कोई है तो डायरेक्टली उस इमेज को स्कैन करके कर दीजिए और टेबल का सॉफ्ट वर्जन आपको मिल जाएगा. विजुअलाइजेशन लाइक जिबली स्टाइल वी हैव नोन, एंड इट सपोर्ट्स लार्ज फाइल. 512 MB तक की फाइल को आप अटैचमेंट में डाल के उसका एनालिसिस कर सकते हो इन चैट जीपीटी. Data analysis and visualization. But what are the weakness? There is a lot of hallucination in the chat GPT. There are chances that might be wrong information, infactual information may be there. You need to check them. And there is good feature known as reason or deep search. You need to refine, but you can use in free version only few times, 3 times or 5 times. 5 minutes left. Yeah, sure. What are the practical uses for brainstorming, then your PPT to textbook, timetable formation? So these are the strength and weakness. Then coming to the Gemini by Google, one of the highest IQ model, 2.5 Pro, it can cross-check the response. आपके Google Gemini में जो AI ने response दिया है, उसका cross-check का एक उसमें function रहता है. Once you check it, that will go to online websites, reliable sources, and will highlight if there is some AI hallucination. So that is the strength with Gemini AI. And if you use deep research, वो दिन में अभी paid plan में यूज़ कर सकते हैं अनलिमिटेड टाइम, बाकी लिमिटेड टाइम ही यूज़ कर सकते हैं. तो देन यू हैव दैट फीचर इन जेमिनी. यू कैन ऑल्सो एक्सेल अटैचमेंट कैन बी डन, बट इट इज़ ओनली इन द पेड प्लान. एंड डीप रिसर्च ओनली 5 times पर मंथ. सो वीकली आपको 1 या 2 बार यूज़ करने को मिलेगा. What are the practical uses? You can use contents for fact checking, solving complex questions, problems, translation of the questionnaire if you are doing some research, and literature review. for the paper presentation. Then this is the most recent one, Grok, one of the highest IQ having model. Then good mathematical analysis part based in handwriting recognition. We doctors have the habit of having writing in running English literature. So I've tried multiple times the different prescription from different practitioner. You give that prescription in handwritten language and then transcribe into the English. It will have excellent handwriting recognition skill. And if you write down that in a ready to download export Word file, it will give that Word file directly. So that is the beauty of Grok AI. Even larger than Gemini AI, 1 GB up to attachment you can have with Grok. Weakness, it loses word formatting on copying. Markdown language हो जाती है इसमें, तो आपको markdown language को demark करनी पड़ती है. There are another AI tools and website for that. You can utilize that. Cloud AI is excellent for reasoning kind of thing, designing the prompt according to your wish. जैसे मैंने prompt engineer बोला, आपको सपोज अच्छा प्रॉम्प्ट चाहिए तो आपको क्या क्या चाहिए 2-3 लाइन में लिख दो, prepare a prompt, तो Cloud AI will assume that role and prepare excellent prompt. That prompt can be utilized later on for another AI tool like Gemini and ChatGPT. So it's a AI tool for the prompt as well. So that's the beauty of Cloud AI. See, this is the last slide, and I just wanted to highlight few case studies and how beautiful the results I got. In the classroom engagement, once I'm having the CCTV access of my entire Parul Institute of Medical College. So CCTV of the entire classroom was ongoing. So I just clicked that photograph and attached to the ChatGPT and told that review this lecture according to our classroom lecture review guideline. It has been already there. So it not only gave me the hand count, that there are total 73 students present in this classroom. According to sex-wise, these many males and these many females. According to row and according to the column-wise, according to engagement, everything was beautifully given by the AI. So indirectly, you can review the process. अगर किसी की training चल रही है, like इसका मैं एक photograph डाल के ChatGPT में डाल दूँ, तो attendance अभी कितनी है, मेरे को पता लग जाएगी कितने लोग mobile देख रहे हैं, कितने लोग मेरे सामने देख रहे हैं. Everything could have been captured using excellent tool. Then is one thing. I give an excellent prompt. I can read down, but let me summarize that in ChatGPT, I gave that assume yourself as a veteran chairman of tumor board at Tata Memorial Cancer Hospital, comprising of oncophysician, oncosurgeon, and radiation oncologist. Now, this is the case summary of so-and-so patient having on and off body ache, abdominal pain, diarrhea, vomiting kind of complaint as of now. Now, summarize the further plan of management. And attachment में मैंने उसको अपोलो की कैंसर हॉस्पिटल की डिस्चार्ज समरी पेशेंट की दी. Then it gave me the beautiful plan for the next management. There were 3 regimens because the patient was only going for palliative care. And I also gave that the patient belongs to middle socio-economic class and from the Ahmedabad region and is a retired teacher. So that also you should consider. So उसने मेरे को response में कोस्ट के साथ बता दिया कि पैक्लिटेक्सेल will be the most suitable treatment for this Shukla patient. Okay. Otherwise, all other having 5 lakh, 10 lakh cost. So that entire benefit of the tumor board meeting that will happen only at Apollo Hospital or Civil Hospital, where all these 3 people will sit together and discuss the case, was done by the ChatGPT alone. So the beauty was in the prompt. I gave 15 line of prompt for that onco management case.
Please conclude.
Yeah. Another is the comparing and contrasting the guideline. For example, we were having COVID, 1 guideline, 2nd guideline, 3rd guideline. You attach both the guideline to Notebook LM or ChatGPT, and you can tell that what are the recent updates in that guideline. NMC is frequently coming out with UG management guideline, postgraduate guideline, medical education report. So that can be all regulations can be compare and contrast. What are the newer addition in that guideline can be done. I myself set the entire paper for UG and PG, undergraduate MBBS student, postgraduate student, using Copilot and Gemini AI. MCQ as well using this. You need to validate, you need to cross-check for the hallucination, but then 70-80% work done by these AI tools. And GPT Excel tool can do Excel sheet analysis, and you can use Grok. We were knowing that BJP का बहुत सारा उस time पे fact checking through Grok आया था और viral images were there. So Grok is excellent in fact checking and authenticity checking. So start using AI tools today or tomorrow we have to learn this. That's the clear message from my side. And last but not the least, that the ethics in using this AI tool, I will just give one example of Uber. So in Uber, the ladies were using the Uber car taxis, and the AI price surging was happening at night. So that is because of AI. Then later on that issue was addressed. So ethics in AI is the must. That's all. Thank you, sir.
Thank you very much, Dr. Prashant. You have given very insightful presentation covering AI, big data, virtual reality, augmented reality, on which methodology AI works, and you have spotted various AI tools, ChatGPT, DeepSeek, Gemini, then Cloud-A, then Grow by Elon Musk. And you also describe pros and cons of this use, including confidentiality. There is a data breach or a information breach can happen by using free ChatGPT or free AI tools. Wonderful presentation. Thank you very much on behalf of IUS Surat.
Thank you so much, sir. Next, I would like to invite Dr. Ritesh Gujjar, sir, Consultant Critical Care and Emergency, Nirali Hospital, Navsari. The topic, critical care and occupational health, bridging gaps for better outcome. I would request Dr. Ritesh Gujjar, sir. Can we have a huge round of applause for Dr. Ritesh Gujjar?
Dr. Ritesh Gujjar has done MBBS, MD, DNB in critical care, medicine, ICDTM, IFCCM, EDIC. Now he is consultant critical care and emergency medicine at Nirali Hospital, Navsari, and he is leading most qualified critical care specialist in South Gujarat. His topic is critical care and occupational health, bridging the gap for better outcomes. Now floor is yours, Ritesh bhai.
Good afternoon, everyone. Thank you for the introduction, sir. Discussion about critical care medicine at an occupational health conference at first seems like talking about the South Pole while standing at the North, totally opposite end of the healthcare fields. But trust me, these two fields are not totally disconnected. The thread which is connecting them meet at the center, which is related to patient outcome. So, occupational health professional more focuses on the chronic health exposures, ergonomics and prevention of the occupational diseases. While on the opposite hand, the critical care, the person who is involved in critical care primarily is trained to treat sepsis, shock, multi-organ failures and cardiac arrest. Why critical care matters today more than ever? If we talk about the era before 20 to 25 years, many serious illnesses and injuries had very high mortality rates. Many senior doctors are present here as a part of audience. They must be knowing that even experienced professionals, experienced doctors were felt completely helpless at the bedside. And trust me, no magical bullet or no magical drug has been invented in last 20 to 25 years. But we have to accept now that in these 20 to 25 years, we are now even more confident to manage even more complicated cases with success. So what has changed in these last 2 decades? The change is the development in one specific branch of the medicine, that is critical care medicine. Critical care medicine is particularly has transformed how we care for the sickest patient, and it has provided the hope and survival to the patient which once had almost no chance. It is the branch of the medicine which take care of the patient in their most vulnerable moments. It is the branch of the medicine where every decision, every intervention can make the difference between life and death. Next slide, please. So why occupational health and critical care medicine should be bridged? As we know that working culture, the work environment, if we compared it to the decade ago, right now it has completely changed. High pressure environment, exposure to different chemicals and physical stress, long working hours, newer technologies, increasing industries. But still, occupational health priorities will be prevention and early detection. But sometimes this is not enough. Suppose a healthcare worker, suppose a security guard or any worker experiences a cardiac arrest or toxic inhalation or multi-trauma at his or her workplace. That's where critical care steps in. But in currently, this step is most of the time delayed, disconnected, or misguided. Critical care is the safety net, but too distant from the occupational sphere. Next slide, please. So why this bridge matters? Occupational health actually should not stop at the gate of the industry or the workplace. And on the opposite end, ICU actually should not start at the gate of the hospital or the ICU. There should be more liaison, more collaboration between these two opposite ends of the healthcare sphere. Next slide. So I have identified, there are many gaps, but I have mentioned few of it between the occupational health issues with critical care medicine. The first and foremost is emergency preparedness. Till at many industries, the emergency preparedness is not enough, not sufficient. CPR and first aid training is rare or sometimes inadequate. Real-time escalation protocols is not there in many industries. And most of the time when patient is being shifted to the tertiary care or level 2, level 1 ICU, there is minimum direct communication, especially in rural and tier 2 areas. I am not talking about communication regarding that particular patient. Communication is always a two-way communication. There should be communication from the hospital to the industrial area as well, which is most of the time lacking. Next slide, please. Few more gaps. There is lack of feedback from ICU to workplace for prevention. So in our ICU also, many a times we admit the patient as a victim of workplace accidents. And trust me, our observation or crux of our observation is how that patient was managed in initial few minutes, how that patient was transferred, and where that patient was transferred. These three particular points ultimately decides outcomes in many acute emergencies in industries. There is still, previous slide please. There is still limited awareness about the role of tertiary care ICUs, particularly among the industrial health professionals, role of trained intensivists in improving the occupational health and creating safer workplaces. Unfortunately, many first aid trainers themselves lack the sufficient critical care or emergency medicine experience, and they teach outdated and inadequate guidelines or practices. It's like someone who is teaching the soldiers how to fight, but they themselves have never been to any war. Next slide, please. And one major gap which we identified from critical care endpoint is the errors in referrals. It can be either delayed due to poor recognition of the criticality of that particular patient. It ultimately affects the outcome. And many other times, it is misguided because industrial professionals do not know or they have very less knowledge about how ICU is operated, how the terminologies or how the different ICUs have different characteristics. Because of this lack of knowledge, sometimes patient is being shifted to the place where it is not being supposed to manage. And later on, time is ticking, and later on when it ultimately finds its proper place, but the time has gone, outcome has gone. Next. So how can we bridge this few of the gaps? There should always a joint drill between the occupational health team and ICU team, including mock codes, toxic exposure codes, CPR workshops conducted on site by actual ICU trained doctors who actually is dealing with this kind of emergencies. Every workplace medical room should be digitally connected to nearby advanced ICU, ideally with a trained critical care doctor. Next slide, please. Occupational health committee should actually involve, or at least they should take opinion from a critical care expert to create emergency plans. And ICU data, use ICU data to improve workplace safety. So whatever patient has been admitted to ICU from particular industry, they should collect the data, or all over the industrial data should be collected and analyzed to improve the safety practices at the industry to prevent the same incidents again at that place. Next slide, please. So very few of the person who is standing as a part of audience may be knowing that not all ICUs are the same. And even fewer would be know that not all intensivists are the same. If we talk about the ICUs, next slide. There are actually 3 levels of the ICUs. So level 1 ICU actually is a basic monitoring and for short-term care. Level 2 ICU has short-term organ support can be available, but with limited capacity. And there are the top level ICU, that is level 3 ICU, which are very rare and very less in our country, where the full-time support of multidisciplinary consultants, super specialists, 24/7 trained intensivists with advanced monitoring and infrastructure is available. So it is the place where night 3 a.m. we can do MRI, night 3 a.m. we can enter the cath lab, and night 3 a.m. we can do embolization or any surgery. So these places are actually the true ICU for any critical emergencies. As an occupational health expert, we need to know the difference when choosing hospital or ICU for our particular patient. Next slide, please. And for most of the, next slide. And for most of the ICUs, what ICU mean is few nurses and few monitors, but that's only a monitored area, not an intensive care area. Just a simple case we received few years back as a 42-year-old factory worker as a collapse after toxic fume leak. There was no training to the colleague staff how to manage this situation. So he was unattended, no oxygen or no any decontamination has been attempted. He was shifted to the hospital where even poorer than level 1 facility was available. And finally they shifted that patient again to the next level after few hours of delay. Ultimately ended up with ARDS, multi-organ failure, and the outcome was poor. Next slide. Another case of 55-year-old security guard who collapses in the industrial area. No one attempted the CPR because they were not properly trained. Someone developed the courage and started CPR. It was almost more than 10 minutes has passed. It was transported to some OPD nearby GP clinic for further management. And that practitioner referred him to the tertiary care. And when he was received, he was managed with CPR, but his brain was lost. So complete coma. Long-term disability with no...
5 minutes left, doctor.
Yes. Next slide. So what lessons we learned from the ICU cases we attend from industrial areas? Actually, workplace preparedness beforehand definitely makes a difference. Time matters. The right ICU at the right time makes definitely a difference because every second counts. Tertiary ICU, trained intensivist, makes a super difference in the outcome. Occupational health and ICU must work on for this industrial preparedness. Next slide. And what we should do, as an occupational health community, we should know the level of ICU, where our industry has been attached, what facility is available there, ensure referral to the tertiary care whenever needed, insist on care by trained person, build relationship with qualified ICUs. I forgot to mention about the intensivist. So in a country where every doctor, where all intensivists, out of all intensivists, 90% intensivists are intensivists just because they tell them that I am intensivist. So we are living in such a country that we are at high risk of mismanaged or misguided to an ICU where there is untrained person who is going to treat such critical emergencies. Next slide. So what should be our vision? So probably my vision also, and as an occupational health professional, your vision should be to develop a system where the occupational health and critical care should be the two hands of the same system and with a final goal or same goal of saving patient lives. With the help of joint training and workshop, regular audits and drills, data-driven prevention, so previous data will help us to improve, and a culture of preparedness and care. Next slide. And take-home message is from my side. Critical care not start in the hospital, it starts at the workplace itself. Timely recognition and proper referral makes a difference. ICU and occupational team must collaborate. Prevention is better than cure. And choose appropriate critical care unit for the best outcome and survival. Next slide. So although critical care medicine, which is very complex, and on the opposite side, the first scenario, which is occupational health, although it looks two poles on the earth,
check, 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 check. Check, check. Light આવી. Check, check, check.
not relevant medically. Injury certificates also you have to be very careful. You should be knowing your injury, what are the gradings. The broad dead patient. Broad dead patient, always inform police. There is a duty towards employer as well, but you have to see your main duty. And what is medico-legal case? Now what is medico-legal case? There is nothing like medico-legal case. Any case where a doctor is either accused or witness is medico-legal case. So potentially every case is a medico-legal case. There is nothing like medico-legal case. But the question is when to inform police. Now let me tell you, you have to inform police about the crime. Now what is crime? Crime is something which you do against somebody else. If I myself fall down from here, then it is an accident. Because there is a dictum in the, there is a understanding in the law that you cannot harm yourself. You cannot harm yourself. I cannot kill myself. I cannot cause harm to myself. So it is not a crime against my body. Crime always happens against the other's body. So if there is any possibility of crime, then you have to inform police. Now, if you take that risk, suppose patient says that I have taken poison and it was ingested by myself. It is not a crime. You should not report. But later on it reveals that there was some force, there was some abetment of suicide, or somebody gave him forcefully. Then you are in trouble. So most of the government hospitals have come out with one guideline, and they have said that we are not taking these slides for want of time, but they have said that these are the cases where you have to make it a point to inform the police. And all this list, it is not there anywhere, but it is just a general guideline. Suspected homicide, suspected case of suicidal death, unknown unconscious patient, death on operation table, suspected unnatural death. Now what is unnatural death? Death is natural. Death can't be unnatural, right? What is unnatural? Unnatural is unexpected death. When you don't feel that this should die and that fellow dies, then it is unnatural death or unexpected death. Please inform police in such situations. Sudden, unexpected, violent, unexplained death, instant death after treatment, married lady dying within 7 years of marriage, maternal mortality, death related to abortion, all this you have to inform police, and please make it a point, let police investigate. Don't give even death certificates. Don't issue that. Don't be in hurry. We must know what is culpable homicide, murder, that we are not skipping this, but we should know these things. And as I told you again, medical certificate and injury certificates poses a problem. Like there are so many such cases coming to us. The injury certificate or the medical certificate was given wrongly by the doctor to somebody. And it was private practitioner. So company can't do anything. But that company filed complaint in the medical council that your doctor is giving certificate at 3 months rest for this condition and it is not justifiable. And the doctor was called by medical council to answer that. So that you can't do, and their name will be removed for certain time. So if you plan for vacation, you can take that risk, right? Otherwise, you have to be very cautious. And it happens, like there was one bank manager who came to me when I was working as a gynec, and I was about to take loan from him. I already applied, and he came. He said, sir, my transfer is happening to nearby village. I don't want to go. Just give one certificate to my wife that she is suffering from a problem, and she is taking your treatment. So my transfer will be withheld. Now what to do? If I say no, my loan was already in that bank. And if I give, I was wrong. So I always try to put the ball in their court. So I said that, sir, okay, give me one application that my wife is having no problem. I am giving loan to Dr. Bhatt and I want to put him under some pressure, and that is why I am asking for a fake certificate for my wife to prevent my transfer. He said, how can I write like this? I said, then when you can't write for your wife, how can I write for your wife? What my wife will think? So, he understood. So, always put the person in the problem, and then they will understand where we stand. In look-alike situation, do not hesitate to take second opinion. Documentation is must. It can be computerized, type, handwritten, whatever way you want to do, but please document the things. And when the documentation is proper, consent is proper, and something goes wrong, suppose you are happy with the patient, but something goes wrong, patient will start waving at you at all the occasion. They will file civil complaint, criminal complaint, medical council complaint. But if your documentation and consent is good, you can wave it back to the patient like this. Just see. Right? And that is where they will be in trouble. You can give it back like this. Okay? So please make your documentation proper. And as a doctor from sonography, we can know which child or which baby is going to become Puspa. Similarly, we can know from the questions of the patient that this patient is troublesome. Do not take that patient, refer them to nearby competitor. No problem. Right? Don't take them. And non-compliance of the law. Law is, everybody has to know the law. When it is gazetted, every citizen of India is supposed to know the law. Nobody will come and tell you that this is the law. And what are the laws doctors don't follow? That is POXO Act. That is came into highlight from the Kotiar rape case, where information was not given to the police where the minor was pregnant. Any sexual intercourse with a minor is rape, and you have to inform police. If there is suspected injury at the genitals, please inform police. Let police investigate whether it is injury or sexual offense or whatever. But don't take headache, otherwise there is 1 year jail. And let me tell you, jail is a good place. Don't fear that also. Jail is a good place. They give you clothes, they give you work, they give you recreational activities, they show you films, and you get to see your spouse 1 in 15 days. What more a government can do for you, right? So, but if you fear that, then you should refrain from not following the law. And if you want to be 100% free from medical legal problem, you can start your band, you can become photographer, you can join Bollywood, Hollywood, Dawood, Ibrahim, whomsoever. There are so many career options. But in short, to be out of medical legal problem, you have to run away and leave medical practice. And that is not possible. I always say that if you follow Baba Ramdev like this, you may learn some asana to diagnose your own piles. You can do that. But it is impossible to be out of medical legal problem while being in a medical practice. Right? So medical practice has to put you into the threat of litigation. No problem. Always be prepared. After listening to me, you may feel certain amount of pressure. Right? But pressure is necessary to make you do wonders. And whenever there is medical legal problem, you have to take medical legal and medical legal advice. Because general advocates, they don't understand our language. Like there was one board, only 10 issues allowed on the court. One lady went there with only 10 issues. That is what happens with the advocates, those who are not into medical legal practice. Also, they don't understand our action. Like this, she is in some foreign country and she needs something. And you see, she will do some action. But he will not understand, right? That is what happens with the advocate who do not understand our practice. Right? And what medical legal person will do, something goes wrong, he can't change it, right? It is already done. But if you have proper documents, like you go to medical legal person, and if you have proper documents, he will put those in front of judge in such a way that ultimately it will mitigate the effect. That is what is the role of medical legal consultant. So medical legal and medical legal, all three have to dance together. Sometimes we look for the things very far off, but actually it is very near. Similarly, if at all you need me, I'll be just around the corner. Have indemnity insurance. How many of you are having indemnity insurance? You must have it. Everybody should have indemnity insurance. This is Be Safe indemnity insurance. You must have it. And indemnity insurance will not do anything, but they will provide you safety. Even if you are busy, the insurance will work on its own through their advocates, through their legal luminaries, and your work will be done and they will be behind you always. So do not panic. Do not keep concentrating on a problem which has happened. You may harm the other normal case. And last, always continue your journey. Not only walking, but dancing like this baby. And have stress-free practice. To have stress-free practice, you must practice to remain stress-free. Thank you very much. Thank you for patient hearing.
First of all, I would like to thank my co-chairman Bijal Bhai, because he invited us at the seminar in Bharuch, where we met Hitesh Bhai, and we were like, his talk was wonderful that day also, and today also is wonderful. And I hope I told so many people to just wait for his talk. I think
It was a wonderful talk and at the same time humorous also. So once we learn from, and it's a famous saying that a person becomes great by learning from someone else's mistakes. हम तो गलती कर सकते हैं पर दूसरे की गलती से अगर हम सीख सकते हैं, that's really great learning. And now I hand over to Bijal bhai.
Sir, only one question. You have been successful gynecologist. Now you are a successful medical legal practitioner. If non-political, which one you found better? That's why I said non-political answer.
I have worked there. It was not that I was bad gynec, so became advocate. If that answer you want, then I will not tell that. Even I had gold medal in MD. So I was always a good gynec. I was laparoscopic surgeon. I was learning laparoscopy to 3rd level. And then I left because there was nobody. In medical legal field, the only advantage is there is nobody who is into medical legal practice. Rather, I am in a more practice. Gynecologists are 45,000 in entire India, while there are 9 lakh lawyers. So it is a bigger competition, but still, if you have something different, then you can always excel in whatever you do in life.
Particularly doctors who are practicing in a small cities, like say for Daman, we are private practitioner. We can't afford to have full-fledged departments and separate staff for documentation like corporate hospitals. So for us to remain documented all the time, it is always difficult.
Sir, documentation is must for everybody. There is no such demarcation that small hospital, big hospital. In one of the case, it was asked, if doctor said that, sir, I don't have time. So the judge said that means you have more patient, that means more money. Hire more people to write it. She said, no, I don't have that much money. Then judge said, then you must have time. Then you write it yourself. You can't have not having both. Time bhi nahi hai aur paisa bhi nahi hai. Then leave this. Right? Either you have time or you have money. It is always inversely proportionate.
सर वो स्लाइड तो दिखाइए ना, व्हाट नॉट टू राइट, जो आपने दिखाया था भरूच में.
That was different talk. It was about documentation, where the documentation mistakes also can lead to a big problem. Like there was one case of Chennai where it is a criminal case where from the undergarment of the victim a semen was found, semen. But the police underwriter had typed semen, S-C-M-M-E, and some different spelling. And in Tamil that word means some red sand. So they said that there is no evidence of semen. It was red sand, and which is found in any seashore. So there is no rape, and that person was acquitted. So this is the importance, and that is what I see when I went for one audit in one of the hospital. There was a case where patient with left breast abscess. In discharge card it was written patient left with breast abscess. It makes the difference, totally different. So do not make such mistakes, it can lead to problem.
What not to write in OT, that case was there. Operation theatre, time of surgery, anesthetist notes and...
Yes, time of surgery. See, time also have to be perfect. When you write time, in the, see law, understand one thing, what I have seen by going to the court, not only local court, the Supreme Court, National Commission, any big state commission or district commission, they don't understand medicine. What treatment you have given, it is least concern. But they know time, they know date, they know how you are documenting. Suppose your 5 a.m. finding, 10 p.m. finding comes after the, before the 5 a.m. finding or 5 p.m. finding, then they will say that you have added afterwards. Sometimes we take signature on a blank paper and then doctor keep on writing till below the sign, keeping exact curve as patient is going to sign in future. Usually signature has to be taken after something is written. You cannot take signature on blank paper. It immediately speaks that you have written it afterwards. So all these things they can catch. The time, there is a case of Badial Hospital, which sir is telling. There, this urologist has started a surgery he has written time at 4 p.m. And the anesthetist time was 4:30 p.m. Patient died on table. The court concluded that you have started surgery without anesthesia because you have written 4 p.m. A surgery cannot start at 2 different times. You have, after patient died, you called some colleague of yours as an anesthetist and he was there in the OT at 4:30. We don't believe that it is the same time you have started. Now, who will do PCNL without anesthesia, you tell me? Nobody can start. He argued that. The court said you must have given it then. But he came at 4:30 because he has written 4:30. So please be very aware about these things. They are very much, and we are always taught in limits. In medical, say normal range. Say for sugar, they will say from 80 to 120 or postprandial 120 to 160, whatever range they are teaching. Blood pressure 100 to 140. They are teaching us in range, right? Hemoglobin 11 to 15, 10 to 15. They will teach us in range. But in law, there is no range. 18 means 18. Like any POXO case, if girl is less than 18 years, that means on 18th birthday, midnight 12, 1 minute before she is minor. If you have intercourse at that time, it is rape. After 1 minute, it is not rape because she is major now. So law is always like that. When I have to file appeal in 30 days, it is 30th day before the court sits, before the court adjourns. I have to give that appeal. So it is 30 days. That means 30 days. So never go by range. Abortion, suppose it is allowed up to 24 weeks, you have to do 24th week, midnight 12. If before that it is within the law, after that it is crime, 7 years of jail. So please be firm about this, the boundaries in the law.
Hello. Yeah, all of you please give him a warm applause. It was a wonderful talk. And sir has come all the way from Mumbai. Today Vande Bharat he has come and today he is also going. So thank you all sir for considering my request. Yes, one last question. Yeah.
Yes, the consumer law says that even if one patient is charged out of 100, 99 are free, then all 100 are within the ambit of the law. Yes, again there was government hospital where nobody was taking charge, but they said the salaries are given by the people from the tax and they are coming here for the treatment, so indirect they are paying you. So they are under the, so even resident doctors, first year resident of orthopedic, 10 years back he was given 10 lakh rupees fine for not explaining the discharge card to the patient. So PGI Chandigarh. So you have to take indemnity and it cost almost 10,000 rupees for a gynecologist or surgical branch and 4,000 rupees for non-surgical branch for 1 year for 1 crore. So if you are not earning 4,000 in a year, you are justified. Otherwise you have to take it. And criminal law, everybody is under the ambit of criminal law. For criminal law, there is no excuse. Everybody is under the ambit of the criminal law.
Thank you, sir. Thank you a lot. Thank you, sir. Our next speaker will be Dr. Gaurav Khandelwal. Sir, you can sit here.
Yeah. Thank you. The next speaker, Dr. Gaurav Khandelwal, orthopedic surgeon, Shelby Hospital, Surat. The topic, miracles in spine.
Hello. So post-lunch session, even in colleges used to be, what a pain. And that too in Daman, you're missing the party and sitting to listen to lectures. I'm really impressed. So first of all, thank you, all of you, delegates. But more importantly, thank you, all the people, all the doctors from the industries who have supported us for the last 8 years at Shelby Hospital. From the scratch to what we have become today. The last week itself was extremely busy. Last 2 days I was operating non-stop, slept at 1:30. I'm quite dazed. And if it wasn't for Daman, IAOH, I would just refuse to come today. Looks like everyone is quite asleep still. Well, that's good. So you won't remember what I'm going to do now. So problem is that after such a long, exciting TikTok video, I have to talk about something very serious. But whether you like it or not, very soon you are going to face the same problems that I'm going to show you today. Someone in your family at this moment has back pain. Someone of your friends has back pain. Some of them would be having serious spine problems as well. And whether you're a doctor or not, you will be faced having to decide whether or not to advise him to go for surgery. And what spine surgery impression that you have in your head now is going to help you make that decision. I am here to help you so that you make the correct one. All right, so let's begin. So the commonest problem that we have nowadays as doctors, as spine surgeons is, someone among you will send me this WhatsApp. This MRI image in WhatsApp, ke sahab jo ne su karvanu ema. And then when I ask, what about the patient? This is what usually, like one of these patients, he told me, this is a doctor, he's telling me the 60 years female has back pain, leg pain, not able to walk. I have given conservative treatment. અત્યારે સારું લાગે છે. પણ જો ને તમે શું લાગે, શું કરવાનું? Even now if I open my phone, at least 1 or 2 MRIs will be there. Somebody has sent. કે જો ને, it's not that easy. And you'll find out why. So I usually insist that it's not possible. I need to see the patient clinically. And that is because when such patients come, when this patient came, the MRI is all right, but the patient is actually more older, has diabetes, hypertension, both leg pains, numbness in both legs and perineum. If you know what that means, there is bilateral foot drop. Already in bed with diaper, she is passing urine in the diaper, she doesn't even know that she has become incontinent. Now, unless you check for this, how will you know? And then has to undergo emergency surgery. Patient recovers, but if you see here, just a second. All right. So if you see here, what she's wearing is not a footwear. What she's wearing is an AFO, a foot drop splint. Because even if I have decompressed the nerve, the pain is gone, the foot is still paralyzed. And I have no idea when that is going to recover. Now this has purely happened because of delay. If this patient could have come in time, hopefully we could have saved those legs as well. Hopefully she may still recover, but we don't know. A common patient, you may also see some x-rays like this. The one on the left side is normal, the right side is a scoliosis. Elderly people commonly have this. And what do? Medicine and physiotherapy to everyone. કે એ તો સારું નહીં થાય. Doctors will tell the patients, bend થઈ ગયું ને, એ તો આમ જ રહેવાનું, ઉંમર થઈ ગઈ છે બાની. But along with this pain, what do you think will happen to the nerves? So this can be corrected like this. It has to be corrected. A huge number of screws have to be put. And then the patient will start walking, but many of them have permanent neurological deficits simply because they didn't take treatment in time. Another one, similar case, same thing, still having weakness. Importantly, in cervical spine and thoracic spine, even if the cord gets almost completely squeezed, there is no pain. Patient will slowly, steadily become paralyzed, become weaker, may have some tingling numbness, but absolutely no pain. Elderly people will feel it's just part of their aging. They may have some imbalance. Unless and until you examine the patient, you are not going to find that the cord is getting compressed. So, a bit complicated, but just bear with me on this one. Elderly patient, ankylosing spondylitis, you know the one in which the spine gets fused? Multiple comorbid depression, had earlier one fracture, healed up, came for a second time with another fracture. But he has come 2 months late because the fracture is at C71, at this junction here. And somebody outside had told him, looking at the MRI, jagya par achhe aavi jase. And he's feeling a bit okay. But if you have learnt about ankylosing spondylitis, you know that it is the fused spine. The entire spine is a single rock. If it breaks completely. There is no incomplete break. So all the fractures are unstable. It is just going to slip away. They didn't agree for any intervention. Saru lage chhe. And he went off. And then, after 4 days, early morning I get a call from his doctor, ke papa na pag halta na thi. Morning he got up to go to the toilet, he couldn't feel his legs. Emergency ma shift kariyu. When he came, both limbs are 0. And this is the fracture. Now if you can see that, I don't have a pointer here, but you can see the fracture line, right? At the mark. It looks benign, but I can tell you this is extremely dangerous because look at the level, C7. If the cord goes, everything below is going to go. Now, because he has come in emergency, he has taken clopidogrel the night before. On one hand, if I take him to surgery immediately, he may bleed to death. And every hour that is passing by, his deficit is becoming permanent. So this is the kind of problems that prop up now. So we couldn't wait. Taking the risk, took him for surgery. Now ankylosing spondylitis means the chest is fused. Anesthesia problems, intubation problems, all that, finally we could manage to operate. Problem was the anesthetist had to be called an emergency. He had not checked him in detail. After surgery, he removed the tube. The chest just collapsed. Oxygen went to 20. And he was not able to intubate back because ankylosing, the neck is also fused. 2 more anesthetists had to come in, rush. Somehow managed to re-intubate, somehow brought him back. Survived that. This was done. This is also complicated but went well. Finally recovered. All of that because of delay. If it could be diagnosed and treated in time, if he had a bit more faith in the surgery, this could have been saved. One more. Another common problem, elderly, 70 years female, multiple fractures in spine, but admitted under a renowned orthosurgeon in Surat. And the relatives have come with an MRI scan, saying कि just opinion જોઈએ. Patient સારું છે, patient દુખાવો પણ નથી. Just look at the MRI. And I just blankly refused because I know what happens in these patients. They got so upset that we are ready to pay the fees. Why can't you just give an opinion? And later on, I was also wondering that maybe I could have been a bit more polite. But when they brought the patient, I asked the patient, move the legs. Patient मैंने कहे छे, अरे मेरा पैर नहीं हिल रहा है. तो I said, आपको नहीं पता आपका पैर नहीं हिल रहा है? किसी ने पूछा ही नहीं मेरे को. सब आके पूछ रहे दर्द कैसा है? दर्द अच्छा लग रहा है सो के. पैर हिलना बंद हो गया है, paralyzed. Already admitted patient in an orthopedic hospital. Now the story just begins again. So these are the fractures. MRI looks doubtful, but this is a very dangerous fracture again. Just imagine what will happen to this patient if the patient sits. This MRI is done in a supine position, in a lying down position. That time there is no body force pressing on the spine. When such fracture spine sits, when the pressure comes, that fracture fragment is going to go inside the cord. So this you have to be able to predict. Now, story just began. Went for admission, had ECG changes. Trop 3 was through the roof. What is Trop T? She is having an active myocardial infarction going on. We are trying to get for surgery. So diabetic patients and silent MI is going on. So what to do first? Should we save the heart and the patient or save her legs? Just take and typical patients of ours, one relative is in abroad here, one doctor is in NHS, he took my interview on the phone, tame su karso e baddu, just imagine. In the meanwhile, heart is failing, legs are dying. In any case, took for angio in the morning at 7, 1 p.m. operated her same day after having given heparin. From there, went to the ICU, organism is sepsis, renal shutdown, survived all of that, celebrated her birthday with us, recovered as much as possible, some deficit was there, but recovered from that and went home. This one you may be knowing, Devendra Bhai. He had come to us in emergency, completely paralyzed from the neck down. Now, this is not an uneducated man who doesn't know what could happen in the spine. But this guy went about 50 places with all these files, everybody except a doctor. Except a doctor, he has gone to everything else. I won't name that. And he has become totally paralyzed from neck down and has come in an emergency. Now, thing is, I just got a call. મને ખબર નહીં હતું કે એ સાહેબ છે. I just knew a patient is there. તો પહેલા તો બે ગાળ આપી. શું કરતા હતા એટલા દિવસ? And he's totally zero from down. So I told him, see, they were planning. Actually, એ પહેલા બીજા હોસ્પિટલમાં ગયા હતા. ત્યાં they knew who he was. They have written, referred to Mumbai. Not even hospital name. Just get the hell out of here. कौन टच करसे? Quadriplegic patient, VIP. I didn't know that. So I told him, see, if you go to Mumbai now, 6 hours to minimum drive છે. ક્યારે operation થશે? By that time, this is going to become zero anyways. If you trust what I'm going to do, I'll do the best possible thing and we can take a chance. Fortunately, agreed from zero. This is recovery after a month. Completely recovery થઈને, he has joined back. Again, he's on duty. So now just trying to wake you up once again, I need you to answer this. How long did the 100-year war between England and France last? Anybody? 100 seems obvious, right? It's not. And you can check all of these right now on your phone. These are all true. Which animal do you get cat gut? This is an easy one, not from cats. I hope you know. Hey. It's from sheep and horses. In which month do Russians celebrate October Revolution? I suppose by now you got the hang of this. This is not October. Yes, yes, sir knows it. November, nice. And camel's hair brush again does not come from camel, it comes from squirrel fur. See, what I'm trying to tell you is that you already have an impression of what, you know that there is spine surgery going on somewhere, and you have an impression of what goes on. But that can be a very wrong impression because even doctors nowadays, I have seen advising patients के spine में तो result ज ना मरे, spine operation तो करवानुं ज नहीं. Doctors advising patients. You can imagine what happens to patients then. And I am seeing this every day. So I am requesting you, remove your preconceived notions from your head. What I'm showing you is not what the average people are doing outside in a government hospital in a bad setup. This is state-of-the-art surgery. It has become standard now. So earlier we had only X-rays. Then we went on to having everything, CT, MRI, 3D CT. Look at the CT scan. There is a fracture. You can see the smallest possible fragment. So we have angio. You can see it inside the body, see the organs. High quality CM machines inside the operation theater. We know exactly what's happening inside. So just look at this one. This is a benign bone tumor of the spine. 20 years back, the only treatment was open the chest, go inside, remove the tumor, put a cage, put a plate. Now what we can do, just put a needle, a thick needle inside, do an indirect decompression. From that we get the biopsy on table as frozen, put bone cement, vertebroplasty, immediately patient starts walking. That is what minimally invasive surgery has become now. Obviously, we have operating microscopes, so the nerve which you cannot see from the eye, we can see so big, even if I try, I will not injure it. Importantly, we have neuromonitoring. Now, do you all know about neuromonitoring? So, just like you know ECG, you have been using ECG. How many doctors are there? Can I see a raise of hands, please? All right, that's why I was wondering why people don't know ECG. All right, so for people who don't know, ECG you have seen in movies, yeah? ECG of the heart. So it is an electrical signal of the heart. The similarly thing for the nerve is called an NCV, right? An EMG for the muscles and NCV for the nerve. This is a live NCV during surgery. Now why this is important? Surgeries are done in anesthesia. Patient is turned over. Suppose I'm doing a scoliosis correction. I cannot see all the nerves. Suppose I do a correction, some nerve is getting stretched. After closing, we turn over and now the patient not moving the legs. What do we have to do? Put under anesthesia again, turn over, go inside, make a correction and hope that the nerve has recovered. And then again close and then turn over and then check whether improvement is happening. The nerve will die. So this is the only machine which gives you live feedback that even if I touch a nerve, this will start beeping. So before the injury happens, we can stop the injury from happening. So once you have this, the chance of having a neurodeficit is very, very less. So this is about our department. Now it has become a high volume center. I have personally done a lot of surgeries, also experienced in multiple hospitals, and in all the spine techniques available in the country, we have it at Shalby Hospital, Surat. And this is about just my training and all, FNB spine from Ganga and Germany. We'll skip that. So now, coming to the point, is minimally invasive surgery just a fad? Because any surgery you see nowadays.
Sir, last 1 minute.
All right. When you say stop, I'll stop. It's
It was shown long back. I told after 2 minutes.
Sure, sure. Whenever you say. All right. So this is how you imagine surgery should be, right? This is in your head, all blood flying around, the dura and open screws. Now, what is the problem with this? This is the cross section of your abdomen. For doctors, they know, right? If we enlarge this part, this is the vertebra, and these are the back muscles, the muscles in your back. Now, just look at this. This is cross section of one surgery done before and one surgery done after. Just look at these areas. The area which was brown, which was filled with muscles, is now filled with this white tissue, which is fibrosis. That is dead tissue. That is going to pain for life. There is no coming. You cannot transplant muscle. You cannot build it with physio. That part is dead. It is going to pain. So if you do an open surgery and cut off the muscle, like we were doing before 20 years back, constant pain is going to happen. So because of that, there was fear of surgery, continued back pain, even in good surgeries, open surgeries. But now we've come to this, we call it the zero technique. Like it is endoscopy. Just look at that, there is no blood. The endoscope goes from the side. It is a very small cut. It can be done in local anesthesia. So forget about heart failure, liver disease, kidney disease, doesn't matter. You can do in local anesthesia. Patient is awake and talking to you. Live neuromonitoring, even if I touch the nerve, patient will tell me it's hurting. So I won't touch. So completely safe. And after the surgery, immediately, from here we have come to here. So just one case, this is the disc, removed, the fragment. Oops, sorry. Well, the video that I'm showing, you can see it's inside the operation theater. There was a time when after doing surgery, patient used to be in bed sometimes for months. Then it became weak. At least nowadays, most surgeries, they stay for a few days in bed. But if you do surgery like this without disturbing any normal tissue, the patient will walk from the operation theater itself. They can just walk out and walk to their room and take a discharge and go home. So we just keep the patient because 24 hours is required for the insurance. Other than that, we can actually send him home by the evening. So do we have some time?
No, sir.
No.
We have 2 more lectures.
All right. If there are any questions, yeah, sure. If there are any questions, I'll take it.
Sir, questions during tea time.
Okay, fine. Thank you.
So I'll call Hitesh bhai also and we'll give them a memento. Hitesh bhai, please. Hitesh bhai is to leave.
So I would request Shubham sir to please share the memento to Dr. Hitesh and Dr. Gaurav. Can we have a huge round of applause for both the lovely speakers? For the wonderful presentation by both our honorable speakers over here at Gujcon 25, hosted by IOH Surat. जोरदार तालियां होनी चाहिए दोस्तों for valuable presentation and knowledge sharing. Thank you, Jayan sir. Thank you, Shubham sir. Next, we have Dr. Tapan Desai. The topic is AI in healthcare. Dr. Tapan Desai has a clinic in Valsad and Pardi. Thank you. सर एक सेकंड. हाँ. Dr. Kishore Parekh sir and Dr. Hitesh Singhala sir. We have Dr. Tapan Desai. Sir.
Should I? Very boring topic, but friends, it is very, thank you. It is very much interesting topic so far. If you want to survive in the world of 2020-30. Okay, so basically I am not a tech savvy. I am not an IT professional. I am just a simply dentist, but having a good knowledge of a technology, and I used to play with some technologies. So I am the person who has designed one software for a medical field. I will talk to you in my lecture. Okay. So the lesson to learn from today is, even if there are so many technologies arrived in this world, the technology won't work without electrification. The technology will not work with the help of humans. भाई होगा क्या presentation चालू या फिर ऐसे दे दूं? चलेगा. Good, fine. They are trying. So I use ChatGPT. आप लोग use करते हो क्या ChatGPT? Everybody is using. So one day I asked ChatGPT, अगर आपको एक दिन human बनना हो तो what you will do? So I asked ChatGPT, if you want to become a human for one day, if you have a heart for one day, what you will do? And the answer I got from the ChatGPT is, number one, I will see the sky. I will smile, I will cry, I will find you, and I will talk with you. That means technology doesn't have emotions. Technology doesn't have feelings. So friends, the word most important sentence is, AI will never ever take place of any human. But the person who is AI empowered, the person who is powerful in using technologies will definitely replace you. Be it in the medical field, be it into a general, regular technologies. कनेक्ट नहीं हो पा रहा है. That's fine. So there is a technical glitch we are facing since afternoon, but don't worry about it. I will speak what I have to. And how many of you are into private practice? The question number one. आप लोग सब प्राइवेट प्रैक्टिशनर हो? Anybody is using practice management software? आप लोग यूज करते हो practice management software? So of course you are the authority. Everybody is using practice management software. So how you are using this practice management software? Only for data management, or you record all the data, you put everything in the software and try to evaluate what is happening in your practice? Okay. So there were two lectures. The earlier lecture was about the AI. The second lecture was about the medico-legal issues. And the third is the advanced technology. So remember, all these three has to be empowered with AI. You must have all the data of the patient. You must have all the tactics, all the procedures, all the X-rays, photographs, scan, MRI, investigations, prescription, whatever you have mentioned, whatever procedures you have done, it has to be in your presentation, in your practice management software. You must have consent. You must have digital consent as well as the physical consent. Earlier in the court, it was mentioned that there was no any digital consent. But now, as if you have a video consent, I have designed one software which has a digital consent in it. Unfortunately, nothing is working. So if you are using such type of software that will make your life easy, like Practo, Clinicia, Clinify, Kiwi Health, there are so many software. How AI will empower first into a medical technology, where it comes into a diagnosis, then comes into a surgical planning, then comes into a treatment, then comes to your data analysis, and lastly into about research. Starting from a medical diagnosis, whereas we are into a remote area where we are practicing into a tier 3 city, what we are lacking is the human resources. We are suffering from a trained technical staff. But there are software with the name of Visco AI, which is the assistant nurse, which has an AI nurse. So whatever you mention, the software will tell you which are the procedures you have to perform, which precautions patient has to take. Then comes there are so many software, all the radiologists, all the CT scan and MRI centers using these AI technologies, all the pathology laboratory using these technologies. So without this presentation, I think I am little not able to convey the message that what AI will help you. But the only thing what I can say is, without AI, you are not going to survive for the future period of time. Being into medical field, there are so many smartwatches are now available. There are devices which can monitor your sleep pattern, which can monitor your heart rate, pulse rate, SpO2 levels. According to that, you can manage the critical situations. Then there are so many apps and the devices now coming which can continuously monitor your heart rate. So anything, any ECG, the fluctuation in the ECG that can be recorded on this smartwatch, and immediately you can go to a nearby center and the life of the patient will be saved. I think I'm going to conclude my lecture because without presentation I'm not going to waste you people's time. Thank you so much. Some other next time maybe I will come up with something better thing. Thank you so much.
Thank you, Dr. Tapan Desai. From the Surat committee, we are sorry we will not provide that, but within 2-3 minutes you nicely explained. And we are shortage of the time, so we will not discuss any question answer. If you have any query, you can discuss during the tea time. Thank you.
Thank you, Dr. Tapan. It was very short and very informative, very useful session. Now, the next speaker is Dr. Chintan Patel. He is from Twin City Clinic, Vapi. He'll speak on basic of chest X-ray and basic of EFT. It is very, very important subject for all OH physicians. So, Dr. Chintan Patel, the floor is yours.
Very good evening, everyone. I know that this is post-lunch session and the last session which is going to happen. So I'm really thankful to Iaoh Surat and Gujcon 2025. It had been a very good event these 2 days, from like miracles, robot, AI, and many surgical advances which has been shown. But today I'm going to speak something very basic, which is very much essential to any of the occupational therapist or industrial health expert and professionals. So let's talk something about lungs. और lungs में दो चीज़ें बहुत important, that is your chest X-ray and pulmonary function test. Before we start, can we take a deep breath and exhale? और एक बार And can somebody from the audience can tell कि 24 घंटे में in 24 hours how many times do we take inhalation and exhalation? Anyone from the audience? हमने brain के बारे में भी सुन लिया, ये spine के बारे में भी सुन लिया. So anybody from the audience? In 24 hours, it's 21,000. Around 21,000 breaths we take in 24 hours. So something which is very important, which is dynamic, हर बार connections बाहर से और internal चीजें हो रही है. So we're gonna talk something about it. Okay? So essentials of X-ray and BFT. In like 15 minutes I'm given, I try to justify whatever I want to deliver. So why it is essential? Because in day-to-day practices or in emergencies, X-rays can be done easily. So same is for any of who is an industrial health expert, because it is readily available, easily accessible, and a very cost-effective tool to diagnose any of the respiratory illnesses like infection, fibrosis, interstitial lung diseases, obstructive airway diseases, any inhalation injuries or fractures. So before we do or read any of the chest X-rays, it is very essential that we know that this is the X-ray of the same person. So that's why name, age, and sex is very much essential. Also, the projection of the X-ray, whether it is AP view, PA view, or it is any of the lateral views or the views which is the doctor has recommended. Position, it has to be in full inspiration and erect spine. As now we are sitting here in a very recumbent position, we cannot do a chest X-ray in that position. Also, the pulmonary function test cannot be done in that position. The person has to be in an erect position. Rotation, while doing a chest X-ray, somebody cannot stand this way, this way. It has to be a proper demarcated position. Then and then, the reading of the chest X-ray can be in a better. And also, the exposure has to be very good. So you can see a chest X-ray here where you can see certain demarcations. So how do we approach? Whenever we see or read a chest X-ray, go in a very systematic way. Normally we do a chest X-ray to see any kind of lesion in the lungs. But when we read the chest X-ray, it is the last part which needs to be evaluated. So before that, what we will do is we'll see the airways, we'll see the bones and soft tissues, we'll see the cardiac sellout, we'll see the diaphragms, we'll see the CP angles, and at the end we will see the lungs in a zigzag manner, considering right and left lung in a Z technique. So this is a normal chest X-ray where you can see centrally there is a trachea, in the center there is a heart, besides both the sides there is lungs. So when we are assessing or reading a chest X-ray, what we see is airways. So airways is centrally placed. In the left side you can see two X-rays, with one with label and one without label, where you can see that there is deviation of the trachea. So when you see the airways, you see the trachea, you see the carina, and you see the bronchis. So when you see this, you will be able to justify whether there is any tracheal deviation or pull. So in this X-ray, you will be able to see two different etiologies. One is pneumothorax and another is pleural effusion. In both the cases, there is shift of mediastinum and there is shift of trachea. So this is how you will be able to demarcate. Bones and soft tissues. So whenever you are seeing an X-ray, look for the clavicles, look for the anterior ribs, posterior ribs, your scapula, which will be fanned out. So also look for your vertebra. So any kind of any bony pathologies, whether it is fracture, you would be able to see. Also, there can be bony calcifications which you will be able to demarcate, which is essential from industrial health point of view. Cardiac sellout. You know what structures lies in the mediastinum and cardiac. The heart, also in the right side there is right atrium, left side it's left ventricle, the aortic knuckle, the pulmonary conus, the pulmonary veins passing there. So this is how you can know what structure is behind that And if there is abnormality of this mediastinal structures, you will be able to decide. So this is how, like if there is a cardiomegaly, from an X-ray you will be able to know that cardiothoracic ratio is changed. Also, if you can see the left side of the heart, it is obscured with an homogeneous opacity and the CP angle is blunt. So it can be a pleural effusion or it can be a mass also. So this is how you will be able to demarcate. Diaphragm and costophrenic or cardiophrenic angles, very essential, because the shape of the diaphragm is essential. The elevation or where the placement of the diaphragm is there, because left side your diaphragm will be on the lower side because of the placement of the heart. Also, when you see the diaphragms, the shape, when there is pleural effusion, it would be like the convexity will change when there is pleural effusion or any kind of air collection is there. Also, when you see the angles, the cardiophrenic and costophrenic angles, both needs to be evaluated. So, from occupational health point of view, there can be pleural calcifications which you can see on the pleural spaces. Now, it is all about lungs. When you are looking at the lungs, always consider 3 zones, and that also right and left. When you are seeing the upper zone on the right side, consider same thing on the left side. When you are seeing on the middle zone, consider same on the left side. Same holds for your lower zones, right and left. So always use right and left in a zigzag or a Z manner whenever you are evaluating the lungs. When you are seeing the lungs, look for infiltrates, look for opacities. Once it is done, look for the hilar shadows, whether there is something enlargement is there, so that you can know about the mediastinum lymphadenopathy or a mass in the mediastinum. If it is like ICU patient, you can look for like NG tube, or there can be endotracheal tube or a CVP line which is there. Sometimes pacemaker also be seen. So what interests you more is about such X-rays. Okay, from industrial health point of view, when there is exposure of certain fumes or industrial dust for a long period of time, it can be like 15 years, 20 years, there can be silicosis, asbestosis or interstitial lung diseases. And when the exposure is more, if there is destruction of lung or parenchyma from inside, infections like tuberculosis can also occur. There are certain red flags which not a single MBBS person should miss. That is pneumothorax, tension pneumothorax particularly, collapse of the lung, mass, pleural effusion, and cavity in the lungs. So this was about chest X-ray with like basic interpretation and certain opacities or abnormal things which can be demarcated. Let's go to another part, which is pulmonary function test. We talked about anatomy. Now we're going to talk about physiology, where anatomical applications which we can consider in the pulmonary. Why it is essential? It is readily available, easy to interpret, in which you can diagnose obstructive and restrictive lung diseases from a single test. So what are the components which we usually see? In spirometry, we see the lung volumes. Lung volumes, we can know the total lung capacity, at the same time the reserve volumes, diffusion capacity of the lung in certain restrictive lung diseases like interstitial lung disease, flow rates, PFR. So when we were just interacting and when I was preparing this slide also, why I have kept specifically these 4 parts? This PEFR, it is a very 350 rupees available, a small tool which you can use in a regular practice. कि आप सारे workers को आप every month you can do this PFR test and you can see the variability. Second is your spirometry. You can repeat the test every 4 months or 3 months to see the variability. At the same time, the seasonal changes which occurs, like somebody's PFT would be different in monsoon, winters, and at the same time in summers. So that variability you would be able to detect. Once any abnormality is detected, or if you feel that this person can have restrictive lung diseases, DLCO should be done at least a year or 6 months to see whether this person is worsening or static. And lung volumes can be assessed with a bloody plethysmography if you find it maybe 2 years or 3 years once in a while. So how do we do it? Normally, if patient is on any of the bronchodilator medications, whether inhalation or oral, should be avoided for at least 6 to 8 hours and preferably 24 to 48 hours, because this can interact, the interpretation will change. Also, instruction to the patient is very essential. If you don't instruct the patient correctly, like sitting this way and doing, patient is anxious, then definitely it is not going to happen. Also, the nose clip needs to be used, which is most of the time we see that people don't use the nose clip because that inhalation and exhalation has to occur through mouth. Also, even if there is some leakage from the mouthpiece, your interpretation won't be right. Also, when you do the test, it is very essential that you do 3 maneuvers, very essential, and from it, the best maneuver has to be taken. But make sure that all 3 maneuvers are done with good efforts, because if the effort is not good, then you won't be able to reproduce what you see. Sometimes people just like blow into the PEFT machine, so like, this is how not the test is done, because when you do this test, there has to be a proper inhalation and exhalation which has to occur, and then you will be able to get the loops, which is the base core of your pulmonary function test. So whenever you do it, it has to be a full inhalation and an exhalation. So it has to be like this. This is how a test will start and end, because your FEV1 is the first second. Your flow is for entire 6 seconds, and a full inhalation will only give you an inspiratory loop. Otherwise, this test is obscure. You do 100 tests, it would be a false report. So whenever you're doing, make sure the start is good, as I demonstrated. There should be no cough or hesitation from the patient. Also, you should, or the technician should, assess that the effort is good. If the effort is not good and not reproducible, I mean, you can avoid the test on that day and you can call the patient again to see the documented pulmonary function test. And of those, you need to choose the best one. So once you have assessed the quality, you need to see the pattern of the loops. So what I showed you in the demonstration of deep inhalation and exhalation. So whenever there is a deep, yes sir, yeah, got it, 2 minutes. Yeah, yes sir. So whenever you take a deep inhalation, the first FE max, you can see the up arrow will happen. And when you exhale for 6 counts, that the down arrow will up. And the inspiration, this loop will be found. In this way, you can find out obstruction, restriction, or whether it is a normal pattern. So once you find that it is an obstruction, assess the severity. You can use any of the criteria, ATS or GOLD criteria, to identify it. Once you have seen the obstruction, check for bronchodilator reversibility. So you can use any of your Asthaline or Duolin to see the bronchodilator reversibility, which is FEV1 and FVC should be less than 12% and less than 200 ml. If it is less, there is no reversibility. If it is more, the reversibility is good. This way you can see whether it is a reversible airway disease or irreversible airway disease. The flow volume loops will make you identify whether it is normal, restrictive, or obstructive. You can clearly see that the picture is totally different. Also, if you have something fixed obstruction, whether it is inside the airways or whether it is extrathoracic, you will be able to identify from this graph. So it was about spirometry, but as we have seen about AI and miracles and robots and XYZ things, we too have advanced pulmonary function tests like DLCO, body box. Now we have a more simplified version where the spirometry is forced, whether this advanced test can be done at a normal tidal volume. So from this case, what you will see, 45-year gentleman, 20 years of factory employee, chronic cough, occasional dyspnea, chest X-ray is normal, PFT shows a reversibility test which is less than 12%. Any diagnosis, spot diagnosis? Anyone? From the loops, normal chest X-ray, reversibility is less than 12%. This is a case of COPD, chronic obstructive pulmonary disease. If had been a reversibility, it would have been asthma. So the take-home message is, check the quality, pattern, severity, reversibility. Clinical correlation is must. Chronic exposure in our field is very much necessary that we take the history. What is the spot diagnosis for this chest X-ray? Anyone? Just go through A, B, C, D, E. So here if you can see the airways, the central airways is deviated to the left, the carina is at T4 normal. You can see there is pruning or hyperbronchovascular in the right lower zone. Left upper zone you can see there is some inhomogeneous opacity with some central cavitation. Your left diaphragm is elevated with some fibrosis. So it can be an active COX or a past history of tuberculosis which can have a reactivation with fungal infection. So take home message from chest X-rays, technique and exposure very much essential. A, B, C, D, E is very much essential when you do it. Clinical correlation very much yes. Never miss the red flags, very essential. So whenever you see a chest X-ray, I say that read it like a book, very much essential. And TFTs are not just a test for the lungs, they help us breathe clarity to the diagnosis. So anatomically and physiologically, if you see, the chest X-ray and pulmonary function test are essential tool to any industrial health expert. Thank you so much IOH and at the same time Gujcon 2025 for giving me this opportunity to speak.
Thank you so much, Dr. Chintan Patel. It was excellent presentation and you have explained basics of exercise as well as the PFT in very simple way. As today we are running so much, the time is so much, I think we are late for the validation function also. So here we conclude. You can ask questions during tea time too.
Yes, thank you so much, sir.
Thank you. And we are thankful to organize with my co-chairperson, Dr. Hitesh Singhala. Thank you so much.
I would request Dr. Tapan sir, Dr. Tapan Desai and Dr. Chintan Patel sir to join us on the center stage, and I would request both our chairperson to felicitate with Bijal sir. Bijal sir, I would request you to please join us on stage for the token, a memento to both our speakers, Dr. Tapan Desai sir and Dr. Chintan Patel sir. Guys, एक बार जोरदार तालियां हो जाए for Dr. Tapan Desai on behalf of Gujcon 2025, hosted by IOH Surat and Dr. Chintan Patel. Guys, a big round of applause. Thank you so much, sir. I would request Bijal sir to hand over. Okay. The chairpersons are requested to please be here, and Bijal sir, I would request you to please a token of love and appreciation on behalf of IOH Surat Gujcon 2025. एक बार जोरदार तालियां हो जाए. Thank you, Shubham sir, and now I would request Bijal sir for some important announcements for everybody over here.
And I'll request all the stall delegates to just come forward to collect their gifts by the time sir gives his presentation. Who are present in the hall, please.
Good afternoon, everyone. As we are already running late, first of all, I would like to congratulate the organizing chairman, organizing secretary, and the entire team of Gujcon 2025 for a grand show. From last 4 months, whenever they have opened their mouth, they always talked about Gujcon 25. Even they called me at 7 a.m. or whether 11 p.m. They were always talking about Gujcon. So congratulations for a grand event. Just a small announcement. There is always one state conference that is called as GIMACON and one national conference called as NETCON. This is the 100th National Conference of Indian Medical Association, and first time ever, this time state conference and national conference are going to get organized together. So 26th is Gujcon, and in the evening it is pre-conference workshop for NatCon, and 27th-28th of December is going to be NatCon at a beautiful ambience of Club 7 Ahmedabad. I request on the behalf of Indian Medical Association, being Vice President of IMA South Zone, all of you to invite at NatCon 2025. It is going to be a grand event, and we are expecting more than 5,000 delegates. And our own Dr. Anil Naik sir from Gujarat is going to take over as National President of Indian Medical Association. It's a great news for all of us. So I welcome you all on the behalf of Indian Medical Association again. Thank you.
Thank you so much, Bijal sir, for the important announcement. Now I would request Dr. Shubham Jain sir to please join us on stage and take the closing ceremony and the felicitation forward. Let me tell you, it has been an insightful 2 days. जितने भी लोग बैठे हैं, एक बार जोरदार तालियां हो जाए for Gujcon 2025. What a great success. So many speakers, so many hard work of so many hard and important people like Shubham sir and their entire team of Iaoh at Surat, Jayan sir, all the senior people over here, those who are present from the Surat team are requested to join. And I would also like to request Shubham sir to please join us on the podium.
Yeah, first of all, thank you all. At the end of the 4 months of marathon, we are really exhausted, and we had 445 delegates, which is, I think, a history in making in Gujcon, and most of them, like, they have stayed back till the end. It's not the time to announce that we had this around 25 scientific paper presentations, and it's the time to announce the winner. The winner is Dr. Rohan Kosambia. Please give him a warm hand. I think he has gone from Namo Silvasa. If anyone from Namo College is there? Okay. Anyone from Namo College is there behind? Yeah, please, you come. You give it to him. And with the consent of Kamat Sahib, we have named the trophy as Paldikar Mewada Trophy, because these two people, they are the icons of occupational health in Gujarat, and they have trained more than thousands. Kamat Sahib, please come on the stage. Please come on the stage. Let him. The name is now Paldikar Mewada Trophy, and we have a forum of all the 7 branches. Now any branch who is hosting Gujcon, the trophy for the best presentation will be named as Paldikar Mewada Trophy. And the runner-up is Dr. Prakash Kumar Desai, Senior Medical Officer, Vadodara Manufacturing Division, Reliance Industries Limited. And his topic was effectiveness of hearing control program in large petrochemical industry, a longitudinal study. A very warm, please, applause. And for the first time, apart from these trophies, we have given them a complimentary Parker pen also, which I think that is also first in Gujcon. Like all the paper presentations, they were given something. मतलब लोगों के दिमाग में रहता है कि इसमें मेरे लिए क्या है. I have read so many times, what is in it for me? मेरे लिए क्या है? अगर मैं present करता हूँ, ठीक है, certificate is another thing. So, and I will also like to call our stall partners, Hygia, Jain bhai, Hygia ka trophy. Hygia, Mr. Ranjit. Ranjit, come with your team, please. Photo. Yeah. Hygia Services, We had 26 stalls. I think that is also history. I think in Gujcon, 26 stalls. It was a beautiful stall area, and all supported us very well. Yeah. Alpesh, you also come. Alpesh, come. Alpesh. Eon Med. Doctor Store. HCL Healthcare, Dr. Gupta. HCL, many people have left, but Dr. Gupta is still here with us, as his train is in the evening. Then Dr. Store, Tracky. Now I would like to call one person जिसको मैंने 3 महीने में बहुत परेशान किया है और हमेशा वो बोलता है सर नहीं हो पाएगा, फिर वो करके देता है। तो मुजम्मिल, जीएम फ्रॉम मीरासोल, प्लीज मुजम्मिल गिव यू अ वार्म हैंड। बहुत इन्होंने हमारा हेल्प किया। इवन आज 10 बजे का चेकआउट था, वो भी काफी लोग बैठे हैं, मतलब अभी तक चेकआउट किया नहीं है। तो दैट इज सेल्फ सेज फॉर हिज सपोर्ट। Anyone else left from the stalls? Stall वाले कोई हैं जिनको नहीं मिला है? Okay.
This year we have introduced new category. Those who have given solid support for the success of Gujcon. And the winner is, the man of the series is Dr. Shubham Jain. And we are felicitating him with the blazer on behalf of Iaoh Surat and Gujcon 25. Another person, Dr. Jagdish Kamath, who has supported us from far distance, but we never felt that he is far. He was just in our heart, and he has helped in many ways for finalizing stalls as well as members from Vadodara IOH. He has done more than 25 members for this Gujcon, as well as he helped us in getting many stalls. And he is one of the very experienced player organizing conferences. So we are thankful to Dr. Jagdish Kamath for his unwavering support, untiring, and he has advised and guided us in many ways to, and success is yours, sir. We are just hard workers. We got many references, many help from you, many suggestions, which helped us in doing this conference in with grand success and in great way. Thank you very much, Kamath sir.
Yes.
ગુડ ઇવનિંગ એવરીબડી. હું હંમેશા કહું છું કે કોન્ફરન્સ કરવાની હોય ને તો એમાં બહુ મોટો પ્રયત્ન જોઈએ. આઈ હોપ આઈ એવરીબડી અન્ડરસ્ટેન્ડ ગુજરાતી. કારણ કે કોન્ફરન્સ કરવી એટલે બહુ મોટું યજ્ઞ કરવું અને 100 છોકરીઓને જાણે સાથે પહેણાવવાની હોય એટલું મોટો યજ્ઞ છે. જાત જાતની આત્મા પરમાત્મા એક મોટું સંયુક્ત કુટુંબના લોકો જ્યારે લગ્ન લઈને બેસે ત્યારે બધાને ઇન્ક્લુડ કરવા પડે. શુભમે જ્યારે પહેલાં વાત કરી ઘણા વખત પહેલાં તો મેં શુભમને કીધું, શુભમ શાંતિ રાખજે, સારી ટીમ બનાવો. અને શરૂઆતમાં એને જ્યારે પહેલાં પગલાં લીધા હું એને ઘણા વર્ષથી ઓળખતો હતો. મેં કહું ભાઈ પહેલાં આમાં હિંમત જોઈશે તારે અને અત્યંત પ્રયત્ન કરવા પડશે. યુ વિલ હેવ ટુ ડુ નથિંગ બટ હાર્ડવર્ક એન્ડ દેર ઇઝ નો ઓલ્ટરનેટિવ ટુ હાર્ડવર્ક. જયંતભાઈને હું વર્ષોથી જાણતો હતો. હું ને અમારા સિનિયર વાઇસ પ્રેસિડન્ટ ડૉક્ટર કિશોર પરીખ ઓકુકાન વખતે આવ્યા હતા. જયંતભાઈ બહુ યથાર્થ પ્રયત્ન કર્યા એઝ અ GM L&T. અને અમે 24માં બહુ મોટી નેશનલ કોન્ફરન્સ કરી હતી બીજી વાર. એટલે અમને ખબર હતી કે આમાં બહુ જ સારું આયોજન કરવું પડશે, વહેલીથી પ્લાનિંગ કરવું પડશે, બધાને ભેગા કરવા પડશે, બીજી 6 બ્રાન્ચોનું કોર્ડિનેશન કરવું પડશે. એટલે આ બધું ચાલુ કર્યું અમે શરૂઆતમાં. But I think we should give a very big round of applause to the entire team because they have done a marvelous job. Sitting in Surat, they have been able to organize in a place like Daman. The basic reasons why they were very successful, I can give a few points. First, they did a lot of excellent planning. કોઈ પણ કામનું તમારે આયોજન કરવું હોય તો યુ હેવ ટુ વર્ક યોર પ્લાન, પ્લાન યોર વર્ક. અમારા ગુરુ ડૉક્ટર પરલીકર હંમેશા અમને શીખવાડતા કે આયોજન કર, લખી લે, કાગળમાં લખ. So first and most important, they have done excellent planning. They started planning well back, much before, I think 6 months. Then we used to organize one event in 7th June. Kishore bhai and Jain bhai were able to persuade our team. અમે 7 જૂનની અમે કોન્ફરન્સ હવે 20 સપ્ટેમ્બરે લઈ ગયા છે. So on behalf of Vadodara branch, we expect support from Iaoh Surat. અને I think એ દિવસે તમે કમિટ કર્યું હતું કે 30 માણસો અમારા સપ્ટેમ્બરની કોન્ફરન્સમાં આવશે એટલે બસ ભરીને લાવજો. Number 2. Second important point was they had a very good social media coverage. The brochure was excellent. Shubham designed the brochure well. Of course, I advised him one more thing. Yeah, he and Kemaut did a very good job. મેં કીધું ભાઈ પૈસા તમારા ભેગા થવા જોઈએ. કોન્ફરન્સ કે જો પૈસા ભેગા ના થાય then it's not worth it. So second important plus point was good amount of financial planning. Then they used the technology. Throughout the day we have been learning integration technology. So Subham and Jayan bhai were very good at inducing technology. અને મીટિંગો કરતા વિડીયો મીટિંગ એ પણ સસ્તી, એકદમ કોસ્ટ ઇફેક્ટિવ, ઓછા ભાવે વધારે આઉટપુટ, રાઈટ? So that was another plus point. The venue was very good. The ambience was excellent. They did good fiscal planning. Early bird પર બહુ પુશ કરતા અને the amount of efforts I think Shubham has done. 4 મહિનાથી ધૂણતો હતો ખાલી. He was just grumbling, Gujcon, Gujcon, Gujcon. So thanks to Shubham, he reserves a true એક છેડોને સાચવી રાખ્યો. And I think the result is very obvious. They have done an excellent conference. The fiscal planning was good. I am very happy to note the scientific sessions were very good from good hospitals. The use of AI in the scientific agenda was good. The introduction of medicals, like no idea છે કે નજીકની મેડિકલ કોલેજના સ્ટુડન્ટ્સને તમે ઇન્વોલ્વ કરો, યંગર જનરેશનને ઇન્વોલ્વ કરો. દેટ ઇઝ વન મોર આઈડિયા વિચ ધી અંકલેશ્વર ભરૂચ બ્રાન્ચવાળા કોઈ છે બેઠા છે અહીંયા? અંકલેશ્વર ભરૂચ કોઈ છે નહીં, બધા નીકળી ગયા. હા બેઠા છે. તમારે આ ધ્યાન રાખવાની જરૂર છે. મેડિકલ કોલેજને ઇન્ક્લુડ કરો અને વોટ્સએપનો ઉપયોગ સારામાં સારો કર્યો. એટલે આઈ થિંક યસ, એટલે વોટ્સએપનો બહુ સારો ઉપયોગ કર્યો. ફ્યુ points for you to keep in mind that this is a conference of occupational medicine, Jayanbhai. So next time જે નવા ઓર્ગેનાઇઝર્સ છે એમને એક અપીલ છે કે કે તમે કોઈ બેલેન્સ રાખો. આઈ નો કે કોન્ફરન્સમાં એજન્ડાને તમારે બેલેન્સ કરવો પડે, કોમર્શિયલ અને એકેડેમિક. So few topics on occupational health would have been included, then the people who have come from industries would have been more satisfied. There was one message from a senior person કે તમે ડૉક્ટર કામત ઇનોગ્રેશન ફંક્શનનો એક પ્રોટોકોલ બનાવો, કારણ કે ઇનોગ્રેશન ફંક્શન વોઝ નોટ વેરી વેલ પ્લાન. ખાસ કરીને જે બ્યુરોક્રેટ્સ આવ્યા હતા, the way they were behaving, it was not in good taste to professionals like us. So these are two simple points. કારણ કે inaugural function has to be very meticulously planned. We had the national president, Dr. Hitesh Singhalla. So I think એમને મધ્યમાં રાખવા જોઈએ, કારણ કે અમારા આખા એસોસિએશનના પ્રમુખ છે. He is Mr. President. So he should have been kept in the center of the entire event. These are two feedbacks from, not from the critical point of view, but for us to learn. So I think it is altogether an excellent work, and I hope this is the beginning. You have to make your branch stronger, because all of us, all the 7 branches in Gujarat, have to go ahead. If Kishore Bhai agrees, we are 25% of the membership of all India level. We are 7 branches, and I hope from 725 in Gujarat, under the leadership of Dr. Singhalla as president and Dr. Kishore Parikh, we should reach the mark of 1,000. Thank you, everybody. Long live Iaoh, long live India.
Now I would like our national president, Dr. Hitesh Singhalla, to say a few words.
મજા પડી ગઈ ને, જલસો પડી ગયો ને. ડૉક્ટર શુભમ જૈન એન્ડ ડૉક્ટર જયંત પટેલના રાજમાં હા તો બોલો. યસ, એગ્રી.
કાલ રાતનો પૂછો પછી હા બોલશો.
Yes. The Gujcon is well organized and your hard work paid off. It is well organized, informative Gujcon 2025. The conference chairman Dr. Jayant Patel, organizing secretary Dr. Shubham Jain, chairman delegate committee Dr. Bijal Kapadia, and Surat and whole Surat organizing committee worked tirelessly to make this conference a grand success. More than 425 delegates across the country have been registered. This is a great achievement. I wish to congratulate all for that. I appreciate the time and efforts put by the Shubham Jain. I really appreciate all of your hard work. Your hospitality made the event truly successful. And you can say the scientific session was excellent. And કાલ રાત્રે જે શુભમ જઈને જલસા કરાવ્યા, really is amazing. Thank you. And next time, Ankleshwar branch is ready to organize the Gujcon. So Ankleshwar branch, please, Ankleshwar branch member, please come down. Please come off the stage. Look, madam, yeah. You want to say something? We are ready to organize.
ગુજકોન 26 ની મારી ઈચ્છા છે કે અંકલેશ્વર ભરૂચને મળે. એના માટે હું બધાને આગ્રહ કરું છું અને બધા માણસોની, મારા ઓફિસ બેરર્સની, નેશનલ પ્રેસિડેન્ટની અને બધાની શુભેચ્છાઓ ઈચ્છું છું કે મને ગુજકોન 26 અંકલેશ્વર ભરૂચને મળે એવી હું આશા રાખું છું. થેન્ક યુ.
I'll request National President to honor our chairman, conference chairman, Dr. Jayant Patel. Next is Dr. Kirit Solanki. Kirit Solanki, खुद ही ले जाओ ट्रॉफी. कामत साहिब. Dr. Vijay Patel, he has really been like a right hand to me in entire thing. And Dr. Kirit, entire scientific, he has handled single-handedly with the guidance of Gupta sir. So really hats off to him. 3-4 days back, I was a lot of tension, did not sleep entire night. I called up Kirit, I think morning 5:30, and he gave me assurance that Shubham bhai, everything will be done. Don't worry, आप वापिस हो जाओ. मैं सोया नहीं, फिर 5:45 बजे जयंत भाई को भी फोन किया कि किरीत को एक बार और बोल देना. तो So that was the kind of commitment we had. Next is Dr. Alpesh. Vijay no birthday खाते किशोर भाई प्लीज कम ऑन द स्टेज. कल आप नहीं आए उसका बहुत बहुत धन्यवाद. कल आप स्टेज पे नहीं चढ़े उसका बहुत बहुत धन्यवाद. और आप आज चढ़ सकते हो. Dr. Bhavin Dave, he also handled the scientific sessions very well. Kishore bhai, from Baroda to Baroda. And last but not least, Dr. Mehul Rehwar, he supported us from Bharuch like anything. 2-3 sponsors he has given, which helped us in organizing this in a grand way. Dr. Mehul. All the best to Dr. Mishra and Dr. Mehul for the next Gujcon 26. And now I'll request everyone to I will invite Dr. Kishore Parikh to just say a few words. Then we'll break for tea.
Good evening, everybody. I think everybody is hurried to go home. So I won't take much time, just 1 minute, 2 minutes. It was excellent show by Surat Iaoh's team. And credit goes to Dr. Subham Jain, Dr. Jain Patel, and entire team. So let us have big round of applause for them. This is one of the excellent conference what we have experienced in the terms of scientific session, foods, venue, and everything. Yesterday we enjoyed a lot the entertainment. So I think everybody, I haven't seen such kind of the energetic level, people dance, sing, everything. So it was wonderful conference. And again I congratulate Dr. Jain Patel, Dr. Subham, and entire team. And I wish best of luck to Ankleshwar Bharuch team for Gujcon 2026 next year. Thank you so much.
Thank you. We'll just have a group photo. Dr. Bijal, please come on stage. Balwant bhai, please, aa jaiye. Everyone, please come on stage. And thank you. We'll break for tea now. Aa jaiye. We'll have a group photo.